any kind of physical disease. We also know that chronic disease is inevitably associated with poor mental health. We know the mechanisms through which this can occur, through the impairment of immunity, through poor drug default, and adherence to follow-up and treatment. And finally, we know that the co-occurrence of these disorders can reduce the lifespan of an individual significantly. We also know the increased burden of non-communicable diseases in low and middle income countries, and that exposure to risk factors can both precipitate and worsen the outcome of NCDs. We are aware of the use of tobacco and alcohol, stress, physical inactivity, and lack of adequate diet, a healthy diet, which can all be precipitating factors. And these are preventable risk factors. We also know that poverty, as well as globalization, urbanization, and an aging population can all be risk factors for NCDs. However, when we come back to mental health and mental well-being, it's important to understand the basic constituents of good mental health. One talks about the affect, the cognition, and the conation, or simply put, one talks about one's emotional state, one's thinking, and one's behavior. Mental health is also the ability to handle stress well, to relate to others, as well as to make healthy choices. It's very important for productivity. It's important for personal reasons, for community reasons, as well as for occupational as well as societal well-being. We must also understand that just as in health, positive mental health, again, doesn't mean the absence of mental illness. And we look at what are the components of positive mental health and how we can inculcate it in our society. So traditionally, when you look at the way people understand prevention, if you look at the arrow beneath, we'll talk about the diagnosis of the mental health problem, which is in black. And then you talk about secondary and tertiary prevention, as well as disability limitation. And there again, good health, recovery, and effective self-management are important. And when we don't have active prevention, the chronic distress, as well as a poor outcome and even premature death are consequences. And therefore, you move up into the primary and the secondary prevention. Primary prevention, which looks at mental health promotion, as well as good health promotion in general, and secondary prevention in terms of reducing the risk factors that we talked about earlier. When you look at mental health in particular, you'll see that a whole lot of contexts, past, present, and perhaps even future, can affect a person's mental health. Therefore, for example, we now know through research that early adverse experiences, including trauma, witnessing violence, experiencing violence of any kind, including child abuse, sexual assaults as children, or even later in life, witnessing violence, as well as life events, can precipitate poor mental health and also precipitate illness. Experiences of mental conditions, medical conditions, as I mentioned, can also worsen a person's mental state. We know that as far as mental disorders are concerned, there are genetic risks for established mental disorders. We also know that stress can cause epigenetic changes and make people more vulnerable to mental disorders. Use of alcohol and drugs are well-known precipitants, and they also aggravate outcomes, both of mental as well as physical health. We also know that social isolation, displacement, migration, loss of jobs, what we are worried about post-COVID are also risk factors for mental illness. Pandemics, as exemplified by COVID, certainly increase the amount of mental distress and lower a sense of well-being in communities in general. The traditional approach, which looks at preventing the early onset of disease, prolonging the remission between episodes of disease, prevention of relapse, and of course, reducing the recurrence of a particular disorder, reducing the overall prevalence in the community, and looking at attempts to reduce or mitigate mental illness are somewhat traditionalist approaches and may not be enough to really promote mental health. The WHO therefore talks about improving mental health through integration of mental health mechanisms into the care and prevention of NCDs. We know that very often mental health conditions and NCDs co-occur. A person-centered management is very important, not just to mitigate mental distress, but also to mitigate physical distress and improve treatment outcomes. How can you deliver these? You can have them as person-centered healthcare interventions, as community-based approaches, or as population-wide interventions. And we look at mental health promotion in the context of these. It's important to understand a little bit about how mental illness can actually bring forward disease. So we know that, for example, life events can easily cause illness to occur much earlier than it might have otherwise. And again, immune responses to stress have been postulated as mechanisms for bringing forward illness. We also know that each of us have different emotional thermostats. Part of the personality that we develop is inherited, and part of it is a response to our environment. And therefore, we sometimes need to adjust these thermostats to be able to cope with diseases. We also need to learn how to build up resilience and cope with adversities, because good mental health does not mean just being in a happy state, but having the flexibility to deal with any kind of stress. We know that extreme forms of stress and absence of stress are both not very conducive to good mental health. So optimal stress and the ability to manage this is a hallmark of good resilience. We also know that we've used the life skills approach for adolescents, and those involve good communication, self-awareness, empathy, learning how to cope, learning how to be creative in your thinking, how to make decisions, how to solve problems, as well as managing interpersonal relationships are all very important. And the earlier we learn these things, some come innately, some come from families, some have to be learned. And when we do that, we're likely to be able to have effectively good mental health so that we can cope with any kind of adversity that we meet. The focus on well-being is not only for personal well-being, but also in the workplace, because we know that workplace mental health is very critical to workplace productivity, to good interpersonal relationships at the workplace, for greater social connectedness within the world of work and outside. And it's a very good buffering system against stress and improves resilience and so on. The area of positive psychology has taught us several things in terms of how it's important to have positive experiences and remember those positive experiences, have optimal experiences and processes. Now, subjective level, life satisfaction is something that's very important. Being in the flow or in the present and having a positive effect at the present time, and of course, being hopeful and optimistic about one's future are all very important for positive mental health. So, developing strengths, which include personal skills, attitudes, as well as qualities like courage, being able to forgive, having good interpersonal skills, being creative, being persistent with one's work, being kind, being compassionate, expressing gratitude are all very important skills that one can develop to be comfortable with oneself. And at the community level, these kind of individual values can permeate into the community, giving us certain social qualities which can develop optimal communities as well as institutions. So these are thoughts in positive psychology, which are very important factors which can determine how we are able to keep ourselves mentally fit. So it's not just about happiness or hedonism or having pleasurable feelings. It's also engaging with your environment, engaging with people that makes you a calm and satisfied individual. So building trust, building hope, and using our strengths. And as I mentioned in the previous slide, issues like gratitude, kindness, generosity, optimism, appreciation of nature and its beauty, like I showed you in the first slide, are all very important hallmarks of positive mental health. People also talk about flow experiences, which I mentioned, which is really the ability to concentrate and be absorbed in any activity at hand and nothing else that matters. So being in that particular zone, being intrinsically motivated are all very important in terms of having these peak experiences and being able to go with the flow. rather than be completely self-absorbed, which is something that we see in a lot of youth these days. We have a lot to offer in positive mental health from our own civilization and our own roots. As you know, Ayurveda also talks about mental distress as arising from the imbalances in the functioning of the mind, understanding, consciousness, perception, memory, intelligence, character, behavior, as well as conduct. And it's the Ayurveda concept focuses on balance between the mind, the body, as well as the soul, which is the extra dimension. And health is a result of a pure body, a happy soul, and a selfless mind. So the health regimens or the swastrit, the correct behavior or the sadvrit, and yoga are said to be the health regimens towards optimal mental health. All of you are aware of the Triguna concept, as well as the Tridosha, which is the imbalance of the humors, which can cause distress or illness. And of course, what is ideal behavior or the Achara Rasayana, which can help one develop this kind of attitude so that one is equanimous in one's self and is able to deal both with one's inner thoughts as well as with the outside world. And yoga is a perfect example where, you know, in the Bhagavad Gita, there is a lot of focus on how to make the mind equanimous. And there is this section in the chapter 2, which talks of performing action and being fixed in yoga, being able to deal with attachments and being even-minded in success and in failure, or in that sense, equilibrium, which is samatvam, which is actually what yoga is about. So the yoga approaches treat the body as a holistic entity. It recognizes that individuals are unique and their needs are unique. It enables self-empowerment and self-healing. And the quality and state of a person's state of mind influences that healing. And it recognizes that the regular practice of yoga promotes strength, endurance, flexibility. And again, as we talked about in the positive psychology of the, in the Western context, talks about the characteristics of friendliness, compassion, and self-control while cultivating a sense of calmness and well-being. So we all know the Patanjali's Ashtanga, which talks about yama, niyama, asana, pranayama, pratyahara, dharana, and dhyana, and finally the state of samadhi. So very often yoga is confined only to the asanas and the pranayama, but there is a whole lot in terms of the principles of yoga, which also talks about the discipline in daily life and what we talked about earlier, not just the state of the physical health and the mental health, but also in terms of a higher need and meditation, which are supposed to be important for the well-being of individuals. How do you achieve this kind of positive mental health? So the Gita, again, in chapter 6, talks about temperateness in eating, sleeping, working, and recreation, which can mitigate all material pains by practicing the yoga system. So whether you talk about the contemporary risk factors that I spoke about earlier, which is diet, exercise, dealing with stress, and so on, you'll see the same reverberations of what seem to be the important qualities or approaches to maintain good mental health in our society. Buddhism does the same. The Buddhism concept goes from the handling of suffering, recognizes suffering as an inevitable aspect of human life, and talks about how to deal with the suffering by emphasizing on the individual, on self-awareness, and on personal development. It talks about compassionate approaches and direct responses to human dilemmas that challenge or undermine the well-being of an individual, and it focuses on practice that improve contentment, resilience, as well as focus. You know that a lot of the mindfulness forms of treatments and meditation have largely emerged from the Buddhist philosophy. Some people will say that if you only take mindfulness, neglecting the other tenets of Buddhism, there can be adverse side effects of those approaches, but it is taken in the context of the other qualities of good mental health and well-being. Mindfulness can be a very powerful way of improving one's mental health and well-being. So we need to talk about mental health promotion in the context of disorder and distress, and we need to move beyond that. And therefore, there are huge opportunities to actually look not just at mitigating mental illness. Dr. Rajesh would have spoken to you about the huge burden of mental disorders. So certainly we have to do that. We have to reduce the treatment gap for mental disorders, make treatment, early treatment, follow up, and rehabilitation important. But at the same time, it's also very important to understand that there is a large community which needs to look after its mental health. And this is as important as looking after one's physical health. Sometimes people neglect their physical health as well. And therefore, looking at both in context becomes very, very important. And recognizing this along a developmental spectrum, how do you look after children? How do you look after pregnant mothers to make sure their mental health is well maintained? Young children, school-going children, adolescents, young adults, older adults, elderly, women, men. What are the mental health needs and how can you look after it? People in different kinds of settings. So what is that we can offer something for everyone across a different context, and what are the specific needs for different groups of people in terms of looking after their mental health is something that we need to look at. And the Health and Wellness Center started under the Ayushman Bharat are looking at some of these concepts in addition to early recognition of mental illness. And therefore, we need to be aware and see where we can actually have mental health promotion. In every setting, I believe there should be mental health promotion, whether it's at home, in schools, in institutions, in hospitals, we should be focusing on mental health promotion. And how do you inspire young minds to enhance positive mental health? It's about making wise life choices. It's understanding, feeling good, but not only focusing on hedonism. It is growing as an individual, developing the life skills that I mentioned earlier. These are all very important characteristics. We can also emphasize that mental health is not just the absence of disease. It's about enhancing fitness. It's a continuous attempt at improving one's state of mind, realizing one's potential, and giving one's best to life. And taking charge of one's mental well-being talks about reaching within and understanding oneself, polishing one's psychological skills in the three domains that I spoke about: emotions, thinking, as well as behavior, reaching out, being altruistic, but at the same time, being mutually supportive. These are very, very important for positive mental health. And therefore, we are moving from a deficient model of problems to be fixed to a positive model which looks at focusing strengths, developing talents and interests, from a top-down approach of teaching to a self-learned bottom-up approach, from an instructive modality to learning of it as an opportunity to learn new things and to strengthen oneself. And we also know that positive mental health and positive youth development is effective for overall growth, besides reducing problems which we've been focusing on usually. So it's very important to look at the context of mental health and well-being in a holistic manner, not just in terms of reducing stress, but also in terms of developing positive habits and goals, developing one's self-esteem, developing the resilience and capacity to be able to deal with stress and distress. Learning harmony and tolerance is another very, very important aspect of good mental health. Of course, physical health and mental health are very closely interlinked, and therefore physical health is as important as mental health. Mental health is a very, very good and strong contributor to the social fabric, and therefore it's very, very important. Academic engagement can be very important, but more importantly is a more practical engagement with the surrounding and happy relationships. Now, I know that this is a little unusual in terms of a talk which focuses on minimizing NCDs and looking at the risk for NCDs. But the whole world is understanding the importance of mental health and therefore moving away from the traditional construct of why mental health is important in terms of reducing risk and the consequence of disease, to actually understanding that it's very important for social capital, for societal well-being, as well as for the overall health of the society and the nation. I just wanted to say that several of my colleagues are doing work in this area of positive psychology and well-being in the community. Dr. Seema and Jyotsna are working on positive psychology and youth mental wellness. Dr. Shivrama and his team are using integrated medicine, yoga, and Ayurveda in promoting mental health. Dr. Pradeep and his team in epidemiology are looking at Spandana, which focuses on developing the overall health, including mental health of youth. There are various colleagues working with children who are doing school programs. We're working with women. We're working with the elderly in terms of promoting their mental health and well-being. And Dr. Naveen and his team are working in the community to not only look at the illness, but also the entire spectrum from well-being to illness. So I just hope that we will, in the next few years, be able to change our focus from looking at an individual only through an illness dimension, including for NCDs, and looking to see how positive mental health can not only improve the individual's resilience and immunity, but obviously recovery from illness as well. Thank you very much for a patient hearing.
Next, we will be having presentation by Dr. Rachita Gupta. She is a National Professional Officer, Nutrition in WHO Country Office of India. Ma'am is public health nutritionist with over a decade of experience. Ma'am, please join. You will be joining us online.
Good morning, everyone. I hope my screen is visible.
Yes, ma'am, your screen is visible.
Wonderful. So thank you so much for inviting me to this important meeting. And, I'm pretty glad. So just taking away from the previous discussion on mental health, my presentation would be focusing on addressing unhealthy diet and childhood obesity in India. What I would be covering in my presentation is basically on what specifically we need to do in terms of addressing dietary risk factors for NCDs, including healthy diet and obesity among children and adolescents. However, since I'm touching on the existing policies, which primarily focus on addressing undernutrition alone as of now, I would like to bring to your attention the double burden of malnutrition in India, which also includes under and overnutrition and remains much less addressed in the public health policies and programs in India. So I would be talking about what is the double burden of malnutrition, its extent in India, why it's important to address it, the economics involved in it, linkages to the global nutrition targets, SDGs, and the National Nutrition Mission, evidence-based to facilitate policy action in the country context. Are we doing enough in terms of policy and program actions? What are the drivers of double burden, and what are the actions we need to take to address it? And lastly, what are the priorities for India in this context? So undernutrition and overweight have historically been considered separate challenges affecting distinct populations and contrasting risk factors. While undernutrition was linked with poverty, food insecurity, and infection, obesity was linked with affluence, dietary richness, and sedentary behavior. However, this is not true anymore. Increasingly, what we are seeing is the two forms of malnutrition occur simultaneously within the same communities, families, and even individuals, such as, a child who is both stunted and overweight at the same time. And obesogenic environments are expanding while the causes of undernutrition persist. And hence, there's an increasing proportion of individuals now facing this double burden of malnutrition. The slide here shows how double burden of malnutrition has advanced rapidly in India. The graph on the left side shows that India had no DBM in 1990s, whereas by 2010s, this has not only made an appearance in the country, but has also increased rapidly, with more than 20% of the population being overweight or obese. Sorry for the small graph, but what we can see here is a trend in progression of DBM in India. As you can see, while we have made little progress in reducing wasting, stunting, and micronutrient deficiencies in the country over the last several years, An increasing proportion of our children are becoming overweight and obese. What is more worrying is that both forms of malnutrition are being seen in the same child, which is putting them to an increased risk of morbidity and premature mortality due to NCDs. This table here, it's from the latest CNNS survey of Ministry of Health and has data available on several metabolic risk factors for NCDs among children and adolescents. What we can see here is that a significant proportion of children and adolescents suffer from dyslipidemia and are already pre-diabetic, increasing their odds of suffering from NCDs related mortality later in life. The situation is no different among adults, as is evident from this data from 2 rounds of the NFHS survey. The proportion of adults who are overweight or obese has been increasing exponentially among both men and women, with both the groups reporting high prevalence of hypertension and diabetes. As per the Global Disease Burden Report, malnutrition and poor diet are the top 2 risk factors driving death and disability combined in India, and hence it's important for us to address this. So yes, this slide here compares the cost of undernutrition and diet-related NCDs from 1995 to 2025. What we note here is that while India's cost of undernutrition will continue to decline with India's rapid increase in diet-related diseases, similar economic costs of undernutrition and overnutrition have been projected by 2025. Hence, it's critical to address DBM in India. Also, if you look at the global commitments that India is part of, both the SDG 2 and SDG 3 on nutrition and health encompass addressing the double burden of malnutrition to achieve optimal health and nutrition. Even the global targets on nutrition include specific targets on not just indicators related to undernutrition, but also child obesity apart from addressing unhealthy diets. However, when you look at the country context, these global commitments are not fully reflected in the targets set under the Poshan Abhiyan, which only emphasizes to tackle undernutrition with no target to curb the rising burden of childhood obesity in the country, as I had mentioned earlier. The projected prevalence of child obesity in India is 17.5% in 2030, based on the trends up to 2017, which contrasts sharply with the WHO UNICEF 2030 target of less than 3%. Hence, if business remains as usual, India will not be in a position to achieve the global nutrition targets. And given that India is one of the major contributors of malnutrition globally, it's not just going to be a national but a global loss. Talking about progress towards achieving various nutritional outcomes, it is important to see where we stand with regards to various interventions to achieve optimal health and nutrition. And it's important to see interventions which are addressing both the forms of malnutrition. While India is implementing all the best practices, it is the coverage and quality of these interventions with large interstate differences in the delivery of these interventions, which is preventing us from achieving the desired outcomes. For example, if you see, while we have more than 60% of women who have 3+ ANCs, IFA coverage still remains low. Despite 80% institutional deliveries, your early initiation of breastfeeding remains low. And breastfeeding is as important a risk factor, poor breastfeeding for NCDs and overweight obesity as it is for undernutrition. It's important to understand that as well. Hence, it is important to, address these missed opportunities moving ahead. Also, we need to recognize that if implemented properly, package of existing interventions will be sufficient to address the double burden of malnutrition, and we don't need a new set of interventions per se. I'm sorry, I think the slide moved. Okay, coming on to the evidence base that we have for India on the sale of foods high in sugar, salt, and fat. Basically, as WHO India, we have been supporting Ministry of Health and Food Safety and Standards Authority of India in developing relevant programs and policies to address dietary risk factors for NCDs. And in order to do that, we've undertaken some research pieces. This is one of them, and I'll be presenting a couple of more of them. So the slide here shows the growth of ultra-processed food market in India based on analysis of market research data. What you see is that the ultra-processed food categories comprise of chocolate and sugar confectioneries, breakfast cereals, ready-made and convenience food, salty snacks, and beverages. So these are the main high consumption categories that we have selected for this particular analysis. And what you will see is that over a period of 2005 to 2019, the sector has grown by almost 70%. And within subcategories in 2019, while beverages had the maximum sales volume, chocolate and sugar confectionery had the highest retail sales value. And the trends have been similar, during the years from 15 to 19. So what's important to note is that all of these are foods which are high in sugar and fat, like beverages, all your Pepsi, Coke, and those are consumed in large quantities by children and pretty frequently, and hence are fueling the epidemic of childhood obesity. In terms of per capita retail sales over the 15-year period within the ultra-processed food sector, what we see here is that the per capita sales, which can be used as a surrogate of per capita consumption, since we don't have any consumption data from the latest NSSO survey, we use this as a surrogate. We witness a steep increase from 1.8 kgs in 2005 to 7 kgs in 2019 for beverages, while chocolate and sugar confectionery saw the steepest increase in terms of per capita retail sales value of $1.4 in 2005 to $9.5 in 2019. So this data is indicative of the upward trend in consumption of foods high in fat, sugar, and salt, which coupled with other metabolic and behavioral risk factors is fueling childhood obesity. We also took a study to assess the extent and power of marketing to children to understand how it is influencing their consumption, and the assessment was done across all platforms, social media, print media, and other forms as well. This is quite relevant in today's time when children are no longer watching just television, but spending most of the time in front of laptops, assessing, OTT platforms and social media sites. What we observed was that parents and children are enticed to consume foods high in sugar, salt, and fat, and these soft drinks using these different marketing strategies. And whatever investments that you make in behavior change communication from a government perspective, it's very difficult for you to match the investments that the private sector is making in terms of marketing their products. We've also been supporting Ministry of Health to provide inputs on syntax as part of the annual budget inputs, given the fact that sugar-sweetened beverages is one of the major concerns among children and adolescents. We studied the taxation structure on SSBs over a decade and how it has impacted its sale, again, taking that as a surrogate for consumption. What we observed here was there has been a steady increase in per capita sales of SSBs, sugar-sweetened beverages. The annual per capita consumption of carbonated soft drinks, all your fizzy drinks that we say, has increased from 1.8 liter per person to about 4.1 liter during 2007 to 2017. So just within a decade. Also, since juice-based drinks, which have a much less GST compared to the traditional carbonates, companies are introducing products in these categories to take advantage of the prevailing tax discrepancies, and also to take advantage of the view of consumers that these juices are supposed to be healthy, which is not true. It's the whole fruit which is healthy and not these processed products. The figure on the right shows the trends in the average retail price of different soft drink categories in India over the last 10 years. And surprisingly, the price, what you see, these prices are adjusted for inflation using the 2017 prices as base years. And what you see is that these prices have been consistently falling over the period, not increasing. The relative decline in real prices of SSVs has been 46% over the last 10 years, which clearly indicates that they have become more affordable over the years. We also modeled the tax regime needed to reduce consumption of SSVs in India. And with our own price elasticity of SSBs came close to about 1, which means that basically a 10% increase in the price of SSBs would in turn affect a 10% decrease in consumption. Okay, Coming to the policy landscape in India, as I mentioned to you earlier, India is committed to the global nutrition targets and the SDGs, both of which includes target on overweight and obesity. However, as I'd mentioned earlier as well, these global commitments are not getting reflected under the Poshan Abhiyan. While India is one of the first countries globally to develop a national action plan and monitoring framework for prevention and control of NCDs, I think this was discussed yesterday also by one of my colleagues. And it includes targets on halting the rise in diabetes and obesity. It's a comprehensive sort of strategic framework for dealing with all NCDs and their risk factors, including dietary risk factors and overweight and obesity. So it's important that we implement this properly and also we monitor its implementation. Coming on to diet-specific policies and regulations. So the Food Safety and Standards Authority of India, which is the apex food regulator in the country, they have been revising some of the key regulations with support from WHO to create consumer awareness and restrict availability and access to unhealthy foods. These includes regulation which prohibit advertisement of unhealthy foods, regulations which prohibit all forms of marketing and sale in and around schools, and a regulation which is being currently revised to include thresholds to define unhealthy foods, like an objective method to do that, and thereafter developing a hybrid warning label to sort of help consumers make informed food choices given the low literacy rates in the country. So once fully implemented mandatorily, India will have one of the strongest regulatory landscape globally. Apart from these, we also have the advertisement code of Ministry of Information and Broadcasting, which does not permit advertisement or promotion or of production, sale, and consumption of cigarettes, tobacco, alcohol, and other intoxicants. But it's important to note that it does not have any reference to unhealthy foods, which remains a gap. So this is a policy gap that needs to be addressed. Also, the Consumer Protection Act 2019 has provisions of penalties for misleading advertisements. However, the provision of penalizing endorsers of unhealthy foods, like a lot of cricketers and actors, they do that remains a weak component under this act as well. So the existing policy and regulatory landscape needs to be further enhanced to curb the rising burden of overweight and obesity in the country. We need to modify the existing rules and regulations of FSSAI and MOIB related to ads and claims to make them more stronger. We need to develop comprehensive regulations addressing all forms of marketing, including point of sale, toys and gifts that usually manufacturers provide in the packet itself. Effectively enforcing regulations develop. It's not just ending at development, but also enforcing and monitoring different regulations, including those on front of pack labeling and others. Discouraging promotion by use of children, celebrities, and licensed characters, restricting timing and volume of ads of unhealthy foods, and lastly, fiscal measures such as imposing higher taxes on unhealthy foods to reduce their affordability and thereby their consumption as well. Coming back to more of a health, not just health, but a systems or a settings-based approach to address, different forms of malnutrition. It's important to understand that the double burden of malnutrition, it has shared drivers with the same risk factors for both undernutrition and overnutrition. And hence the platforms to address all forms of malnutrition, the target audience, and the interventions all remain the same. Hence, we do not require any separate program or strategy to address overweight or obesity, but what we need is double duty actions to address the coexistence of the two in India. Actions, those which can have co-benefits. So some of the actions, that are needed to address DBM include in a health system based setting are, for example, supporting antenatal care and including counseling on healthy diets, promoting optimal breastfeeding, redesigning guidance on complementary feeding to enforce to mothers that they do not need to feed their child a calorie dense diet, which is just made up of carbs and sugars. Redesigning our growth monitoring programs, not just to flag children with undernutrition, but also overweight and obesity. In the education sector, we need to redesign our school feeding programs and devise new nutritional guidelines for food in and around educational institutions, which provide a more diverse diet. For the social safety net programs, we need to redesign our food transfer subsidies and vouchers to ensure that, you know, whatever food is being provided over there, that's a balanced diet and it's not just a carb-rich gruel. Then comes the food systems approach, where we need to scale up our agricultural programs that promote production and consumption of nutritious food, and also, you know, improve affordability of a balanced diet in order to tackle all forms of malnutrition. So it is important to define malnutrition as both undernutrition and overnutrition with the life cycle approach in a policy and program context in India. And it's important for you to keep the foot on the pedal and keep both undernutrition and micronutrient deficiencies under control, but at the same time, target childhood obesity. So from a health system setting, what I can say is you need to focus on improving early feeding practices. Sorry. Apart from that, you also need to increase physical activity, implement fiscal measures, labeling and marketing regulations, and eliminate artificial trans fats from food chain, and also reduce salt intake to curb obesities. I'll just end with that. Thank you so much.
Thank you, ma'am, for the wonderful presentation. Next, I will be requesting Dr. Thakur to join us.
Okay, so very good morning to all of you, and welcome to this second day. So we are going to discuss a very important concept of setting based approaches on health promotion. Since there is no previous lecture by Subhaji, if I just ask you, what do you mean by health promotion? Yes, anyone? Health promotion. Healthy behavior, yes. When we are in a training mode, you can speak anything. No problem. Right? Creating an enabling environment. For what? Lifestyle modification or other. What else? Encouraging for healthy habits. Yes. Healthy dietary practices. Promoting healthy lifestyle. Creating awareness regarding this. Right. What else? Lot of physical activity. Yes. Community participation. Advocacy for health. So many views on this, right? So it is very important to understand that what is health promotion. And health promotion is enabling people to take control of their health. When we say enabling Enabling means that empowering, right? So if I am saying that Dr. Sonali, take control of your health, she is to decide what to eat, when to eat, how much physical activity is to be done, right? So this is her sweet choice. You may give information that, okay, as far as diet is concerned, take 5 servings of fruits and vegetables. Take less than 5 grams of salt. Take this much of fat, right? Take lot of fiber. So you are giving the information, right? Same is true for physical activity. Indulge in at least 30 minutes of brisk physical activity and 130 minutes in a week. So you have provided her the information for anyone, and it is up to the individual or the communities to decide that how it is to be. It is my personal choice, but you are empowering them, right? So this, definition, understanding of this definition is very important. And in this, I will be discussing about what are the setting-based approaches, experience from different settings, workplace and community, and also touch something about health and wellness. Now, this we need to understand. Sometimes people think that health education and health promotion is the same thing. It is not, right? The health promotion is a more comprehensive concept, and health education is the part of it. And health education deals with more of behavior change. It could be a active or a passive process. But health promotion goes beyond healthy public policy. So health promotion is health education and healthy public policy. For example, if I want to control tobacco in National Capital Territory of Delhi, so it is not only that I should educate the people that tobacco is bad for health, it may lead to cancer and other things, it may not change the behavior of the people. How many people in this audience have made at least one person to quit smoking or taking tobacco? Raise their hands. Only 2 or 3. Please give them a big hand. My dear friends, if you can make even one person quit tobacco in your lifetime, that is achievement as a professional. It's not an easy task. Changing the behavior of the people is very difficult. So it is not only the health education which is important for tobacco in Delhi. It is the healthy public policy. Now, what is the policy for tobacco? Kotpa. So strict enforcement of the Kotpa in Delhi. So under Kotpa, you have certain warning which is to be given on the cigarette products, ban on the advertisements, right? Nobody can smoke in the public places. So when you go to any hospital, you find people smoking. डॉक्टर ही पीते हैं, लोगों की तो बात छोड़िए. Smoking rates among the doctors are very high. I will not one of हमारे एक तो फोरेंसिक के प्रोफेसर होते थे, वो इतनी सिगरेट पीते थे कि पूरा फ्लोर ही जो था धुएं से भरा होता. सो कहने का ये है कि लोग पीते हैं और हॉस्पिटल में भी पी रहे हैं बिकॉज इन्फोर्समेंट नहीं है. अब यदि मुझे देखना है कि ये हो रहा है तो कितने चलान किए पुलिस ने जो लोग सिगरेट पी रहे. At one stage in PGI, we raised anti-tobacco volunteer force. We have published this paper also. They are all unions of doctors, employees, Safai Karmachari. They were brought on one platform and told them, you will not smoke and you will not let the people smoke. So health promotion goes beyond health education, but covers healthy public policy. और जो सबसे बड़ी हमारी प्रॉब्लम आ रही is that we forget this. This is very important. Now, health promotion approaches, there are different approaches. Issue-based health promotion addresses specific issues, promotes healthy practices, for example, unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, injuries, unsafe sex, right? So this is issues. You take one issue and start working. And let me tell you here, changing behavior of the people is a very difficult process. You might have seen changing behavior of your husband or husband changing the behavior of the wife. So difficult. And where there are so many difficulties, people come up with many theories and models. That's why in behavior change, you have many theories and many models. Latest being this trans-theoretical model given by Prochaska. Means, I mean, anybody can give a theory. Theory is not a fact, but you can say that if we have to change a behavior, so where there is a confusion, you have many theories and many models, and same is true here. In behavior change, communication, again you have many. So lot of confusion is there, but as far as NCDs are concerned, we should be very clear. Population-based health promotion promotes health among the children, adolescents, women, elderly, workers, and other population. And life course approach is also one of the examples. These are some of the terminologies which are used, so we should be aware. Now, setting-based approaches in health promotion promote establishment of healthy settings such as healthy city, workplace, school, villages, islands, districts, markets, hospital. So setting is a specific place, right? And establishment. Now, a place or a social context where people engage in daily activities. If you are working, say, in a medical college, for you, the medical college is a setting. And if you are working in a department of community medicine, the department of community setting is a subset, right? A place where the people actively influence, use, and shape the environment can promote health by reaching people who work in them or using them to gain access to the services. So it is associated with promoting healthy settings. For example, we have a healthy city program of WHO, which is coordinated from Kobe in Japan. They have many cities which they have included, and Bangalore at some stage also participated in this. Now we have a smart city program in India. So this is an example of healthy city program, because health is also a component. Villages. One of our PhD student is now developing a model for health promoting villages, right, in Punjab. So village is a very important sector. Workplace. All of are working at some workplace. Some are working in medical colleges. Some are working in health services. Some are working as a student. Are our workplace healthy? Our, supervisors are more fond of creating stress, putting pressures, do this, right? So this workplace setting is very important. Schools, very important setting, a very defined environment. All of us have passed through this phase, and we have very fond memories of our school days, right? Community, we all know. Hospitals. Hospital, while I was in WHO, we we have a hospital, health promoting hospital program where we included this Safdarjung Hospital, SGPGI, Jipmer Pondicherry, and PGI Chandigarh to develop these hospitals as health promoting hospitals. What are the principles and perspective of health promotion in different settings? A holistic and a socio-ecological understanding of health, focus on population, policy, and environment, equity and social justice is very important. We have few lectures on this also. Sustainability, community participation, enablement and empowerment, cooperation, consensus, and mediation, advocacy. So all these principles are very important if we are working on a setting-based approach. Now, school-based approach. This is the school setting is one of the most important settings because all our habits are formed in our child, right? So why it is important? Reaching children easily, receptive age for behavior change, high impact on health and development, high evidence for prevention, very cost effective, essential improvement in water and sanitation, contributing to health equity, all children participate and benefit in the same. Globally, rising prevalence of childhood obesity. In India, we have on one side a problem of undernutrition, but this overweight and obesity is also increasing. The evidence is strong that such type of interventions are effective, and we have also some of the studies which are available. And all these problems, they require a multidisciplinary approach. The school setting has long been recommended as a health promoting environment. आप जिस भी स्कूल से पढ़े हो वहाँ कैसी environment? Nowadays there is no capital punishment. If I recollect my days, during my days this capital punishment was very common. Teacher डंडा लेके आते थे और वो पिटाई करते थे. जो क्लास का मॉनिटर होता था उसको अपने से भी बड़े बड़े बच्चों के मुंह में जब मार इसके थप्पड़ जाके एक लाइन में थप्पड़ लगाते थे. लगाए हुए हैं. आई मीन विद द डॉग आई फील कि हमने क्या किया. वो हमारे टाइम में कॉमन था. टीचर बहुत स्ट्रिक्ट हुआ करते थे. आजकल तो आप किसी के थप्पड़ लगाओ पेरेंट्स आ जाएंगे उसके और टीचर के ऊपर जो है केस भी हो सकता है. बट हमारे टाइम में ऐसा नहीं था. अब आई एम टॉकिंग अबाउट 70s. समय ये चीजें बहुत कॉमन थी. And there are also success stories, and Singapore is also one example where they have a trim and fit program. Now coming to the workplace setting, as I have discussed that all of us are working either in medical colleges or in health services or in NGO setting. So these settings are also very important, and there are some studies from India done by Confederation of Indian Industry. What we have found that our workplaces are very stressful in India because our bosses are, they create a lot of stress. Right? They are not taking it that way, and stress level is almost to the extent of 50%. And all NCDs, they are related with stress, right? Large number of working adults of varying socioeconomic status. We have different type of workplace setting. We are working in health services, but there are workers who are in the industries. So every industry, they have their own setting. Workplace intervention can have positive psychosocial and behavioral effect on NCD related risk factors, right? Because stress is related with diabetes, hypertension, and other lifestyle diseases. So the prevalence of these diseases are very high in our workplaces, which we will discuss later. And unfortunately, there are no organized program for workplace intervention in the city, except for few good industries. Tata, they have some program. We work with the Mahindra Group, they have some program, right? But there are many industries where you will not find any health promotion program. we also need to understand that what is the difference between the illness and the wellness. What is the difference? I and we, right? Means if we have to achieve health, we have to work with the population as a societal responsibility. Now, if we see these setting-based approaches, we have health promoting schools, health promoting workplaces, health promoting communities, and these are some of the things where we have worked in the past. We have a 12 and 20 week lifestyle intervention model. We have a accreditation system for health promoting schools. We were invited by the WHO and the Government of India to develop a healthy workplace model. And we have also developed a health promoting district model in Punjab and Haryana. So I will be sharing some of our experiences. In the 12 and 20 weeks lifestyle intervention model, 12 weeks means effectively spread over 3 months, and 20 weeks effectively spread over 5 months. Because any school, you have academic year, you have holidays also, you have exams also. So you cannot run these programs whole of the academic year. And what we found that in 12 weeks lifestyle intervention program, there was a change in the behavioral risk factors. We saw their behavior, we saw their physical measurement, we also saw the biochemical profile. So there was significant increase in the outdoor physical activity, reduced TBRs, and food consumption by the children. And when we raised it to 20 weeks, we found that there were certain changes in their physical measurement. Also, there was weight reduction also, waist circumference also reduced. So this was found. So it means that there were behavior changes as well as some physical changes, but no change in the biochemical profile, because this will not happen within a short period of time. You need a sustained program. Now, this is the accreditation system of schools as health promoting school, which was developed by us under the WHO Government of India collaborative program. We have developed our own standards, and there are 9 standards on different aspects like school health services, school nutrition services, school environment. Likewise, there are 9 domains, and on the basis of a checklist, we categorize the school into bronze, silver, gold, and platinum, right? And eventually, all these schools, all 206 schools in Chandigarh, they have been assessed and accredited under a ICMR project we undertaken. So these are 2 papers which has been published in International Journal on 12 and 20 weeks lifestyle intervention models, and this is being given in your folder as well, so you can read. Now, this is a accreditation program experience from Chandigarh in these 200 schools. When we started this program, it was a 3-year program. Almost 81% of the Chandigarh schools were below bronze, right? And after an intervention of 1 year, where it was a self-quality improvement program, but we found that only 13% schools were below bronze, and almost 85% were having different categories above bronze or above. And out of this, there were 2 schools which even achieved platinum status. It means that if we give opportunity to the schools, they can introduce health promotion program. And the second good thing which we observed, that the improvement was similar in private and the government. So it is not the only private school, but government schools, if they empower, they can deliver the good services. So recently we were invited by the CRO WHO to do the evaluation of the school health program in 11 countries of Southeast Asia, and also see this is the global standards for health promoting schools which has been introduced recently and which we did. And also during last year only, that is the regional committee of CRO, this report was accepted, and there is now a call for action for improving the school health program, which we designed, and that has been adopted by the 11th health minister of these countries. Coming to the healthy workplace model, there are three main domains promoting healthy practices: physical work environment and psychosocial work environment. There are core, expanded, and optional component in this. And in any workplace, there is a comprehensive assessment checklist and there is a rapid assessment checklist. If you are working in a medical college and you are working in a community medicine department, and if you want to check whether it is a healthy workplace or not, there are these comprehensive and rapid assessment checklists which are available, and you can assess that, and accordingly you can design your program. We have also developed a framework for healthy workplace program in the district setting, where you can work with the industry and implement such program. Now, this is the surveillance of risk factor in a workplace setting in Chandigarh. I'm just giving you an example. Consumed alcohol in last 1 month, 45%. Sedentary lifestyle, 32%. History of stress, 45%. These are among the workers. History of back pain, 30%. Overweight and obesity, 38%. Hypertension, 36%. So if you see the data from CII, in India, all risk factors are very high in our workplaces as compared to the general population. And this is the reflection of our workplaces, and it requires a lot of improvement. This is also published as a module which is with the WHO, and it is also published in Indian Journal of Occupational and Environment Health. And coming to the community setting, this was the health promoting district model which we developed in Punjab and Haryana, district Hoshiarpur and district Ambala of Haryana. The focus in this is integration, convergence within the different programs, multitasking by the health workers and the workforce, pooling of resources, and multi-sectoral participation, including the Panchayati Raj institution. And this is the example which I was giving, that the funding or the resource allocation for health promotion is almost negligible in our country, and it was only, you can see the 0.6% of budget in Punjab and 1.2% in Haryana. And out of this, 75% goes for advertisement with photograph of politicians, right? And 25% for printing. Nothing is available for any. And this is published. This is also called Hoshiarpur Ambala model, and this will be provided in your book. Now, just to touch upon this Ayushman Bharat, there are two main components: National Health Protection Scheme, which is not in our purview, but we have this Health and Wellness Center, where 150,000 sub-center in the country are being developed as health and wellness centers. There is a package of how many services? 12 services, right? And NCDs are also included. But in my opinion, this health promotion in different setting component is not there, right? So it needs a lot of improvement, but it is a good beginning, right? And some of the states are now also embarking on these health and wellness center PSCs. Sub-center PSCs are also included with the additional manpower. Recently, we started with a global health and wellness initiative with the Indian version. Hello, हंसो और हंसाओ, बढ़ो और बढ़ाओ. Now, it appears to be very lighter, but if you see, it includes everything of physical. Hello, lot of physical activity. It also include healthy diet. हम पहले इसमें खूब खाओ कहने लगे थे, पर खाते आप खूब हैं वैसे. So we decided इसमें खेलो ले, right? हंसो और हंसाओ. You have heard about mental health, positive attitude in life. नेगेटिविटी बहुत आ गई है, उसको कम करने के लिए बढ़ो और बढ़ाओ. बढ़ो और बढ़ाओ मीन्स खुद भी बढ़ो, लोगों को भी बढ़ने दो, एंड दिस इज मोर ऑफ ए मल्टी सेक्टोरल पार्टिसिपेशन. आप सभी मिलके जो है you should be doing. So this has health promotion in different settings, multi-sectoral actions, monitoring and evaluation. This is already published in 2 journals, and it is also a editorial. You can go into detail of this. And this was launched during last year by the mission director and additional secretary in the Ministry of Health, Mrs. Vandana Gurnani, on 2nd March, and it is now being undertaken in some of the districts in the country on pilot basis. If any one of you want to implement your to summarize, setting approaches, workplaces, communities should be promoted for health promotion. Strengthening of health system through a primary healthcare approach is a pragmatic step for universal health coverage, which is initiated by Health and Wellness Center under Ayushman Bharat. You know, we were talking about these 3 pillars: health promotion, surveillance, management. So unless we promote this health promotion in different settings, by doing so, what is the benefit? 70 to 80% of NCDs are prevented. But unfortunately, very little focus. I have written a paper in our Indian Journal of Community Medicine. Is the focus of prevention missing in Indian national health programs? So that time this Ayushman Bharat was not there. So we said yes. Now the government is giving emphasis on these health and wellness centers. Those who are program officer, is there any budget allocated for health and wellness centers separately under your budget? State program officers, is there any separate budget allocated for health and wellness center in your state? So this has happened. Initially what they did when it was started, it was just pooling of resources under the different. Am I right? And eventually in one of the meeting, I posed this question to Mr. Binod Paul, who is the member of Niti Aayog, that what proportion of budget you will be spending on this, health and wellness center out of the total Ayushman Bharat? Does not having answer. You need resources to implement any program, so this is very important. So more resources are required, and we really need to mainstreaming of health promotion and engage general public to mitigate the epidemic of health. And one thing which I would lastly emphasize, that health promotion include healthy public policy. And who makes the policies? Who makes the policies in the country? Bureaucracy and politicians. Unfortunately, we technical people are very poor communicator with these bureaucrats and politicians. I attend many meetings. स्टेट की मीटिंग में बैठे होंगे, वो सेक्रेटरी एमडी बोले जा रहा है, प्रिंसिपल सेक्रेटरी बोले जा रहा है, डायरेक्टर हेल्थ सर्विसेज जैसे बैठा हुआ है, हाँ जी हाँ जी हाँ जी. This is such a sad state of affair in our country. मुझे शर्म आती है कि you lose your right as a professional. आपका काम, you are a technical person, they cannot dictate the terms. हमने ये देखा कि जो हेल्थ सेक्रेटरी कोई 2 साल रह ले, जो ब्यूरोक्रेट 2 साल हेल्थ सेक्टर में रह ले, वो सोचता है कि वो डॉक्टर भी बन गया है कि नहीं? ये नहीं बनने देना है. You tell them that this is wrong, sir. It is up to you whether you want to implement or not. और ये मैंने जितना भी मैंने काम किया है, हमारे टेक्निकल लोग they are losing their importance. You have a very definite role to play in the advocacy, which somebody was saying, and also healthy public policy. Please discharge your responsibility. Don't be a mute spectator. Speak in the meetings. Make your presence felt. That is what is required. So with this, we stop here. Thank you very much. If there is any question, I will.
Thank you, sir. If there are any questions from the participants,
No question is in whose situation. There is a question.
Thank you, sir, for your very enigmatic presentation. So, just out of curiosity, the study which you did in the schools, you had gold, platinum, gold, and all. So, in our country, what so what about the sustainability of this endeavor that you put in? Did you have any kind of approach to follow it up? Like everything when it goes on in a project mode, sir, things are well planned, well attended. But after you completed your project, like I think it was published in 2015, uske baad sir kya hua? Like, do we
Yes,
have any
so
stories?
I understood your question. This is very good. We started with the 17 schools and then upscaled into entire union territory of Chandigarh. Chandigarh became the first state in the country where schools are accredited. You will find the certificate issued by us in the gates of the school. This school is accredited as platinum health as per health promoting school standards. They feel proud. You come from Bhubaneswar. There might be certain schools which are having big name and getting admission is very, very difficult. But are they really health promoting? They may not be. Right? So we have implemented this in Chandigarh as in a program mode, and now we are advocating at the national level. Thailand is another country which is doing this in whole of the country. These are the two countries where this program. Other countries, they have school health program, but not health promoting systematic program. Sri Lanka is also doing good because I have evaluated their, health and wellness program which they have, and I got the opportunity to evaluate this Badula district in Sri Lanka. Dr. Shanti is also there. You will also hear from something, but it can be. It is feasible, and we are working that it should be there in all of the country. And we are discussing this with the Quality Council of India, which has accreditation program for hospitals, labs.
So what did you have a kind of a follow up after schools were accredited by you? Did it kind of get a good spillage, and were the parents excited to put their students in those particular schools?
This is a research question, but
Yes,
this accreditation is valid for 3 years. So they have to go get their school reassessed. It takes 2 days for assessor team of 2 people to assess a school and declare their health promotion school status. Thank you very much.
thank you, sir. Next, I will like to request Dr. Shanti Mendes for the next session. Ma'am is Consultant Global Health, the Geneva Learning Foundation, Geneva, Switzerland. She is Fellow of Royal College of Physician, London, and she is also Fellow of American College of Cardiology. She was included in 2020 in top 2% researchers of the world. Ma'am, you can start.
Thank you very much. Can you hear me?
Yes.
Let me begin by thanking Professor Anand and Professor Thakur for inviting me, and also WHO for inviting me to speak in this very important course. And I would like to also congratulate them for taking it to the 7th round. Good morning to all of you. And it's very nice to speak to you this morning, joining you from Geneva. Let me try to share my slides with you. I hope it will. Can you see my slides? Hello.
No, ma'am.
How about now?
No, ma'am.
Okay, I seem to be having a technical issue here. Is it possible for you to project them from there? I have sent the slides earlier.
Yes, ma'am. Yes, we are trying.
Is it working?
Ma'am, we are just doing it.
So let me begin till the slides come on. This morning you have heard a lot about very interesting subjects: mental health, nutrition, health promotion, from eminent speakers. And I'm going to talk to you for about half an hour on evidence-based interventions for prevention and control of non-communicable diseases, including the best buys. But I will focus mainly on the best buys. First of all, introduce them, and then also tell you a little bit about their development and why and what and how they should be implemented and their importance. But because this is a training session, I see a lot of young people in the audience, and it would be very good if you want to interrupt me and ask questions at any time. I'll be very happy to respond. So, as you know a lot about non-communicable diseases, I'm sure. We need to understand the context in which we are addressing prevention and control of non-communicable diseases. They are not the only diseases, and we need to also focus on what else is happening in the health arena. You heard that there is a huge burden of mental health issues. And then we have other challenges which are evolving, like the pandemic, like climate change, poverty, lack of resources, all that is going around us and getting worse by the day, I would say. Here in Geneva, we are in spring and we have just experienced snow for the last couple of days, which is extremely unusual. And that's the same kind of thing which is happening everywhere else in the world. So with all these things going on around us, we also need to now focus on non-communicable diseases. As you know, when you say non-communicable diseases, we are talking about 40, 50, 60 different conditions. But you will hear most of the time in my presentation and in many other presentations about a few non-communicable diseases: cardiovascular disease, cancer, diabetes, chronic respiratory disease, a few diseases, and a few risk factors. And the reason for that is that these are the ones that we are focusing on. They have been prioritized because they share common risk factors. You know that. The common risk factors being the behavioral risk factors and air pollution that has been added to that. Are you able to get my slides?
No, ma'am, we are unable to display that. It's a PDF and it's closing.
Oh, really?
Uh,
Let me try again here then.
Ma'am, can you see? Oh, no.
Were you able to see? I have
No,
them
ma'am.
on this. I have them on the screen now. I'm sorry about this.
Ma'am, can you download the presentation or download the PDF and then share?
Sorry, what do you mean download the presentation?
Um, is it in the? It's in the mail. Then you can download and then share screen.
Can you do this, please? Can you show the audience the slides, and I will speak from here? Is that possible?
Do only the online participants won't be able to see. I will share the slides with the online participants and they can check on their own screen or on their own WhatsApp. Okay, so let's work that way then. The delegates who are there offline will be seeing the screen and the online candidates will share the slides and they can.
Okay, so have you now projected the slides?
Yes, ma'am, we have projected. Yeah. So, which slide do you want me to start with?
Yes, please go. Just go to the next one.
So, ma'am, it's being shared online, so you can now continue. Okay.
Can you move to the next slide? Okay, so let's hold it there. So as I said, I'm going to take you through when they were developed, what they are, why are they important, and how can they be implemented, and also why the uptake of best buys have been rather slow. Next, please. Next slide. So I explained this context to you in a little while ago, that when we talk about cardiovascular disease, strokes, cancer, diabetes, and the complications of diabetes, kidney disease, all these are NCDs, but there are many other NCDs, although we are focusing on these 4 major NCDs because they share the risk factors that you see: unhealthy diet, physical inactivity, tobacco use, harmful use of alcohol, and air pollution. And of course, then you would expect that the best buys, or the so-called very cost-effective interventions, are focusing on either these major risk factors or some of these major diseases. And don't forget that populations are aging everywhere in the world, and therefore, unlike communicable diseases, we are never going to be able to completely get rid of non-communicable diseases. So that's another big challenge that we have to face. And there is also a huge hereditary factor. Next slide, please. So just to give you a little bit about, a little bit of information about the history of development, you would have heard by now that we have had several UN high-level meetings related to NCDs, and the first one was in 2011. And it was at that time that we had this huge challenge of presenting to the heads of state and governments why it is important to focus on NCDs. Not only that, what can be done about NCDs? Because when we talk about NCDs, as you know, we are talking about, as I said, 40, 50 different diseases. So therefore, we had to come up with something attractive, which we can present to the politicians and policymakers and the decision makers who came to this UN high-level meeting. And therefore, that was the time when we started looking at cost effectiveness and interventions that can be implemented even in low and middle income countries. Later, these interventions got included in the Appendix 3 of the Global NCD Action Plan in 2013. And after that, they were updated and endorsed in 2017. And right now, they are being further updated. And some of you may know that the Global NCD Action Plan has also been extended to 2030. Next slide. So best buys simply are very cost-effective interventions which are feasible, scalable, and affordable to all countries. When we say cost-effective, there are various definitions, and one definition is that you save or you avert $100 when you spend $1 in low and middle income countries. And all of these interventions you will see when I start showing you what they are, that they are linked to the global NCD targets. Now, what are they? There are 9 global NCD targets. Some of them are on risk factors. Some of them are linked to these best buys. And there is also an overall overarching target on reducing premature mortality. Next slide, please. Okay, let's see what they are. You heard a lot about tobacco, and obviously there are best buys in tobacco related to increasing excise taxes, packaging, plain packaging, and placing warnings on packages, banning advertising of tobacco, eliminating exposure to secondhand tobacco smoke, and health education in health promotion programs that you heard Professor Thakur speak to. So you have there 5 best buys which can help all of the population if you implement. Next slide. Then you have also best buys related to Alcohol, somewhat similar. Increase excise taxes, ban advertising, enforce bans on exposure to alcohol, and also regulate availability of alcohol. Restrict physical availability of alcohol, sales outlets to have regulations. And when it comes to physical activity, health promotion, particularly mass media campaigns, were found to be very cost effective. And these are extremely important because you know that we have rising levels of obesity practically in every single country, including India. Next slide. Look at the diet. Diet is again very important in relation to preventing obesity, controlling obesity levels in children. And there, what is cost effective is reducing salt intake through reformulation of foods, creating supportive environments, that is, making available food which have reduced salt. And of course, these supportive environments can be used to support the intake of fruits and vegetables. And then you have mass media campaigns again, and reducing salt intake through the implementation of front pack labeling of food. So what you see is that when it comes to risk factors, tobacco, alcohol, physical activity, unhealthy diet, most of these best buys are related to legislation, regulation, and putting in place healthy public policies. And the advantage is that you will benefit all of the population. Children, adults, adolescents, the elderly, etc. Next slide. Now, when you look at best buys related to health systems, you find that there is actually very few. One that is very important is related to hypertension and diabetes. And you already heard that hypertension levels, diabetes levels, and other risk factor levels are very high in populations around the world and also in India. So this particular best buy related to drug therapy and counseling is all about reducing cardiovascular risk in the population. How? By using hypertension and diabetes as entry points and then assessing the cardiovascular risk and treating accordingly. I will explain this further when I use it as an example of how to implement a health service best buy. And you will note that this is the only best buy for health systems. And these days, when we are talking about universal health coverage, this best buy has got to be included in basic benefit packages if you want to move forward in controlling NCDs. Then we have two best buys related to cancer, cervical cancer. Vaccination against human papillomavirus is one, and screening for prevention of cervical cancer by screening women aged 30 to 49 years through various methods, which we won't go into. And there's a lot of work going on related to this. Perhaps you know, Dr. Cherian Varghese and others are working on this, and there is also a global initiative. Next slide, please. Now, why should we focus on best buys? We need to focus on best buys because there is a return on investment which is very attractive, because at the end of the day, resources matter a lot. They matter a lot to all countries, but particularly for low and middle income countries. We all know that. And resources are very limited. And so if you look at the investment of $1 across these different best buys that I spoke about, related to tobacco, you saw several best buys. And if you were to invest $1, the return will be almost 7 times. In relation to salt, if you invest $1 in the best buys, you get a return of 12, and so on. You can see that every single best buy intervention, there is a very good return. And this is a very important issue related to best buys that you have to understand, because the money for health comes from the Ministry of Finance, and ministries of finance, they understand return on investment. It's very difficult to convince them to just give money only for interventions that are very costly. They want to see return on his investment, and this is the language that they understand and identify with. Next slide. But you need to also recognize and appreciate that prevention as well as treatment, they have a cost, and they have to be implemented over a long period of time. And in this particular study that WHO did modeling the return on investment, they have done it over a period of 2018 to 2030. If you were to invest in best buys, what would be the return? You can see that in order to begin, scale it up, and then involve the whole population, you will need almost 7-8 years to get the return. So prevention has a cost, treatment has a cost, but of course, prevention interventions that are within the best buy list, they are very much more cost effective than treatment interventions, as you would expect, because drugs are costly. Next slide. And it is also important to recognize when we talk about health, what is the return in this implementation of the best buys. Not only do we save lives, as you can see over the years, almost 8.2 million lives can be saved. There is also prevention of heart attacks and strokes. And you will reduce also premature death in people between 30 and 70 years. And there's also then generation of contribution to economic output, because you are saving lives, then there are more people in the workplace, less sickness, and there is also therefore gain for the economy. And economic development therefore will be helped by investing in best buys. So there's a return on investment by 2030 if we were to implement all of these best buys. And that is to the tune of $350 billion in this modeling exercise that WHO did in 2018. In other words, if you were to invest in all these best buys that I showed over the period of several years, by 2030, there will be a cost, but there will also be a return on that investment of $350 billion. Next slide. So you might be asking yourself now, why do you need to focus on affordability and sustainability? Is it necessary? If you look at the per capita spending on health of different countries, high income countries spend to the tune of about $5,000 per capita on health. But if you look at upper middle income countries, it is around 500. Low middle income, $80. Low income, $40. So you see, low and middle income countries cannot expect to implement programs like the way high-income countries do. Just to give you one example, in high-income countries, you find that sometimes they have successful single risk factor programs like hypertension programs, just focusing on hypertension. But low and middle income countries cannot afford to do that because we don't spend that much of money on health. And if we were to then start single risk factor programs, they will not be sustainable because you know that in NCDs, when you treat people, in most cases, you need to continue treatment lifelong. So that's going to be costly. It's not like malaria where you give treatment for a few days. And therefore, it is very important to think of sustainability and affordability. And that is why best buys are indispensable for NCD prevention and control in all countries, but particularly in low and middle income countries where resources are very limited and where there are competing priorities. Next slide. Next slide, please. Okay, so where are we today? We are looking at the Sustainable Development Goal 3.4, which everybody is speaking about. That is to reduce premature mortality by 1/3 by 2030. And a recent assessment done showed very clearly that only 14 countries out of 194 WHO member states are on track to achieve these targets. So the premature mortality target cannot be attained by the rest of the countries unless they change the way they are addressing non-communicable diseases. And there are no countries, in fact, which are on track to achieve the 9 global NCD targets. As I said, there are 9 global NCD targets, and many countries have set also their national targets in alignment with the global targets, but no countries are on track to achieve these targets, which are to be attained by 2025. Then we speak about universal health coverage a lot. But the WHO Global Monitoring Report clearly shows that very little change has happened in terms of integrating NCD services into these UHC programs in countries, particularly in low and middle income countries. Next slide. So I want to talk a little bit about the health service best buy, which I said was focusing on hypertension and diabetes together in an integrated fashion with a lot of focus in primary care. Why is it important? A person who has multiple risk factors, even if each factor is only moderately elevated, is at an overall higher risk than someone with an elevated single risk factor. So if you have, for example, mild hypertension, we take the cutoff as 140/90, look at a person who has blood pressure of 150/100, we categorize the person as hypertensive. This patient will have a higher risk if he's a smoker, if he's a male, if he's obese, if he has a family history. So multiple risk factors occur more commonly than just a single risk factor. And that is very common in the population. I think there was a previous presentation that you saw. This is very evident. A lot of people have elevated cardiovascular risk. So targeting treatment at people who have high risk leads to greater benefit in terms of number of events avoided, because we have to always think of the outcome. How many strokes and heart attacks are we avoiding? Not only to talk about, are we controlling blood pressure? We need to go beyond that because we have to be focused on the outcomes. Next slide. When you take the population and look at the cardiovascular risk, I'm sorry, I didn't have time to update it for India, but if you look at these other Southeast Asian countries, it is similar, India also. Cardiovascular risk, when you look at the population distribution, the very high risk shown here in red, you have a small percentage of people, but you have also people with medium risk here shown in yellow. And altogether, the high and medium risk would be about 25%. And then the rest of them, they have mild or low risk. And when resources are limited, we need to have a way how we focus on the medium and high risk people, because they are the ones who will develop heart attacks and strokes in the near future. Next slide. And so WHO has the WHO PEN package, the WHO HEARTS package, the cardiovascular risk charts, which enable countries to use this best buy in health services. Next slide. Recently, the risk charts were updated and they are much more accurate, the new charts compared to the previous charts. And they are also easy to use. Of course, you need to train the doctors in primary healthcare particularly. Next slide. So here is an example of a risk chart which uses age, systolic blood pressure, male, female, smoking, non-smoking, and of course, cholesterol levels, and whether you are diabetic or not when you want to determine the risk. But the new set of charts also have charts which do not use cholesterol, but use BMI instead. So both these sets of charts are available for use. Next slide. And this gives you the reasons why a total risk approach using risk prediction charts and this particular best buy is very much better for control of hypertension and diabetes in primary healthcare, particularly in low and middle income countries. I won't go through all of these. They motivate patients. They help you to target people at higher risk. They help you to integrate risk factors. We were talking about mental health, obesity, all these health promotion in the morning. We need to integrate, not just focus on single risk factors in primary care. Next slide. There are many reasons why the uptake of best buys is not so good. One is the commercial pressure to promote tobacco, alcohol, and obesogenic food. Again, you heard a lot about this in the morning. And in addition, industry also tends to promote single risk factor programs, even in primary care. Even guidelines are just focused on single risk factors. You need to move away from this and focus on an integrated approach. That's very important if you want to use the best buys. And we, of course, need political commitment. Next slide. So for implementation of these best buys, you need to integrate them into the universal health coverage programs and make sure that in primary care, you use integrated approaches, particularly to address hypertension and diabetes. At tertiary care levels, you can have your specialized single disease programs and they are required. Next slide. So I'd like to end here by saying that in order to attain the SDG target that everybody is talking about, reducing premature mortality by 1/3 by 2030, you need to use best buys to reduce risk factor levels, and you need to use the best buys in the health system, particularly at the primary care level, through universal health coverage programs to address risk factors and risk factor situations and status of people in a much more efficient and effective way, particularly a sustainable and affordable way. So thank you very much for your attention. This particular document has been circulated, so I hope that you'll be able to read more about other cost-effective interventions. The best buys are not the only cost-effective interventions, but they are indeed the most cost effective. So they should get priority. Thank you very much.
Thank you, Shanti, for taking all participants through the whole process of identifying best buys and listing them out. Thank you for joining from Geneva. Maybe too early for you than us. Thank you. And any
Thank
questions for Dr. Shanti Mendes? Yeah. You have a question, Shanti, just hold on.
Sure.
Ma'am, when we talk about banning the advertisement, like every company comes up with surrogate advertisement. So how do other countries are dealing with it? Every company has surrogate advertisement in some way or another way.
Yes, this is a very important question that all of you will have to grapple with if you are getting into NCD prevention and control. And in fact, the situation is getting worse practically in all countries because, you know, the amount of resources that the commercial factor has, it is many fold more than what the ministries of health have in order to promote healthy behaviors through health promotion programs. So, you know, unless you have regulations and legislation banning advertisements related to selling of unhealthy food to children and beverages to children particularly, it's going to be extremely difficult to counteract the commercial pressure. And the solution is in legislation and regulation, I believe, you know, and also fiscal measures, you know, price increases of these unhealthy products. But it's a very important question and a question that everybody is trying to grapple with in all countries.
Thank you, ma'am. We will be moving for a mobility break now.
Okay,
Online-
thank you very much for your attention and for the opportunity to speak to you. Thank you, Professor Anand and Professor Thakur and WHO.
Thank you, Shanti.
Participants and good morning. I will be now presenting on building multi-sector actions for addressing public health challenges. Although it will sound to you more kind of a theoretical because the real actions and the examples will be coming in the subsequent presentations which will be done by Dr. Anand and other speakers. So please ask questions if you find any difficulty in between, and I will be happy to answer. So the outline of the presentation is basically covering 4 areas. First, making you understand what is the difference between multi-sectoral and intersectoral form of cooperation. What is the rationale or framework for establishing this kind of multi-sectoral mechanisms, and if are there any examples, international or national, and what can be the challenges and barriers. So by the end of this presentation, you will be able to understand the multi-sectoral rules of NCDs, which you have gained some insights in the earlier presentations, and understand the mechanisms which are available to promote the multi-sectoral approach for NCDs. So the fundamental difference between the multi-sectoral and intersectoral, because this terminology is used interchangeably. So multi-sectoral is usually we define when it is between the government or between the government sectors, which is we call as an alternative whole of the government approach. So it's between the government. And when we talk about the intersector cooperation, it goes beyond the government sectors and also include other stakeholders, primarily the civil society organizations, private sectors, and the community itself. Why it is needed, and this has been emphasized repeatedly, that the health cannot do the actions alone, and that is being reflected in the international documents, and as I was sharing with you last day also, that in the UN high-level document resolutions, and you can see the number of times the intersectoral and multisectoral words have been used. So this signifies how much important it is to, if you want to have a proper NCD response. This is the cost of action versus cost of inaction. And this is mainly at the global level. So if we don't do anything in the middle and low income countries for NCDs, the loss will be around 7 trillion. And for the actions which Shanti Mendes was mentioning, the cost of action is just 170 billion. So you can see the huge gap between the cost of actions versus inaction. So why it is required? What is the rationale for intersectoral approach? First, it modifies the social and economic determinants of behavior, which the JS policy was mentioning. So it influences how people eat, how they drink, how they move. And moreover, important, when we do this kind of approach, it creates an enabling environment and maintain this behavioral change in the communities and individuals. When it maintains the behavior change, it has intergenerational benefits. And when it creates an enabling environment, it not only addresses one risk factors, but it has potential to address multiple risk factors at one time. And more important, the results are cost effective and can be achieved in the shorter time frame. This is something which we say for the whole of government approach or social, how to address the social determinants approach. And this is usually which we also have seen in our public health books and other things. So I will not go into the details, but more importantly is that the health and equity governance and accountability mechanism is there when we are creating synergies across the sectors. So what are the guiding principle for implement multi-sectoral mechanism? And most of you are from the states as well as from the districts, and you have seen this kind of coordinations earlier. So first and foremost is that we have to establish the need and priorities, why this multi-sectoral and intersectoral actions are required. And once these priorities have been established, we have to identify what kind of actions can be needed for this multi-sectoral actions. Then we have to look for supportive structure and process which is available at that particular level, if it is at the state level or at the national level. And then once the structure and process have been identified, what would be the mechanism for his assessment and engagement? That has to be also identified when we are devising the multi-sectoral mechanisms, and see for every programs or actions, if there is no accountability mechanisms or reporting mechanisms, we can't assess the progress which has been done for that. And more importantly, after all identifying these actions and supportive structure, and we have identified whom to address, we have to build the capacity for implementing the multi-sectoral actions. So these are the stepping stones which we have to use when we want to establish the coordination. First, we have to identify who will lead these actions, whether it would be Ministry of Health, or it would be the Planning Commission, or it would be at the higher level beyond the Planning Commission and this one. So identifying the lead agency should be depend on who has a high influence on the policy, equity and health outcomes. That will define the lead agencies. Then once we have identified the lead agencies, because to initiate the discussions with the sectors or multi-sector corporations, we have to generate evidence whether what we are proposing has any impact on the policies and programs. After that, when we have the sufficient evidence, then the policy dialogue starts with the partners, and collectively we develop what will be the shared goals and how it will be we are achieving those goals and the outcomes, and accordingly the multi-sectoral actions start implementing. There are different ways of and platforms available. At the national level, it may be at the highest level of authority, at the PM level, or at the cabinet secretary level, or at the National Planning Commission. There is National Planning Commission. There are parliamentary committees, so that can also be part of multi. There are national steering committees. There are interdepartmental committees, working groups, and task force. So there are different kinds of forums that can be explored for this one. At the subnational level, we have local assemblies committees, chief secretary committees. Like national level, there are interdepartmental committees, and more important, there are certain community governance structure which can be also explored for the multi-sectoral things. And multi-sectoral can be, it should not be like entire health are addressed in one go. There are other also, if they are established committees, like there is already an intersectoral, multi-sectoral task force in the health that can be also utilized for NCDs. If there is a committee established for sustainable development goals or tobacco control, or for any other program, HIV/AIDS, or for the universal health coverage, climate change. So we have to look for the avenues where we can put those issues for the right addressers. So this is a decision-making matrix. That is the 4th step, which is being taken from the Health in All Policy manual. I have quoted in my reading material, so you can go through it. So it gives you how to make a decisions. Once you have prioritized those actions, then you have to identify this, answer these 4 questions. What role and position does the individual play in that department? What it is his reach, what would be the particular interest, what will be the goal, and are this goal in agreement with the common goals or not. And then you identify the stakeholders and their resources, and then you identify how the resources will be mobilized, because both human and the financial resources will be required to implement the multi-sectoral mechanism. Beyond the resources, there is a capacity and skills which is required at the sector level, and we have to understand, because one of the important component which I mentioned was capacity building. So whether they have capacity to understand the politics and its context, what the actions which we are proposing, what is the commercial drive is behind that, and they whether they understand how it is going to impact the health outcomes, and as well as the community, how it will influence the community. That is very important. So the skills which are required is to, because there may be convergent sectors, there may be divergent sectors. Like if you are talking about alcohol and tobacco industry, or ultra processed food industries, there will be a vested interest. So you have to manage those wicked problems and complexity when you are talking about the multi-sector actions. And you have to promote the new mindset on the health promotion. So that kind of skills like advocacy, mediator, or enabler kind of things is required. And that we have to understand before we initiate any kind of multi-sector mechanism, and accordingly the capacities and skills need to be built. This is something, the status in the Southeast Asia region countries, of the 11 countries in as of 2018, and you will see most of this, the National Multi-Sectoral NCD Governance Committee has been established in, and by 2020 it is being established in almost all countries. And the nature of leadership is basically the health minister, which is leading that. And there are incidents of regular as well as irregular meetings happening at the country level. In India, if you see, it has been established in 2018, and it's being governed by the executive lead, which is cabinet secretary, and the discussions is issue based with the convergent as well as the divergent sectors. I will just give you kind of mechanisms which has been envisaged in the National Multi-Sector Action Plan. So in the middle, it is interministerial committee, which is chaired by the Secretary Health and Family Welfare. Here, all the sectors comes and discuss about the action, and the actions which are not being addressed at this level is being referred to the Standing Committee of Secretaries, which is chaired by the secretaries. And the interministerial committee also refer to the health promotion mechanisms, which are the a kind of a task force which has been established, and most of the civil society organizations, UN agencies, and other stakeholders provide their inputs in the this group. And there is a supporting mechanism at the central NCD divisions, and also central NCD division also is in link with the closely with the state government. So that is something envisaged. We have achieved the interministerial committee and the technical advisory group, but there are certain areas which are still to be established under the National Multi-Sector Action Plan. Giving you an example of Thai Health Foundation. So there is at the highest level, there is a Prime Minister who is the chair, and then there is a Minister of Public Health and independent experts. And there is a representation from a lot of departments, including independent subject experts. So they have a sustainable funding also, which what I was mentioning, that the resources are required when you are going to have a kind of a multi-sectoral mechanisms. So they, whatever the 2% surcharge which is levied on alcohol and tobacco as an excise tax is used for Thai Health Foundations, and it not only addresses the tobacco, alcohol, but also a large area of other health issues which are related to NCDs, whether it is road safety, health promotion, community engagement, healthy media plan. So that is something which they have done, and it shows that how if anybody wants to act or coordinate with the multi-sector mechanisms, how the sustainable financings and the issues can be addressed. So just as to a summary, when you go to your state and the respective areas, just look for the windows of opportunities. If there are certain areas which are required to implement the best buys, what are the windows of opportunities available there, and start from low hanging fruit which is easily available, and gradually build on the convergence sectors. So there is need to build partnership and the trust. Generate win-win benefit. Like if you don't speak to the language of other sectors, it's difficult to make them understand. And that's what we have also found when we are doing the capacity building of the states at the subnational level. We have to speak in their language. What is, if we are implementing the action, what is the benefit for them in this one? Then most important things which I have mentioned, there should be a transparency and accountability process should be there, and a process to monitor the impacts. And once we have this kind of things, we can move beyond the public sectors to also include other sector. Taking example as a case study from tobacco control, this is a classical example of multi-sectoral coordinations, and it's not happened overnight or in a year. It is a long journey, and excuse me. So it has achieved a lot of results. Some of the key achievements I have mentioned, the COTPA Act and its amendment. There is a prohibition bill for electronic cigarettes, which was very, I can say that very important regulatory measures to protect the youth. Then the taxation measures, large pictorial warnings covering 85%, tobacco-free schools and institutions, anti-tobacco advertisements in the films, and alternative livelihoods for BD rollers. These are the key achievements which they have achieved by working with the other sectors. And they have established a kind of a coordination committee at all the three levels, at the national, state and district level. At the national level, there is a parliamentary committee, and COTPA implementation interministerial committee is there. And at the district level, it is being chaired by the district collectorate, and all the relevant 12 departments join this meeting for the enforcement of COTPA as well as the awareness generation for tobacco prevention. So what are the major challenges? First and foremost is we need a strong political commitment and partnership. And its partnership should not be at the national level. It should percolate also to the subnational level. So it's not only at the national level, but between the national and subnational level, that kind of coordination is required. Sometimes when we earlier what we have done is that there were 35 ministries and departments were identified, but when you have this kind of large coordinating bodies there, it's difficult to handle those changes. So if there are issues, we can discuss on the issue based things. So these are the challenges. Sectoral alignment and asking for the budget for resources from the other sector is kind of a bigger challenge on an agreement on the performance indicators. That is quite difficult when we are defining the multi-sectoral. And because I have mentioned there are vested interests, so difficulties in engaging industries and private sector. Skills definitely, and more important, the resources, the sustainable funding. There are certain barriers for the multi-sectoral actions. First is there is lack of awareness. Sector doesn't know whatever actions they are taking, whether there is a harm to it. So there is a lack of awareness. Even if there is an awareness being generated, the interest is not there. How does it concern to me? It is not my job. Then comes the territorial issues. Like when we are saying that you have to do these actions, suppose to the education or to agriculture, then they say that who are you to tell me? Then when it comes to the resources, who will be under control of the financials thing? And then there is a lack of coordinations. Like sometimes that's what I was saying, the lead agency identification is the most important. Who is in the charge? That concludes my presentation today. So we have to, in summary, what I would say that we have to first identify the mechanism when we are going to establish a multi-sectoral or intersectoral platform at the state level or district level. We have to identify a mechanism. What is the mechanism available? What will be the process which you will imply to implement those actions, whether it will be cooperations, coordination, partnership, and what kind of right tool you will be using to implement those actions. So these are the reading materials which are available. You can go through it. You will identify most of other things also into that in this reading materials. And that concludes the presentation. Thank you so much. Thank you.
Thank you, sir, for your presentation. If there are any questions.
Morning, Lakshar. Intersectoral funding and pooling funds from the other sector. I think 15th Finance Commission has given an opportunity in this because in Telangana, under urban component of 15th Finance, they have given about 25 crores, wherein we are building up our Basti Davakhanas. In the tribal sector, tribal ministry has given them some funding in the health component, which we are utilizing for our diagnostic purpose. I think this is addressed in 15th Finance Commission grants.
Thank you so much for sharing. And I just want to also bring to your attention that COVID has bring a unique situation where the health sector has been bring at the center of the table. So when we are going to implement those multi-sector action, we can utilize this opportunity because now other sectors are listening to it. And when this COVID kind of committees were established at the state level or at the district level, all kind of sectors were being represented. and that can be continued, that can be further leveraged when we want to address the NCD actions. And going further to your point, it should not be only on the health system strengthening like the drugs availability or the diagnostics. What we want to say in the earlier presentation by Dr. Shanti is how to implement those best by interventions. That should be our thinking behind. Over.
Thank you, sir. Are there any more questions? Online participants can add their question in the chat box also. Oh, as there are no questions, we will be moving to the next session by Dr. Anand, sir.
When we set it up, I will be discussing on what are the different multi-sectoral tools available for us. For a long time, we have been discussing multi-sectoral, but generally nobody knows what is multi-sectoral. There is a lot of confusion. So I'm trying to simplify. There are some things that Dr. Pradeep Joshi focused on. He focused more on mechanisms in the sense that there should be a committee, there should be all those things are also important, obviously. I'm going to focus on tools or instruments, right? So basically, tools or instrument is a means that governments can use in markets or in society to accomplish certain specific things. Obviously, in this context, we are looking at reducing risk factors. That's the main thing that we are looking at. Tobacco, alcohol, diet, physical activity. What are the instruments available to the governments, whether state or center, that they can use to reduce risk due to these 4 major risk factors? And how do governments can choose between them? Basically, all instruments are to nudge people towards a purpose of the whole issue of health promotion. Don't necessarily reduce the choices, nudge people to make healthier choices, right? Purpose. We are not necessarily reducing choices. And over a period of time, if there is not many takers for an unhealthy choice, it will automatically die. Right? You don't have to ban it. It will automatically die because there are not enough people to. Market forces will take care of it. So generally, these instruments can be, for simpler reason, can be called as sticks, carrots, or sermons. Simply put, either use a stick, which is largely law, regulation, and those kind of thing, or carrot, give incentives for people to change, or sermons, which is sort of education, or bhashan, whatever you want to call it. Right? These are generally 3 ways that you can governments can change behavior. If you look at actual instruments, we say there are 4 kinds of instruments. Anything you want to say will fall into one of these 4 categories, and we can, if you want to discuss, we can discuss which. So there are 2 what we call as a hard measures or regulatory measures, which are physical measures and regulatory measures, and 2 soft measures, which are information and structural measures. We'll take each of them and I will give you examples. So there are only 4 broad categories of instruments that can be used by governments to change behavior. There is no other possibility. Anything you say will fall in one of these 4 categories. So we'll start with fiscal measures. Right? Physical measure means 2 kinds of things: taxes or some sort of subsidies or incentives. These are the 3 ways that physically we can change behavior, right? So they use monetary techniques, tax, fees, cess, and incentivize healthy foods and disincentivize non-healthy foods. For example, tax on unhealthy foods, tax on cold drinks, tax on cigarettes, tax on alcohol. They all are fiscal measures so that we want to reduce the unhealthy behavior. Can you give me an example of an incentive? May not necessarily be the NCDs. As I said, this is generic. Any health issue you talk of, this would be applicable. We are talking in the context of NCDs, but these are very generic tools. Can you give me an example of financial incentives to change behavior that we have used in this country? Excellent. Institutional delivery is a very good tool. There we have used financial incentives, all direct benefit transfer, tuberculosis completion. Sorry? Yeah, that is an incentive to ASHA, not for patients. Right? So that is not a behavior in that sense. That's more of a work incentive rather than a behavior incentive. But yes, so financial incentives are part of that, right? Very often, these should not, our primary aim should not be to generate revenue. This generate revenue, obviously, if we impose tax, that is going to some revenue generation. But our primary aim should not that we will have more money at that time, right? For example, in Nepal, tobacco tax is used to run a cancer hospital. Right? That's the main funding for running a cancer hospital, which is very logical. But if tobacco goes down, your cancer hospital will have to shut down, isn't it? So you are actually working to harm yourself, right? Because you are using that as your source to generate money. If you are successful, which you should, that is your own aim, right? Your aim is to reduce tobacco. Then there will be no funding for that cancer hospital. And there are a lot of cancers, not only tobacco which causes cancer. So one has to be careful when we uses these kind of things, not to be too dependent on the money generated by this to fund your core program. You can fund some additional program, that is not a problem, but not your core program. So it also gives you examples like cash transfers, cash grants, subsidies, taxes. Okay, one thing to keep in mind when we talk of fiscal measures is something which is called as a inelasticity or plasticity of fiscal measure. Fiscal measure is not a uniform measure. It does not affect everybody. Does tax affect everybody equally? No. Richer people can pay much better. They don't have a problem. Tax. Most of these fiscal are extremely price sensitive, right? Which is a good thing as well as a bad thing. So you have to know the product which you are going to tax. How price elastic is that product? For example, cigarette is highly elastic, especially for the poor people. You even increasing 10% tax, it is going to affect them for poorer people. But for richer people, you increase it by 1 rupee, 2 rupees, it hardly makes any difference. Right? They are inelastic to change of price. Fruits and vegetable is highly price elastic, right? So fiscal is also a good measure to promote equity, because it will target poorer people more. And if the as we discussed yesterday, and we have still not had time to, many of the NCDs are increasing in poorer people. Tobacco use is higher in poorer people. So you want a tool which does not hit everybody across the board in the same way. You want to hit some specific people, especially poor people. Then fiscal measures are good for it, right? Yesterday, I think somebody made, Atre said, young people are also, again, if you are interested in young people are generally less, they don't have that much of money with them. So if you are interested in getting more effect on younger people for tobacco, alcohol, tax is again a good thing, because they are more price elastic. They will be affected by the change in the price. It also depends on how much tax you write. Right? If you make the raise in tax very small, it will have no impact on anybody. So there is no right answer how much you should increase. So you have to keep all this in mind when you are applying a fiscal measure. It is just not raise the tax. You have to understand your community, your population. You have to understand obviously your fiscal constraints, and then take a decision on what and how much of fiscal measure should. Right? Sometimes some small tax. The question is also whether the manufacturer will pass on that tax to the consumer. Manufacturers, if there is a profit margin, they know their product is price sensitive. They will not pass that increase in price to the consumer. then your taxes, except revenue generation, it does not really help your cause, right? Which we don't want that. As I said, our primary purpose is not revenue generation. So one has to be careful about these things. If it is high enough, then the manufacturer will not compromise their profit. They will probably push it more to the consumer side, right? Or at least partially shift to the consumer side. So these are complex issues which as doctors we are generally not, we don't deal with it, we don't understand these kind of issues. But if you want to push for multi-sectoral actions, you have to have that kind of understanding. Then only you can engage with finance people, for example, right? If you want to convince a finance ministry on these tools, then you have to have this kind of background to talk to them. So maybe, so again, as I said, what type of tax? I know with the people who are familiar with cigarette tax, will tell you whether it is by volume, whether more the volume, more this cigarette is also was by the size of the cigarette, at least initially. Bigger cigarettes were taxed more, smaller cigarettes were taxed less, and those kind of things. A lot tax can have a lot of complexities involved. It is not just raise the tax. If you understand your product well, you can adjust your tax for your specific purposes, right? For example, BDs are not, that's a paradox in India. BDs are not that well taxed in India, but BDs is used by poor people. So taxing BD would make more sense for equity than taxing cigarettes. But we don't tax BDs. We increase tax on cigarettes. So it's a sort of a not well deliberately. Again, none of this occurs without design, and we'll come about it later on. So you have to be clear what is it that you want. If you really want to affect poor people, just for your sake, just to give some context, you know, our Pranab Mukherjee used to be the finance minister. He used to come from Murshidabad. That was his constituency. Murshidabad is the BD manufacturing hub of India. So he refused to increase tax. During his time he was finance minister. He said, I will not increase tax on BDs because it would affect his political survival, because his constituency was the biggest BD makers in India. So a lot of kind of these things occur when we discuss these kind of issues. Okay, so just to give you some examples of whether they work. One example, obviously in tobacco, we know it works, but even in diet and physical activity. So on the left side, you can see fruits and vegetables, and the fiscal measure here is subsidy. You subsidize fruits and vegetables, right? And as you can see, if you see this minus 30 means there is higher subsidy. So higher the subsidy, more is the consumption of the fruits and vegetables. Lower subsidy, 0 means no subsidy. There is, right? Look at the opposite side, which is on carbonated soft drinks. So this is tax. This is not subsidy. More the tax, which is on that side, lesser is the consumption. Obviously, there will be exemptions. There is this kind of relationships. Policy interventions relationships are not like biological relationships. They are much more complex relationships. So as you can see, for tobacco also, it has been shown to be effective. And also, we also, as I said, other non-NCDs, conditional cash transfers for NCD care, like somebody said, for completion of treatment, health insurance. And also we discussed yesterday, somebody discussed on price control mechanisms, right? Controlling anti-cancer drugs, for example, or anti-insulin costs are also part of fiscal measures where you put a ceiling on it. So if you look at globally, how countries are using fiscal measures for alcohol, tobacco, and diet. As you can see, lots of countries are using, obviously tobacco and alcohol strategies are almost similar. There is, in terms of principles that we apply for whether you do for tobacco or for alcohol, the larger principles for both remain the same, right? And those are the two ones. Obviously, tobacco takes the lead in use of fiscal measures, tax. Much less, as you look at foods high in salt, fat, sugar, and salt, you can see that is not much used across the globe. Using tax to reduce high food or salt containing. But sugar sweetened beverages like colas and other things, that is happening in many more countries, but not so much on the other chips and those kind of products. This is on subsidies and incentives. The opposite side, again, not much used in diet. We are not using too much of subsidies to promote diet or physical activity. Somehow, see, less than 20% of countries are doing it. So that is about physical measures. Now we go to regulatory measures by passing a law, by prohibiting something and those kind of things. So there are three kinds of laws. One is obviously the most important is the parliament passes the law. That's the best one. Second is a local government or even a DC can pass an order and that can also be treated as a law. And third is obviously by judgment. Many of these things have come from, for example, banning of junk foods in schools have come from a Supreme Court judgment. They have not come from a law. Parliament has not passed a law, but Supreme Court has passed a judgment on it. So many of these laws can be made in Parliament, maybe a judicial intervention or an intervention at a much lower level, a more of an administrative order rather than a legal order. All three are valid tools for legal. Many of the COVID-related measures were actually administrative orders. They were not legal in the sense that they were not passed by law, by Parliament or judicial. Right? Most of the COVID instructions were administrative orders. Okay, laws can be used to create rights, obviously right to care, right for cancer patients to get care or what those kind of things. Impose obligation and penalties on parties concerned and establish mechanisms for its implementation. Again, it can be used to promote equity, improve coverage, protect citizens from harm. For example, in tobacco, we use law to protect citizens from tobacco-related harms. Ensure accountability by setting up institutional mechanisms for it. Also, one of you asked this question on, I think you asked this question on commercial determinants of surrogate advertising. As Shanti said, the only way to address surrogate advertising is through a proper law, a law which addresses it. So again, you have to keep updating your laws. This is what happens in any industry. Industry keeps thinking of ways to circumvent your law. You make a law, industry studies it and finds a way to circumvent it. You update your law, they will further go. So this is a race which will keep happening. It is not a one-time measure. These measures are not one-time measures. You have to revisit them every few years and modify as per that time's need. Right? So obviously, tobacco has the highest use of by banning smoking in public places and regulatory advertising and those kind of things. That we are not allowed to advertise, you are not allowed to sponsor events. Those all are regulatory measures to control. And as you can see, the stronger the ban, more is the impact on the smoking prevalence. Many countries, so again, it is a legislative call, how comprehensive your tobacco laws are going to be. India is among the best, most comprehensive, but you could pass a law against tobacco, but make it very weak so that it will not be, so you have a law, but actually it does not work. That's the, depends on the provisions of the law, how strong you make it. So the other thing which is often advocated even by WHO is ban on advertising food products and beverages to children. They are not banning advertisement of beverages and these food high energy food products. So you cannot advertise in the channels which children see, or you cannot advertise before 9 p.m. or whatever is that country's appropriate time where children are expected to go to school. India, I don't know what that time is, but so you have to define what products, you have to define what media channels, what time frames. They cannot advertise in it. They'll have to look at, you know, in India today, this is one of the biggest problems, right? Right from childhood, all children recognize Maggie, colas. The whole marketing is driven to children. They are not marketing to adults. There is no advertisement of these products which are targeted at adults. They all are targeted to children. And in most homes in India, children decide whether to. If they say मेरे को चाहिए, parents after some time they accept defeat. And मतलब इसमें बच्चों की गलती नहीं है. Parents भी है 6 महीने के बच्चे को कोला पिलाते हैं. सब लोग पिलाते हैं. मतलब I'm not most of और अब तो ये भी शुरू हो गया कि I have seen almost all newborn children being shown a screen time. कुछ खिलाना है तो उसको हाथ पे मोबाइल दे दो, फिर खिला सकते हैं आराम से. बच्चा कुछ भी मुंह में डालोगे खा लेगा. So there are a lot of these kind of things which we need to look, but those are different issues. But many countries have banned this. It is not, India has not banned it. There has been some movement on this, but we have not made much progress on this. Obviously, commercial determinants are an important consideration. There will be heavy resistance to do this kind of a thing. Many countries have banned it, and they have shown that it reduces. And obviously, childhood obesity, you heard Rachita talk about it earlier. So these are important. Perhaps the single most important tool, multi-sectoral tool available for us for child obesity is this. This is what we should be doing. So go back, many of your state program officers, go back, talk to, start from some states can start. Jaruri nahi hai ki central government has to take the lead, no? Health is a state subject. Why not do it in the states? The other counterpart to this is that why not allow industry to self-regulate? Why should government regulate? So invariably it has been seen that self-regulation does not work. Self-regulation is largely seen as a ploy by the industry to have control within themselves. Self-regulation means we regulate ourselves. You don't do anything. Government do not do anything. We will regulate ourselves. So we have to be dependent on the industry's benevolence or this thing that we will do things right. Unfortunately, in private sector, most often it does not work. Right. So, but it is something. It's a good thing to start off while we debate the larger regulation. But it is something that we could start off and learn from it, and as a first step towards proper regulation, not as the end in itself. For example, codes of conduct for advertising baby food. These all are self-regulation. Many of them have come up as a self-regulation, right? You can obviously go ahead and have then an external regulation also to do it. So if you look at globally, how many people are using, how many countries are using, again, marketing and beverages, you can see almost voluntary, which is largely what I say is self-advertising. Voluntary regulation means it is self-regulation. Mandatory means an external regulation. As you can see, we have in children, at least one of them either is almost 70%. India has neither voluntary nor mandatory. But Europe has one of the strongest this thing, and I even give you examples like France, UK, they all are doing pretty well on it. Obviously, Africa has still not reached many of these issues because NCDs is being recognized as a problem in a much later time frame than the other countries. The other thing that in that we have done better is the trans fat issue, where regulation has been, even in India, there is a regulation on trans fat. So that's is doing much better. Where we don't want trans fat to be in the food supply chain. Okay, so those were the legal intervention. Now we come to structural intervention. This is the most difficult to do and most difficult to understand. Where we change the environment, as you say, health promotion. You create an environment where people are ready to healthy. Obviously, fiscal and regulatory are there. The best examples are urban planning and bylaws. This is the best example is on physical activity, and I will take you park and green spaces, pavement. Also, one of the major reasons why fruits and vegetables are cost higher in India is that there is very poor transportation and storage mechanism. Almost 50% of our fruits and vegetables are lost just in transit. Sad jate hain. Because they are perishable goods. You cannot keep food. We don't have very good cold storage. This thing. They have improved in last couple of 1 or 2 decades, but still we are far short of what we need. If we can store those fruits and vegetables, their rates will come down drastically. So, for example, I keep harping on how many of you do physical activity. So why do we choose physical activity? Again, one of the things that you have to understand in health promotion is we don't blame people. Everybody wants to be healthy. Everybody wants to eat fruits and vegetables. Everybody wants to do physical activity. It is not that people don't want. It is just that there is not enough environment to convert that wish into an action. Right? Intent say implementation may we lose because there are more barriers than facilitators in that process. For example, if there is a good environment here, you would walk. यदि ये हम आपको सिटी के बीच में एक बिजी थोरोफेयर के बीच में डाल देते, आप थोड़ी देर वॉकिंग पे जाते, आप नहीं जाते. Nothing. You are the same person in both the situations, but just change the context. You will do walking in one. So if we need to improve walking, we need to change. We need to have more parks. They have to be well kept. They have to be safe for women. They have to be well lighted. Just building parks is not going to be enough. So these kind of interventions are also important. You can see in many parts of Delhi and many other states also. We have now open gyms where people can go. They are just there in a park. You just put up an open. There are good ways to promote physicality. And I can see in many parts of where I would, lot of people utilize those kind of open gyms. And across the socioeconomic spectrum, both anybody comes from nearby village or such thing, and they also started using it. So more and more those kind of interventions will also lead to more and more. So we need these kind of interventions also. These are, as I said, much more difficult to clearly quantify. And obviously air pollution is almost entirely structural. Obviously there is some physical, for example, use of vehicles or petrol ka tax padao, or entire depends on how good your public transport system is. Unless you invest on a very good public transport system, which disincentivizes use of personal vehicles, there is no way we are going to address air pollution. It will never happen. And we are years away from having an excellent public transport system. So invest these are structural, means you have to invest in infrastructure. They are much bigger investment, long-term investments. They are not short. They will not bring up any impact in a short term. Right? So those kind of interventions are also important to promote health. And finally is information or sermon. आप लोगों को बोलिए, people will change their behavior. Right? So awareness campaigns, including labeling and warning, is an informational. Like in tobacco, you label, or nutritional labeling. These are, you provide information to the consumer. Consumer will take a call to take the appropriate behavior. Right? So this is more on providing information to the consumers. Again, studies have shown that providing it is one of the weaker. That's why this is called as a soft. Just providing information in the absence of other three interventions will not make too much of a change. They all have to work together. None of these will work well alone. Right? They all will work better if they are in a package, and we'll discuss about package subsequently. So I'm sure we discussed about nutritional labeling. We just conducted a study. Everybody looks at nutritional labeling only to look at exposure date. Nobody in most of the general population, they don't really look at usme kitna salt hai, ya sugar hai, calories hai. Salt was actually not required in India till some time back. Salt was outside the nutrition labeling. If you look at all of them, none of them would have sodium as a part of it. Now we have recently introduced sodium also to be part of the package essential labeling. So only for that, consumer has to educate. They have to understand what is sugar, what is calorie, what is sodium. Otherwise, there is no point in putting it there. So in a situation like us, where consumers are more illiterate, less educated, this is a challenge of labeling. How to make it consumer friendly? So we use some simpler, like red, green, color coded, and those kind of a thing. So they are proxies for nutrition labeling to make it simpler for people with less information to still do something about it. So again, as you can see, that obviously and front of packet labeling, where there is a lot of discussion currently occurring in India on front of packet labeling of food products. So gradually it is increasing. Okay, I will have to finish now because the next speaker wants to start in 5 minutes. He has to leave. So ultimately we have to, all these have to put into a package. That package depends on the government's policies and preferences. Some want more liberal, why government should not regulate. There are some political people like US as a generic rule. They said government should not regulate. Let laissez-faire be there. Let people choose. Let them. Some governments believe strongly in government level interventions. So ideology plays an important. These are political choices. These are not just technical choices, right? Increasing tax is a political decision. It is not a technical decision. So you cannot do this without getting people and politicians involved in it. And in any such decision, somebody will lose. Maybe often the industry will lose, and they are going to push back on these kind of things. They are not going to keep quiet. So you will need a lot of, we will need to understand these issues, and then when we talk to policymakers, we should be in a much better position to talk to them. So this will skip. This is almost the best buys that Shanti talked about. For example, Empower is a package. It has all. It has information. It has tax. It has legislation. Right. It does not have too much of structural, because tobacco, it is not that relevant. But tobacco, it will be more of replacing farmers. Those kind of interventions are structural. So Empower is a sort of a mix of all these kinds of interventions. We can use the same for others also, right? So this tells you that there are multiple interventions which we can discuss with governments if you want to address NCDs. Each have their own advantages, disadvantages. The ultimate choice depends on the government's priorities and policies. We should be able to engage with them in the language that they understand. We don't understand the taxation language, but if you want to engage with finance ministry, we will have to learn. They are not going to learn. They are happy, comfortable in theirs. If we want to engage with them, we need to learn their language, how they deal with taxes, right, and talk to them. So thank you. If there are any questions, I am ready to take. Just hold on, because the next speaker wants to go. You can, if you can keep your questions. Dr. Jimon will take a class on. He is taking online on live course.
Sir, it is okay. You can take the question, sir. I'll be
Thank
here.
you, Jimon. Okay, go ahead.
Sir, if revenue generation is not the primary motive of the government, then what are the challenges in sanctioning the laws that target the tobacco at the level of production? Because there are laws targeting the place of smoking and the age criteria, but why there are no laws targeting the tobacco at the level of production?
See, the whole question comes down to whether if tobacco is a legitimate product allowed by countries, then production is also legal. There is nothing illegal in it, isn't it? Unless we make tobacco product itself illegal. If it is a legal product, companies can make it. Or there is, you cannot stop them from producing it, manufacturing it, marketing it. You can only lay down some restrictions to it. But see, ultimately, if you do any intervention at the production level, they will just transfer that to the consumer level. Their profit margins are huge. It will make a very minute impact on the company itself if you do something at the production level.
Then again, the bottom line is like the primary motive is income generation.
The primary motive is to get consumers not to take tobacco. That is our primary motive, not generate money. But just to tell you, as you know, alcohol, one of the main reason why alcohol prohibition is not taken, as you see in Bihar, in Kerala, almost 25% of the revenue used to come from alcohol. So when Kerala prohibited, and maybe Jimon will say more on this, alcohol, their total revenue came down drastically. They had less money to spend on anything. So often this, even though as I said, it should not be primary consideration, very often these are good, important sources of revenues for the countries. Bihar is struggling with its finances because its big share of revenue generation from alcohol has gone down. So it is from government's point of view, it is an important. When we advocate, it is not important from us, but from government's point of view, therefore prohibition is not. You will say increase tax on alcohol, they will be happy to do it because it also increases their this thing. But you say prohibition, they will not be happy. So.
Long term, isn't the government saving on investment on the health, like long term?
So that is the argument that we use when we talk to them, that this is the cost of, I think he showed you, I think either yesterday Atre showed or today Pradeep showed, cost of alcohol. So that's how we say that this is the cost of alcohol in terms of illnesses it costs. That was one of the major arguments for tobacco. There were a lot of cost of illness studies on tobacco. This is the impact of tobacco. We use this, we save this much money, which is, so that's the argument, financial argument. But remember, long-term financial arguments are not very effective with politicians because they are only interested in next 5 years. their time span invariably for decision making is next 3 to 5 years. No politicians thinks I will do something which will be useful 20 years down my time. Nobody, they will not think like that. There's no point in blaming them. Their survival depends on this. So we have to revise our argument to cater to their needs. There's no point in crying they don't think long term. Right? That's how their cycle works. Right? Okay, thank you. We can have more this discussion because I'm going to be here. So, Jimon, now over to you.
Thank you, sir. Let me try to share my screen. Can you see my screen?
Sir.
Is it visible?
Yes, sir, it is visible.
Right. Thank you very much for inviting me to.
Sir, you just have to full screen it, zoomed out. Sir, you should use the slide show mode.
Can you see it?
No, sir, it's still zoomed out. Just use the slideshow mode, it will be okay then.
So I am actually using the slideshow. I actually resumed the slideshow. Are you able to see it now?
Okay, sir.
Can you see it now?
Yes,
no.
sir.
We can't see it fully even now.
Sir, you have shared another screen, sir. You have to. Sir, you have to share another screen where the slideshow is there. Now it is visible, sir.
Is it visible?
Yes, sir.
Oh, thank you very much. Right. So thank you very much for inviting for me to talk about life course approach, operationalizing life course approach for prevention and control of non-communicable diseases. Thank you very much, Professor Anand, for involving me. Next 20 minutes or so, I'll be largely talking about the life course of.
Hello, sorry, sir, to interrupt. Can you go to the 3 dots? Because we are seeing your presenter view. Yeah. So hide presenter view. Yes.
So can you see it now?
Oh no. Now the screen is sharing is gone.
I don't.
Yeah, now can you do the slide? Yeah, now it's perfect, sir. Thank you so much.
So apologies for that technical issues. Thank you very much for involving me. I'm going to talk about operationalizing life course approach for prevention and control of non-communicable diseases. My talk probably will talk a little bit about the concepts around the life course approach. The previous speakers, Professor Shanti Mendis, Dr. Joshi, and Professor Anand made my life much easier. Dr. Mendis talked about the best buy options, how it is important for us to implement the best buy options. Dr. Joshi talked about the whole of government approach and whole of societal approach to achieve these strategies implemented and make sure that it is effective at the population level. And Dr. Anand talked about the importance of policy in terms of the way that he described it as sticks, carrots, and sermons. But the life course approach would be much easier if we can implement all of these across the life course. So in terms of non-communicable disease prevention, we know that it is most effective when we target it at the root causes, at its roots. So therefore, what is important is to take early, appropriate, timely, and collective action, which is very important if we were to reduce the premature mortality from non-communicable diseases. You're all going to die at one stage because of some conditions. And most of us probably will die from non-communicable diseases, but we are not really worried if that is beyond a certain threshold age limit. What we are really worried is about the premature mortality attributable to non-communicable disease. And we are thinking about reducing it by 1/3 by 2030, which is a sustainable development goal, which has been already described by the other speakers. So what is this life course approach to? The life course approach, ideally, it should be an inclusive approach that considers the needs of all age groups and addresses non-communicable disease prevention in its early stages. It should ideally, therefore, provide a comprehensive and sustainable framework to introduce key interventions. Most of these interventions have been already discussed as part of the previous talk, but we will cover some of the important issues around the description of life course approach. So let me take you and tell you that although this life course approach has been discussed widely in different settings, and mostly in high income country settings, they were able to adopt it to a certain level. But let me tell you that this is even more important in our settings, low income settings and middle income settings. Because in low income settings, it is associated with a poor start in terms of the inherited health capacity. So in this slide, the red line, where it starts, that is the inherited health capital for low income countries. And we know that there is a difference in health capital inherited from the previous generation between the low income and high income countries. We start at a lower level. The functional capacity then develops, but it develops very slowly in a low income settings, and it reaches a lower peak capacity earlier in the life course as compared to the high income country settings. And throughout the life, the environmental changes to this function, the environmental challenges to the function are likely to be greater in the low income settings, and therefore it leads to a faster and earlier decline as compared to the high income settings. You probably are also seeing the dotted lines. What it says is that if there is an acute event, say for example, like a myocardial infarction or a stroke, somewhere in the life course, it affects severely for people who are living in the low income countries or low and middle income countries as compared to the high income countries. The effect of acute challenge to health is relatively lower in high income settings. They recover much better or pretty fast as compared to the low income country settings. So the provision of personal care further, it improves, especially in the high income settings. It can slow the rate of the decline, and therefore it can sustain the resilience in a manner that is similar to what we call plasticity. And therefore, people from the high income countries, they start at a better position. They gain certain functional capacity over the life course. Because of the environment that they are exposed to, it is in a better environment. So what are we trying to do in a life course model is trying to whether we can modify this environment and make it in a better place for us to live. So let me also talk a little bit more details about this the theory of the whole of life approach. So if you actually look at in mammals, there are two major programming periods where the epigenome is erased and then re-established. They are gametogenesis and embryo-fetal development, which can be divided largely into three stages: the gametogenesis and embryo-fetal development. These stages are very important. These stages provide a window of opportunity for us to intervene. And therefore, so far we have been talking about whole of government approach or whole of societal approach. And then now I am introducing a new concept of introducing an integrated approach. When I say integrated approach, when we talk about non-communicable disease prevention or control, we cannot only focus on the non-communicable disease programs that are existing either by the government of the central government or the federal government. We need to also think about what are the other programs that are being run by these governments or agencies, and how we can potentially think about non-communicable disease prevention in those programs as well. Say, for example, our reproductive and child health program. There are a lot of components that we could add to the reproductive and child health program where we can ensure that there is a potential for prevention of non-communicable diseases in the women and in their offsprings. Therefore, over time, what we need to achieve is that to reduce the risk exposure at different stages and look at the different windows of vulnerability and address those windows of vulnerability at the right point in time. And if you look at the whole scenario, the chronic diseases in the intergenerationally, I mean, we are, our mothers, there are some risk associated with, the non-communicable disease associated with them because what they have inherited previously, or because of the environmental exposure that they had, and therefore their offsprings will go through two different strategies, two different trajectories, health trajectories. One we call it as a high-risk strategy, high-risk trajectory, and the other one is a low-risk trajectory. If you are continuing in low-risk trajectory throughout your life course, in the infancy stage, in the adolescent stage, and adulthood stage, it is good. And you come back to the next generation as healthy mother, and you would have probably healthy offsprings as well. But if you are going through that high-risk strategy, where there is a risk associated at the birth itself, either in terms of low birth weight or excess weight, and then you have this high-risk strategy, which is been throughout the other stages as well, infancy and childhood and adolescent period, and then adulthood. And then come back to the, I'll say, women in the reproductive age group as a mother, and you pass that risk to the offsprings as well. So this high-risk strategy is kind of a visual cycle which continues throughout the generation. That is very important for us to understand. And then what is this evolution of health trajectories? Now, if you look at this figure, the life course and health development mode, this figure actually describes the evolution of health trajectories under the influence of macro and micro level factors. The left side of the figure, if you look at it, the left side of it reflects the various factors at the individual, community, and macro social level. Sometimes we call it as exposomes. And this impact the health trajectories over time. There is no doubt about it. All of you are aware about it. But if you look at the right side of the figure, which displays how health trajectories evolve over the life course. So that is very important. The health trajectories evolve based on the interaction of the individual's genetic and epigenetic background with the exposome. So that is very important. These interactions are very important, and interactions happens at different stages or different critical window periods, like in utero, in infancy, in childhood, early childhood, middle age, and advanced stage. And those who are following the ideal life course, which is the green line that you see, they have less, they have been utilizing the window of opportunities rather than the window of vulnerability. So they consider it as a window of opportunity, and they have been exposed to the ideal optimal conditions. So if we could provide that ideal optimal conditions throughout the stages of our life course, we would be probably able to achieve what we would like to achieve at the end of it in terms of non-communicable disease prevention. The life course health development edifies, therefore, assimilates the notion of both the biological and social embedding during the critical or the sensitive time windows that evolves or that unfolds the health that occurs because of aggregated influences. So this is very important for us to understand that this is important to address at different stages in life. So there is a MINS declaration, WHO declaration on the life course approach in the context of health in 2020. And this approach, they're saying that there are diverse inequality health trajectories of health are strongly influenced by policies, environment, opportunities, and norms created by the societal, which the society bears certain responsibility, and the government also bears certain responsibility. And therefore, we are talking about the whole of government and whole of societal approach. And whatever be that approach, what we recommend is to act early. Act early, even in the reproductive and child health program, even in the adolescent health program, even in the school health program, we need to act early. And we need to act appropriately during the life transition process according for the window of opportunity and window of vulnerability. and we need to act together. We cannot act it separately as a division of non-communicable diseases. We need to see that the multiple other programs are acting together in terms of our common objective to prevent the progression of the non-communicable disease or prevention and control of non-communicable diseases. So what we could potentially do is that now we need to think about maternal nutrition, a pre-conception health factor. So the RCH program, the reproductive and child health program, is a key important aspect. Now, important contribution to non-communicable disease prevention, giving every child the best start in life in terms of education, in terms of our RCH program, in terms of nutrition, it is very important. So it goes beyond the health sector as well. So we need to also think about a good adolescent reproductive health program. I'll tell you why it is important. Let's look at the example on an adolescent girl. And if they are not exposed to the appropriate environmental conditions, there could be chances of adverse health profile like obesity or the polycystic ovary diseases, which could potentially lead to gestational diabetes, which could potentially lead to health issues in the offsprings. And that will continue. That baby would follow a high risk approach. Therefore, even in every program that we see, we need to see with the lens of non-communicable disease prevention and see opportunities for prevention and use it. Even if you look at the healthy and happy workforce, it is important for us for non-communicable disease prevention. The workforce is very important. All of us work, I mean, if you are getting a secure job, it secures our family as well. So providing that workforce, the appropriate work environment for people is also important for non-communicable disease prevention. We need to invest on social networks, which is an important aspect of non-communicable disease prevention. Healthy and resilient communities. So the urban design or the town planning also has important functions in terms of prevention of non-communicable diseases. We need to also see a place-based approach to health. What I meant by a place-based health approach to health, wherever we are, whether we are in the schools, whether we are in the work sites, whether we are in other places, there should be an optimal health approach so that throughout our life course, we are only exposed to the optimal health factors, and therefore we don't develop conditions like risk factors of non-communicable diseases. Definitely, we need to act on poverty. There is no doubt about it, because poverty again has a vicious cycle to increase the propensity to develop non-communicable diseases. So we need to actually follow an integrated approach across the life course. So what are we going to do in terms of prevention of non-communicable disease across lifespan? These have been already discussed as part of the previous talk. I'm not going to details about it because these we know. But what is important here is that all these factors, whether we are trying to address diet, whether we are trying to address tobacco or alcohol or physical activity, employment or adverse childhood experiences, we need to see the window of vulnerability and window of opportunity and address them at the right time point as early as possible. So what are the action plans that we could think about from this one? Now, we need to strengthen our national capacity. We need to strengthen leadership. And that is where your contribution is that now at the moment. You are at the district level, you are at the state level, you have certain capacity that you are holding in terms of non-communicable disease prevention. You need to see that your leadership, it matters for your district, for your state. And we need to come up with good governance mechanism where there is good multi-sectoral action. As I said, health department may not be able to do it alone. We need to think about other sectors as well. The reduction in modifiable risk factors of non-communicable diseases and its underlying social determinants. We cannot ignore that social determinants of these potential risk factors of non-communicable diseases, which includes fiscal and marketing policies, which has been already discussed, which could potentially influence the demand, which could potentially influence the access and affordability of various things like tobacco, alcohol, food, or the drinks which are high in salt or sugar. So we need to address them, and saturated fat or trans fat, everything is important. Then what we need to think about is strengthening and orientation of health system to address the prevention and control of NCDs through people-friendly, patient-centered approach. At the moment, all of us in all the states, I am aware that we have reasonably, we have primary healthcare system, but they are actually, are they really patient-centered? We may be addressing individual conditions like hypertension, diabetes, or cardiovascular disease condition, but are we, are our health system, are we really catering to a patient-centered, patient-centered? Are we adopting a patient-centered approach? Are we giving importance to the patient as a whole with multiple conditions at the same time? These are the important things that we need to think about it. And then in terms of the universal health coverage, whether we can provide certain services to a large section of the society, that is an important approach that we need to think about it while addressing the NCDs across the life course. So taking a life course approach, it requires that we improve the health literacy. There is no doubt about it, through multi-sectoral action, working with individuals, could be working with institutions, communities, and countries. So these interventions must extend beyond the health sector. We can't restrict it to only to the health sector alone, and targeted within the natural settings that people encounter through the various stages of their lives. So we need to think about what are the windows of vulnerability, what are the windows of opportunity, and use the ideal platform for prevention and control of non-communicable diseases. Whether it is in the school health program, whether it is in the adolescent health program, whether it is in the reproductive and child health program, there is a window of opportunity for prevention and control of non-communicable diseases. And thank you for listening to me, and I'm happy to address any questions that you may have.
Thank you, sir, for the presentation. Are there any questions from participants? Any question from online participants? So I think there are no questions.
So thank you very much. I understand that it is lunchtime and all of you are hungry, but make sure that we have this non-communicable disease agenda in our day-to-day work life. Thank you very much for listening to me. Thank you for the opportunity to talk to you and interact with you. Thank you very much.
Thank you, sir. Now we will be having a lunch. So the session will start by 2. So all of you are requested to have lunch then. Online participants can have break till 2.
नहीं इसमें लगा Great. So you've been all talking about non-communicable disease since yesterday, right? This is the second day. Okay. So you must have seen this slide, so I don't have to talk about it. Okay. So there is doubling of deaths due to NCDs. I don't think any one of you have in your mind doubt about the burden of non-communicable disease in the world and in the country. So yes, no? Okay. So I just want to spend a couple of few minutes talking about the characteristics of NCDs. I'm sure you would have done this in the last couple of since yesterday, okay, and may be aware, because that's relevant to the research, the kind of research what we can do in the non-communicable diseases, right? So we all know it has got a complex etiology, right? Like COVID-19 caused by COVID-19, tuberculosis caused by Mycobacterium tuberculosis, like one bacilli. Like unlike the infectious disease, there's a very complex plethora of etiology, multiple risk factors. There is an insidious onset. I can talk about this in a couple of slides here. So what we mean by complex etiology? So you have chronic diseases. You can take any of our diseases like heart diseases, diabetes, cancers, chronic respiratory diseases, etc. So they do have most of them do have a common risk factor, which are all like high cholesterol, high blood pressure, obesity, and metabolic syndrome. That is the physiological risk factors in the body, which are all influenced by the next circle. Is there a pointer? Okay, that's fine. I can go. Which what we call as an underlying distal factor, which are the behavioral factors, right? Which is physical inactivity, tobacco, unhealthy diet, alcohol consumption, chronic stress, etc. Air pollution also included in that. So then you go to the next level, what we call distal proximal. So one chooses to be unhealthy or one doesn't choose to be physically inactive. That's a possibility, but there are a lot of other contextual factors that influences people to pick up tobacco or being physically inactive, etc. Right? These are, for example, like we can't choose to be active sitting right now here. Okay, so you have been physically inactive since the morning because you're sitting in the seminar room. So the lot of these contextual factors influence what you eat, how you behave, what the habits people pick up, which can be from work, they're based on their income, education, family. So why am I talking about all this? Because when we talk about research, when we talk about intervening in non-communicable diseases, we are going to intervene at these multiple levels, right? It's not just like managing hypertension patient in our own clinic. Okay, so which is influenced by the larger context in the country, which is economy, politics, and also the international influences are there, including what are the trade policies are there, whether UN is doing something about it, etc. Okay, are we clear on this? So we do have this very multiple layers of risk factor for NCDs and complex etiology. Then there is a long latency period. So you had a risk factor, you got COVID-19, in 2 weeks, you're going to get disease. It doesn't happen that way in chronic conditions, unfortunately. Not just start like 2 years back or 3 years back. It starts in the infancy itself. So there are theories you may be learning in the next 3-4 days, may touch upon, or you can go back and read. It's called fetal origin of non-communicable diseases, fetal origin of cardiovascular diseases. It starts from the maternal factors, right? Then what happens in the infancy and childhood, adolescence, and adult life. Okay, so this long latency period is also key when we are designing intervention, when we are designing research to understand non-communicable diseases. Okay, in the insidious onset, what does that mean? People most of the time when they have this, they don't even are aware. There are no symptoms, whether it is diabetes or hypertension. For example, of the 1.4 billion people in the world globally who have got hypertension, only 650 million are just even aware, forget like they're seeking treatment or that they have got high blood pressure. Okay, so that's important. Then there are other issues with non-communicable diseases like prolonged course of illness, functional impairment, or disability caused due to that. Okay, and incurability, most of it, and which frustrates people and which becomes very important when you're designing intervention and research, is because they think it's a lifelong condition, I need to take lifelong medication, etc. Right? So why do we? So I made this slide thinking what kind of research we need to prioritize in NCD, but do we all agree is research is relevant? Forget like even figuring out what's a risk factor for incidence, risk factor for non-communicable disease. But when you are doing a program implementation, I know that I've been told there are state program officers here, so and other public health professionals. Do you think research is key in program implementation? Can I get one of you to say why it is so?
And I gave some policy recommendations for the same. Like the tablet size can be reduced, it can be flavor coded to increase the adherence. But then it's just lying in the air because I was not working here at that time. Okay. So if I had done when I'm working in NHM, I could have piloted it in it and see if the adherence is going high and if the hemoglobin levels have actually increased and has an effect on reducing anemia. So research is very important and it should be prioritized according to the state's needs. Whatever health needs the state had should be prioritized towards that.
I really like what she said. She talked about should be prioritized according to the context, right? Whatever we need to take decision and action, the action, what she talked about was to reducing the size, improving the flavor of the IFA tablet, right? That was the action. But to make that decision and action, if you have an evidence base from a well-conducted research, would be a much better impact on ground, right? So I was coming to the exact point what Madam just said is how do you prioritize? We also have to look at the perspective, from whose perspective when we are talking about prioritizing the research, right? There could be, when World Health Organization and sitting and deciding priority, it is for global and international policies, right? What research needs to be done in these areas. Or when we are talking at a national level, it would be for the national public health policy, what we need to include in NPCDCS program. But you could do, like as a program officer or in your own areas, when you are prioritizing, what influences my local context, right? A health system person might be thinking, what is the research priority for health system, within health system? A clinician might just think, what's the priority for NCD in his own clinic, and patient's priority might be entirely different in terms of what is a priority. So the priority might vary. So you need to figure out on whose perspective you're thinking about a research priority in NCD. So whenever you're deciding, you need to figure out relevance. Is that research relevance? Is it feasible? And does it have a public health impact? That is very important for the public health personnel. Again, I wanted to talk about this again, because whenever I'm talking here, when we are all talking, we are talking about the public health perspective. Okay, but research can have, again, different stakeholders' perspective. Let's just talk about one thing. I think you are all very sure that what is the most common cause of mortality globally and in India? Ischemic heart disease, no doubt about it, right? So if I have to focus, prioritize in NCDs, I mean, if I have to be the topmost priority is to preventing deaths due to ischemic heart diseases. Yes. So what is the priority? Like if you are a drug developer, what would be a priority? Just think through. I don't want you to even give an answer. Like, would you want to create such a medication which can be administered by maybe a non-specialized person in terms of heart attack? Yes, like as a drug developer, what you would be thinking? Health technologist, right? And a clinician, what would be his primary research priority would be? Would that be how to manage an MI? Which I think everybody knows, right? Like, is there a research needed in like how to manage an MI? Probably there might be improvisation, there might be more newer ways of doing it. But what would be a priority in a country like low and middle income countries for a clinician and a hospital administrator, or even for a public health researcher? Huh? Cheap interventions, okay. How early it can be detected. Simplified treatment regimens and which are cost effective. Okay, let's hold on to these thoughts. All these are important, but we need to talk about at what level of intervention, what we need to talk about, right? Preventing deaths from ischemic heart disease, you can do at multiple levels, right? Okay, one, I will come to that. I have a slide on that. I'll come to that part. Okay, basically, so the humongous research areas, these are very broad. Okay, we can have researchers to figure out the intervention which is effective. What are the disparities in the low resource setting, because we need cost effective interventions. Okay, we need to track NCD burden. We need to monitor and evaluate the effectiveness of any program, whatever we are doing. We need to find new diagnostic medicine and technologies to improve better the outcome, right? And figure out other research priorities. Okay, so this is what the WHO sees. Again, this is, as I said, is from the global perspective. We do need an intersectoral and multidisciplinary research. translational research. That's where the priority of WHO for globally lies, and which might be a priority for us too. We'll come back to that. Okay. Okay, I'll come back to this slide. Okay, before we even discuss the ischemic heart disease, the topic at what level we're intervening, let's talk about different types of research, right? All of you are familiar with the types of research? Some of you are, some of you aren't, right? So this is, I want to stratify this as 3 broad types. Epidemiological research. Okay, can one of you tell me what do we do in epidemiological research? Okay, yes, sir. Descriptive epidemiology. What do we do? Like, just give an example in the context of NCDs. Correct. So we just figure out how many people are dying from MI. What is the prevalence of diabetes or hypertension in a particular population or in our country, etc. Right? That's can be there. And we could even have determinants. What causes in terms of association, and figure out, like, for example, tobacco smoking. What percentage of people smoke tobacco? What percentage of people consume low fruits and vegetable? Percentage of people who are inactive, etc. You could even have awareness, knowledge studies when you do a epidemiological study. Okay. Then you have what we call as a discovery research. What does discovery research mean? Okay, figuring out the association, what is causing, for example, genes or any proteins or molecules, what might be associated with these diseases, the basic science stuff, but also the diagnostics and drugs. Well, can we come up with a new diagnostics? Can we come up with the new drugs? And then you figure out whether it works or not through a randomized controlled trials, clinical trials, right? These are discovery research. Okay. Then we have third part called the implementation or operations research. What is this? Can someone tell me about this? Anyone has an idea? Correct. The knowledge we get, we implement on the society. What is the effectiveness of it? Absolutely. So that's a qualitative research. You figure out pathways, what worked and what didn't work in the research. Yes. Huh? Sustainability of the previous research. Okay. Sustainability. Okay. Fine. Possibly. Okay. So, but if you take up the knowledge, you implement it, that's a program. That's what many of you, the program officers sitting here, would be doing, right? What is the research in that? Yes. It's how to reach the no-do gap, how to bridge it. Okay. Just to give an example in hypertension. Okay. We all know how to, do we have knowledge about how to detect hypertension? Yes. Is that easy, difficult, relatively cheap? Okay. Do we have knowledge about what should be done when we detect hypertension? Yes. Okay. And is those medication easy, cheap, affordable, you know, for both for the government or even for other persons to buy? But we still have only 10% control of hypertension in this country. Okay. That's where the no-do gaps come, right? Why it is so. How do we make this reach there? So you can identify strategies. Okay, it's a how do we those strategies, the public health strategies, you can do it in the form of research and figure out whether you can come up with 3-4 strategies, whether this will work or not work, right? So those are implementation research. Okay. So all of you are familiar with these 5 diseases and 5 things, right? I'll come back to this. So we were talking about prevention of deaths due to ischemic heart disease. Okay. So as I said, like various levels, immediately how you save lives from ischemic heart disease is to offer management to an acute MI case, right? Which could be thrombolysis, stent, CVG, whatever the cardiologist does, okay, or a physician does, right? That is one level of care, one level of preventing deaths. When I'm talking about preventing deaths, not preventing IHD, right? Preventing deaths from the IHD. The second level is to prevent the IHD itself. Okay, that is by optimal management of blood pressure, blood glucose, blood lipids. You can go below that and prevent people from getting high blood pressure, high glucose, and high lipids. So let's talk about what do we already know about acute management of IHD. Do we know how to do that? Yes? Okay. But does this happen on the ground? Whatever epidemiological surveys or studies say, or whatever the data, even if it is not perfect, what does it say? It doesn't happen, right? So why it doesn't happen? Have you heard of these 3 delays? Correct. Correct.
And after reaching on time, also there is a delay in like getting the
facility itself. Absolutely. So she already talked about 2 delays. Third delay. The first delay is that you haven't even recognized the symptom and aware that you should seek treatment for that. The second delay is you don't know where to go. You might even do many shopping. You go to multiple places and then go. And the third delay is when you go to the health facility, there is a delay in administrating the right management. So you could do research to figure out how do we overcome these delays? Why are these delays happening? How do we overcome these delays? These kind of research are called implementation research. Okay. So the next one is, I already talked to you again about blood pressure, right? Again, we have effective intervention to manage high blood pressure, high glucose and lipids, dyslipidemia. Yes or no? More or less, there can be improvement, there can be newer drugs, there can be a better way of doing it. There will be a lot of innovations. Okay, there might be a better way of delivering insulin that might come up. So those discoveries will happen. But from the public health perspective, we do have the effective intervention. But where are we lacking in? Again, how do we bridge the gap? Okay, so we need to figure out what are those scalable strategies in which we can ensure management of these diseases, right? Okay. So then the third, improving lifestyle. Again, this is a bigger question. Okay. Keep that in your mind. How do we do that? Let's think about improving physical activity. Do we know how to improve physical activity? Everyone knows, just get up and walk, do exercise. Yes or no? But does that help? Okay. Or sodium reduction. Okay. Does any one of you know how much salt we should eat in a day? 5 grams. Okay. You said 5 grams, ma'am. Do you know how much you ate yesterday? Is that even a figure? Like we as an expert here don't understand like how to calculate. Like we tell people, okay, you should eat even 5, forget less than 1 teaspoon a day. We tell people, right? Like how are they going to do that? Okay, so it's a hard. These are the strategies, figuring out how do we do this when there is a knowledge, okay, which we know, tested strategies, tested interventions are available, but we need to figure out our strategies. How do we make that actually happen on the field? Those are very, very important. I had to go up. So I also thought, I don't know, how good are we on time? I think we are pretty good, right? Okay, 7 more minutes. So maybe we'll not do this. I just wanted to let you know, like you can do it in your, I don't know, whichever the time permits, is to go through this 5 priority disease areas and 5 priority risk factors for NCDs. And what are those research gaps? What are the epidemiological research are needed in here? What kind of discovery research are needed? And what kind of implementation research are needed? When I talk about public health priorities, like when we come to this, okay, specifically in cardiovascular diseases and diabetes. Okay, the lot of them, if I have to list out the priority in terms of effectiveness, in impact and scalability, in feasibility. Okay, these are the three things. Okay, relevance, feasibility, and impact. We would see a lot of those research lies in the area of implementations. There's a lot of things which we already know that should be happening, but it's not happening. So we need to figure out through a solid conducted research to figure out how to do this. Okay. So I also want to talk about two researchers that ICMR is doing right now, which comes in this area. Just to give you a sense, we talked about the acute MI cases, right? We have this project called STEMI Act. So what are we trying? This project is specifically trying to address the 3 delays part of it. So in a nutshell, what is this project is we are making the community health centers as the key health facility for providing care for ST-elevated myocardial infarction. That means they're doing a thrombolysis at the community health center, a medical officer sitting in a community health center. So how do they do? We need to provide the basic infrastructure, which are very basics, and the medication to be ensured in community health center, training the medical officers, and they are teleconnected with a group of cardiologists who are sitting in a hub, what we call as a hub spoke model. Okay, so as soon as a patient with a suspected MI comes, they take out the ECG, send this ECG through telecommunication to the cardiologist, and they advise if this is an ST-elevated myocardial infarction, and they can immediately thrombolyze. Okay, using a drug called tenecteplase. Why I talked about, again, drug discovery is very important, because this, like I know when I was in med school, it was streptokinase we used to use, right? There was a much harder, more complicated drugs to use in a community health center, but this requires just one bolus injection. So which is much more simpler for a community health center doctor to do. So they will thrombolyze, manage the patient, then refer the patient after the patient is stabilized to a higher center. So what is the control? We have collected the data on this management like 3 months before, prior to this. The implementation research doesn't happen like a randomized control trial in a very strict rule, right? We have a pre and a post, like 3 months prior to the project, we collect the data on how the management is happening, how many patients are being treated. We implement this and see what happens after that. And also calculate what you call the symptom to the needle time, like when the symptom started, when the needle, door to the needle time. So with implementing these intervention, would that have improve this? The outcome is not just like managing MI, but we are also interested in whether it reduces the delays we talked about. Okay, so other project again. So this STEMI Act, like again for the program officers here, once this project, and it's almost semi-successful, we are still implementing it. Now it's going to be the part of the national program. Okay, so the national program going to implement this in the nationwide. Similarly, the India Hypertension Control Initiative, this is again ICMR initiated. Okay, the simplest management of hypertension, but still we were lagging behind a lot. So this project used various different strategies, having a very simplified protocol. I think someone mentioned about it, right? Simplified protocol, ensuring medication supply, creating teamwork and patient-centered care, and having a system where we are getting indicators. Okay, something which is not measured is never done, again here in the public health. And we implemented this, and again our research outcomes are looking at the trends of hypertension control rate over time in the same 25 districts. It's been implemented now in more than 101 districts. This is another project. Okay. Okay. So again, I told you, hold the thought on the lifestyle one. This is the hardest thing to do in our communities, right? Lifestyle it's very easy relatively lot more easier to make people eat medicine, right? You tell them you have got hypertension, convince them a bit, eat this tablet every day, right? But tell them to do lifestyle changes, not to have their samosas and go for a 30 minutes walk, not to eat sweets. It's the hardest change. We still don't know. There's a lot of areas to be, we know what works if you do change. And there have been superbly well conceived trials and also been partly done in India too, where they had done diabetes prevention and where they have lifestyle coaches going to the people's house, and talking to them about their diet, giving them gym memberships and a lot of those stuff. Okay. And their lifestyle changed, their BMI came down and their incidence of diabetes reduced in that group. Okay. But we know when we talk about contextualizing is when we are talking about low and middle income countries in a larger sector, how do we come up? Can we come up again? Can we use other alternative methods? For example, yoga. Okay, so there's a lot of research that can be done using alternative systems in yoga and see how that might help in changing lifestyles of the people. Okay, so these are some of the listed priorities beyond the prevalence studies. And there is a NCD research agenda. This is a group of people. They had consulted all the experts and created what are the research priority. I'll leave it to you. You can go through it. I think you will get access to these slides. Okay. So I didn't want you to go through what exactly is the priority. I just wanted you to think through how to come up with priorities when you are thinking about research ideas. Okay. These are some of the relevant reading. I think Abhishek must have already shared with you. Okay. Okay, that's all from me. I'm good on time. Thank you. If you have any questions, please ask. I've seen that project from Mangalore group, right? I've seen that. It's different from that. I know they had this plan. It's very similar to it. They had this group of WhatsApp group and all that. I had gone through that. It's more of a program. I don't think they have good indicators measured in it. It's not run like a research, the cardiology and doorstep, but it's similar to that. Yeah, I can see.
Ma'am.
So where are you from, sir? Telangana. Yeah, yeah. Okay. 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 In Hyderabad or elsewhere? Hyderabad, there's sufficient, right? Okay. Okay, and there are cardiologists there. Okay, okay. Okay, so now you've got it. Okay. So I believe Telangana is not part of the STINGY Act project. It's a NPCD's, the Ministry of Health program, right? In Telangana, yes. Yes, sir. Yes, sir. Yeah, so I think this risk is always there. Like when we are scaling down the down an intervention so that it is accessible to everyone, should we have that specialized center or not, right? Yeah. Any other questions?
Ma'am, you showed a picture where lots of people stand in a queue where surgery is provided. But ma'am, is it due to the government is very much interested, even the research bodies are very much interested in finding new drugs, new technologies, introducing new treatment and care, rather than like there are lots of researchers in public and preventive aspects, but why weightage is not given, importance not given to that, and it's only in papers?
Good questions. It's very hard to say whether a chicken egg story, whether people want it, whether researchers want it. Okay, so yeah, there's definitely a lot more money in pharma and other. Are we? If I have to leave, I'm looking at other organizers. Okay, so this is historically also it's very true, right? Historically also, there's a very nice article by Dr. Atul Gawande, if you've read, and I'll recommend all of you to read it. Hand washing and anesthesia. Okay, both were found at the same time that, you know, both helps. While the hand washing helps in prevention of transmission of diseases within hospital infections, while anesthesia reduces the pain of the patients. How anesthesia picked up and hand washing didn't pick up at the same speed, although it is a very low level, low key, I mean, requires no kind investment in that as such, right? It's a very hard to do. People get fancied about newer things. They doing routines are not interesting. Asking people to go for a walk is not interesting. Okay, you come up with some new fancy thing to tell them, they will be very happy to identify it. Yeah, having said that, I agree. The investment in the public health and lifestyle medicine is
when we talk of new drugs, like government is ready to include that in the protocol. But when we talk of the physical activity, but the government is not ready to install parks, making the physical activity period in schools compulsory. So is it the mistake of us or the government is not receptive?
It's hard to say whose mistake it is, right? It's very hard to say. Like, for example, they're very happy to put those gym in the parks, but to make footpaths on the road, it's much harder for the government to do because there's lot more competing interest. In the school, we want physical activity, and there's always a policy to make it compulsory. But then there is competing importance at the school, whether they have to complete their academics, so etc. It's hard to say who is responsible, but we all have to strive towards making that better. So thank you all. It's nice meeting you.
Thank you, ma'am, for enlightening us. Next, I would like to request Dr. Neha Dumka. She is Lead Consultant, Knowledge Management Division, National Health System Resource Center.
Good afternoon, everyone. So I work with National Health System Resource Center, which is a technical supporting unit of Ministry of Health and Family Welfare. And I would be presenting today the NCDs addressing non-communicable disease as a part of comprehensive primary health care. So just to begin with, I would just like to ask, how many of us here are aware, what do we mean by comprehensive primary health care? Anybody? Can anybody explain what is CPHC? Fine, I will go ahead. So I'll just go back to 2014 when a task force was formed on primary healthcare in 2014, which actually defined some of the recommendations specifically for rolling out comprehensive primary healthcare across country, which fed into our Ayushman Bharat Health and Wellness Center, the comprehensive primary healthcare approach we talk about these days. So the task force had a report which spoke about how an effective delivery of primary healthcare has a high potential of reducing the morbidity as well as mortality at a lower cost for both health systems as well as the individuals as well, and also decreasing the burden at higher facilities, which is secondary and tertiary facilities, and also reducing the need of higher facilities for care. So they also spoke about three main requisites of primary healthcare, which are when the services are closer to the community, A. B, when the primary healthcare team, the people responsible for delivering primary healthcare also have a responsibility for the catchment population or for their population. And C, when there is a care coordination role to see that not everyone needs to go to a higher center, but can be treated as required at the primary level itself. So when we are also talking about universal health coverage these days, if we have to universalize primary health care, there has to be a free permanent access to quality of care without any out-of-pocket expenditure at this level. And to also ensure that we have a social security for people who are accessing care at the higher center, at secondary and at the tertiary center. Not only the care at the facility level, but comprehensive primary health care also includes the community level interventions, which include health promotion, health education at the community level, that how can we talk about primary and secondary prevention at community level itself. So back then, the rationale for introducing comprehensive primary health care was that there was a selective approach where our primary healthcare facilities, as we say, sub-centers, primary health centers in both rural and urban areas, which are now being upgraded as health and wellness centers, were being very limited for providing services in terms of mainly limited to RCH related services, communicable disease, acute simple illness, and not much on NCDs. Also, our NSSO data showed that there is a very low utilization of these public health facilities in both rural and urban areas. And also wherever being utilized, they are more limited to childbirth related services. Plus, the fragmentation of care was another issue raised by multiple experts. And it was also impacting the quality of care for sure. There were high cost of care being incurred, both direct and indirect costs were being reported, a high out-of-pocket expenditure, which was also being linked to medicines and diagnostics. And a report quoted that almost 70% of out-of-pocket expenditure is on non-hospital care and also on medicines. We all already spoke about epidemiological transition, so I would not focus much on that. And of course, there was some unfinished RCH agenda where we had not reached the targets, and there were some states still facing the problems of high TFR, high MMR, or high IMR. So based on all this, in 2018, the comprehensive primary healthcare was rolled out, while our first health and wellness center was launched in Chhattisgarh in April 2018. However, the concept after the PHC report came quite earlier in 2014, and thus, as a first step towards CPHC, the screening of non-communicable disease in primary healthcare was introduced in 2016. So explaining the universal health coverage under Ayushman Bharat, we can see here a triangle with the base which speaks about the primary level of care, where we see that how existing services were just RM and CHA plus some of the communicable disease, maybe we can say TB, leprosy, and some acute simple illness and normal OPD care. But there was a huge gap on unmet need as when we speak about the non-communicable disease at this level. At the higher level, we do have secondary and tertiary care, but again, there was no linkages between these facilities when we speak about NCDs. The community was directly reaching to higher centers, to CHCs or to DH for any treatment regarding hypertension, diabetes, or for cancer also to higher facilities. So with Ayushman Bharat, the CPHC comprehensive primary healthcare rollout, the health and wellness centers were being operationalized at primary level to ensure that we are able to provide a primary service for NCDs at this level, thus bridging the gap, and also developing linkages with the higher centers so that there is a continuum of care, and also there is a follow-up mechanism built so that a person who is reaching to the higher centers is also followed back when they are back to the community. So under CPHC, 12 range of services were defined to be delivered at primary facility level, out of which the initial 6 were those which were already existing, which were all RM and CHA related chronic communicable diseases, nutrition, and acute simple illness. So the first step, as I said in 2016, was developing guidelines on screening, prevention, and control of common NCDs. Under this, 5 common NCDs were identified using the data. The 2 were hypertension and diabetes, and 3 common cancers, as reported by Globocan report in 2012, that oral, cervical, and breast cancer were the commonest cancers being reported in India. So for these 5 conditions, NCD program was launched in 2016, followed by launch of Health and Wellness Center in 2018. And the recent development is the following the rolling out of the rest of the packages, that is oral care, ENT care, eye care, then elderly and palliative care, and emergency services. Elderly and palliative care here were considered as one package. However, they are being rolled out as 2 separate packages with different guidelines and different training modules. The organization of comprehensive primary health care was across the 3 levels, where at the community level, the preventive and promotive care was a prime focus, and also the frontline workers were being actively engaged for health promotional activity and also mobilizing community to get services at the nearest health facility. At the Health and Wellness Center, which were earlier the sub-centers and primary health centers at rural and urban both areas, they were being strengthened with HR, with diagnostics, medicines, finances, so that they can be upgraded as Health and Wellness Center to provide the entire range of packages And at the first referral level, at the next level, the support was being given for effective referral linkages, for having a continuum of care and also follow-up mechanism. The key elements for rolling out of comprehensive primary healthcare were broadly classified under this 9 areas, which were also highlighted in the PHC task force. So first being expanded service delivery, which is already discussed. Now we have a 12 range of services which are defined to be delivered as at HWCs. The second is continuum of care, telehealth referral. So all the health and wellness centers, while effectively delivering these services, they're also developing a linkage with higher centers where not only patients are being referred, but also facilitation is being provided to ensure effective referral. And a closed referral loop is encouraged so that we can have a track and follow up of each and every individual. We also have telehealth now in place with most of the HWCs also providing teleconsultation services with higher centers. Expanding HR, under expanding HR, all the sub-centers earlier had MPW ANMs and ASHAs as the main workforce available at sub-center, which HWC, we have a new cadre of workforce introduced, which is a community health worker. These are non-physician health workers, mid-level health providers as well, which we used to say earlier, who are either a BSc nursing graduate or an Ayush graduate, which undergoes 6-month certification course on community health, which is done in partnership with IGNU and Ministry of Health, and then placed as community health officers and team lead for that particular HWCs across sub-centers. For PHC and UPHC, it was made a mandatory criteria that a presence of MBBS officer as a nodal person, as a medical officer in charge, should be there to make or to consider that PHC as a functional HWC. Also, multi-skilling and training and building capacities of workforce is an important component in the CPHC. With medicines and expanded diagnostics, the list of essential medicine and diagnostics has now been expanded, reflecting upon these 12 range of services for HWCs, for sub-center PHCs, so that the services can be delivered effectively and as designed under CPHC. The community mobilization and health promotion activities, including wellness component, is now a key area where not only we have health, the ASHAs are being trained for effectively doing lifestyle modification, for promoting good health, for promoting good practices in the community, but also each HWC gets a yoga instructor. And also in some states, we have other, like in Meghalaya, they also do some other exercises, not just yoga. So they are all promoted, and there is a provision of hiring an instructor at that level to promote wellness activities. A robust IT system is there. I think next session, the IT system would be explained in detail that how the data is being managed, monitored, and captured across HWCs. In terms of infrastructures, all facilities were provided support by Government of India so that they can expand, they can build their infrastructure to accommodate all these services, like extra laboratory services, or a place for a CHO to sit, a place where we can have a privacy for NCD screening. So that was ensured, where an additional support was provided for infrastructure as well. In addition, there is a partnership for knowledge and implementation across the states, where states are encouraged to have innovation and learning centers as well to support HWC, to set up an ideal HWC, which is a model HWC for the state, and also encourage CHOs and medical officers to do their analysis of data and undertake research as a routine activity. Under financing, while we have an extra finance being linked to all these HWCs, we have a provider payment reforms where a team-based incentive or a performance-linked payments have been introduced for HWC team members, which is set against some indicators, which is linked to their services, for which they will be incentivized in addition to their normal remuneration. So these are the important components of CPHC. Now, under the CPHC, how this NCD, which is the 7th range of package as we described this particular service, how this package was rolled out, and where are we today on this. I will not discuss much on rationale because I see much of it has already been discussed on NCD, that why the whole epidemiological transition, the GBT report, and why we thought NCD as an important area. I would just focus on that we had 3 different levels of care of NCDs under CPHC. As I said, the community level, health and wellness center level, and the higher level. To start with the community level, our first approach was at the community level, we had a community health worker, ASHA, or in other states like in Jharkhand, we call Sahiya or we call Mitanin in Chhattisgarh. So these community health workers in both rural and urban areas were trained to undertake a community-based risk assessment. a checklist was developed, CBAC, what we say, which had all the 6 risk factors associated with NCD, like the age, the alcohol consumption, tobacco consumption, physical activity, family history, or waist circumference, against which a score was to be given by these community health workers to identify or to highlight that who all are at higher risk of getting an NCD. The score was not meant for elimination of anybody to get screened, because the program was about universal screening, where everybody, anyone who is 30 years and above, has to get screened for all these 5 conditions. For hypertension and diabetes, the screening was to be done annually, once in a year, while for cancer, it was decided once in 5 years. So the scoring was done to prioritize whom to send screening first, because it was a caseload calculation was done to with the assumption that on a normative population of 1,000, we have 37% individuals who are 30 years and above, and an ASHA has a normative catchment population of 1,000. So on base of that, 370 people would be 30 years and above. So how she has to calculate and prioritize, and at one time in the facility, not more than 30 or 35 individuals are called for screening. The rationale was that nobody who reaches facility should go unattended, because then there are chances that that person won't come back or return back for getting screened. So with that idea, it was there that person with higher score would be prioritized for getting screening first, followed by rest, but everyone has to get screened. In addition, this scoring was also beneficial because community health workers were customizing their health promotional activities for those targeted groups, that who needs more focus on alcohol related thing, who need more focus for physical activity. So they were also utilizing these scoring for that customization of health promotional messages. So once ASHA does the CBAC, A&M as a supervisor had to do the validation of these forms. So the guidelines specify that 10% of the CBAC filled and submitted at the facilities are to be validated by A&M to ensure that they are filled correctly, and we are also doing monitoring for those things. So for ASHA, an incentive was also linked for each form. When she fills one CBAC form and she's able to mobilize that person to come to the center and get screened, she was getting an incentive of 10 rupees. So once the CBAC is there, A&M is validated, the person reaches health and wellness center, sub-center, or in urban areas at UPHCs, and they get screened. So at the sub-center level, because we had the team lead at CHO and we had A&M, so we cannot say that at the sub-center there can be any confirmatory diagnosis in absence of a medical officer. So the guidelines specified that at that level, we would be calling people suspected individuals for these any of the NCDs, who will be then referred to higher center for a confirmatory diagnosis and also for treatment initiation. So like this was the channel, and in CBAC there was another part where some symptoms were highlighted for which the answer was either yes or no. So ASHAs were trained on that to ensure that anybody who had an answer yes to those conditions would need not wait for their screening turn, but should immediately be referred to the health facility on priority, so that we don't wait for them to get their turn and then something is coming out of that. So now when the patient is getting a confirmatory diagnosis and get a treatment plan from the higher center, there was a specialist consultation was also to be done either through teleconsultation nowadays, and after COVID, the facilities are quite comfortable undertaking teleconsultations. So even some of the health and wellness center where the platform was not developed, they used to do phone calls to the specialist and try to establish link on that so that they can develop a treatment plan and monitor for initial few visits. Once the case established and back to the community, then the medicines were being dispensed from the sub-center health and wellness center itself. And because earlier the problem was that for medicines, the individuals were going to the higher center, getting medicines for 7 to 10 days and then returning back for next medicine. So there was a problem that treatment compliance was not being observed, because people were not very active that every 7 days they have to go and collect the medicines. So under this program, this was defined, the medicines should be dispensed for minimum of 1 month, so that the patient don't have to travel back and forth for this. So the medicines were being, the caseload was being calculated by the CHO at that center, so that accordingly they can indent medicine from the PHC, and that they were being dispensed at this level itself. As a follow-up activity, ASHAs or our community health workers were now visiting these individuals under treatment to ensure that there is a treatment adherence, and also there is no complication and no other problem being reported at their end. So again, this was linked to an incentive. that ASHA visiting these individuals, for every individual who is an identified patient of NCD and under treatment, ASHAs would be given 50 rupees in 6 months. So that means 100 rupees annually for per patient. So when she is doing follow-up, she reports to ANM, who then cross-verifies, and then this incentive was linked to this particular activity. So in addition to these, all these steps across this level, there were also linkages with the higher center. So when NCD program came, it was not like something new is coming up, because NPCDCS was already functional since 2010. But NPCDCS was focusing more on secondary healthcare facilities and limited access at the lower level. So under NPCDCS, we had NCD clinics at both CHC, SDH and DH level. Plus, we also had a dedicated NCD cell at the district and state level. So who were managing this program. But the services on NCD were not that much at the lower level, especially at the sub-center level, although the reporting mechanism were well defined and forms were being filled and reports were being generated for sure. So now when this program came, so as it was a part as an adjunct to that NPCDCS program only, the linkages were also being developed with the NCD clinics to ensure that it's all in one line and there is a continuum of care for every individual who is accessing services from these facilities. So I think this is also, I already explained. Any question on this, the whole chain of services across the level of facilities? Any? Yes. Yes. Yes.
CVAC form should be filled for all population. So in every year we should fill up the CVAC form for all population.
It's an annual activity. So earlier it was only, if you see the CVAC form was to be filled for 30 years and above.
Yeah.
So although in the revised CVAC form, they have added the age group of 0 to 29 years, but still the guidelines is 30 years and above. It was because in some facilities, they were also capturing some data. So that option was there with the risk factor associated. The scoring was done 0 for that age group, but it is for 30 years and above and an annual activity.
But regarding that cancer, as you said, ma'am, within 5 years, after 5 years, we should go for the screening of this cancer patient. But in between that, they can occur the cancer. So if we got that, suppose हम लोग क्या करते हैं कि आशा या फिर एएनएम को हम लोग ट्रेन करते हैं कि अगर ऑन फील्ड आप ओरल में देखते हैं ऑन ऑब्जर्वेशन some observations are there, then you can refer the patient to the PSC और तो वहाँ पे भी 5 साल के अंदर पे भी वो अकर्स हो सकते हैं कि पेशेंट।
आप कहाँ से हैं सर?
उड़ीसा।
उड़ीसा से, बिल्कुल सर। if because CVAC is an annual activity anyhow, so CVAC में part B में where the answers are yes or no में cancer के भी symptoms for these 3 cancers it's mentioned there. So if any time there is any such thing present or there is any complication or even any complaint by it, they can anyway get screened. But we don't say कि they can't get screened in between as well. So that is there, that they can. Thank you.
Guidelines are there for 30 days of prescription drugs for the NCDs.
Yes.
And the CHO can give.
Yes. They can indent, yeah. They can dispense medicines.
Dispense medicines and follow up. Like obviously the diagnosis is not being done, but a patient who's already diagnosed can be given 30 days.
Yes, ma'am. So, ma'am, we have this on the ministry website. Otherwise, I'll leave my mail ID with him. I can send you. There are 2 guidelines. One is the comprehensive primary healthcare guidelines. The other is the screening, treatment, prevention, and screening and management of NCD guidelines. Both have defined that the medicines have to be dispensed for 1 month. Because NCD guidelines came in 2016 and CHO, the HWC came in 2018. So CPHC guidelines mentioned about the CHO component.
Is there any protocol for follow-up of adherence of medicines by patients? Do you do anything?
Yes, so there is under this program, we are also training the different cadre of workforce, the HWC teams. So there is a protocol for Ashas to follow up on those because she does a routine household visits. So she's undertaking that activity and she's being trained for that. There's a 5-day training module for Asha where we train her on that. And also because this activity is linked to an incentive, so the CHO and the ANMs are also trained on this.
So Ashas do the opportunistic screening of 30 years and above, or there's a fixed day of doing this screening of patients?
Asha is not doing screening. She's just doing community-based risk assessment and community mobilization. The screening is done at the healthcare facility level, where based on her caseload or based on the facility's caseload, because a subcenter might be serving to a population of 5,000, normative population, what I'm talking about, is more also at times in some of the bigger states. So they do their caseload, and accordingly, sometimes they're doing once in a week, sometimes they're doing twice, or sometimes they did a mega camp approach. So all that is happening. It varies across states. So that guidelines, only the calculation was there to be used as a guidance, but how they can plan their screening.
Thank you.
Okay. Public-private partnership in screening.
All exercises in any linkages with medical colleges and hospitals, private hospitals or private practitioners. Has something been built on that?
As because this, if I'll say, being limited to the primary healthcare, not much. Government colleges, maybe basically state medical college and government medical colleges are playing active role by being a mentor to health and wellness center, but not private.
They're just being used in trainings and all that. Training the CHOs, cadres, not otherwise, I guess.
Training on what, ma'am? On NCD, or are you talking about their the course?
I don't see much interplay or much involvement of the medical colleges or this in the formative stages of this comprehensive primary healthcare program. I'm just curious that do you have a scope of involving the private sector into it?
Yes, certainly. Anything? Anyone else? Yes.
Do you think one CHO is enough to cater to all the 12 services? Like journey when you go to the health service center, the major issue comes is ANMs have been long there. They say RM and CH is our part, the NCD is the CHO part. How do you deal with that?
So in my following slides, one of the challenges I highlighted was this only, the role clarity. So we are still figuring out, because in some of the states we saw also, because the VHR workforce as defined under HWC is 1 CHO and 2 MPW, either 1 male, 1 female or both female. So in some of the states, even this came up where one ANM was doing RCH work, the other one was doing NCD work. So we were still okay with that. In ma'am, video from which state? Okay, Haryana. Yes, Haryana and UP had this thing where they divided, that the Ashas, the ANMs were doing the RM and CH, they continue to do that, and CHO started doing the rest of the thing. So we are still by means of building their performance link payments, linking their indicator to services, and very soon we are also going to release a guideline for CHOs that how their role is effectively equally important for RM and CH delivery. So this concern is there and we are working on it. But they are supposed to handle all, just not NCD, but all services.
Good afternoon, ma'am. Ma'am, I'm a community medicine resident, ma'am. For my data collection, for my thesis, I have been going to community for my observational study. I found that many of the ASHAs are not, they are not filling CBAC forms. The most common reasons they were saying that we are busy in our RCH programs, and previously we were getting incentive to fill CBAC forms. Now we are not getting that. So we are not filling that CBAC forms. Most of them has told that reason. And second is, since they are not filling, they must be data hampering also, no, ma'am. Like there must be some level of data hampering or something. They will try to show that they are working. So how government is doing, like, is there any monitoring about it, ma'am?
Yeah, there is a monitor. Where is this that Ashas are not filling? Just out of my curiosity.
Like I'm from Banaras Hindu University, ma'am. We have a RSGC
in UP. You're talking
yes,
about UP. Okay. So yes, I mean there is a mechanism which is inbuilt mechanism is there. When we talk about the performance linked payments, we started defining how CHO has to be a team leader for ASHA and NM both. However, in our next presentation on IT also, you will be listening to that thing, how these CBAC and all are just getting converted, are being digitized, and how the monitoring process. So I think I'll leave it for them also, because there is a whole mechanism for the CBAC being digitized and then having the job aids for each of the cadre and how they are being followed up at the CHO level, at the medical officer level, and having a dashboard at district and state level as well. That one is one digitization. However, I'm not very sure about this not being incentivized for filling CBAC, because I won't comment on that much, because I'm not aware of that as of now. But yes, the mechanism on the reporting is there. A monitoring mechanism is there to ensure that this activity is being done on a routine basis and the data is being generated and filled and reported at the national level. Because once HWCs are in place, we also have a HWC portal which does the facility level real-time data entry for the same. So which registers how many CBAC are filled on daily and how many people on treatment, how many people are medication, everything is being done there also. So maybe the next presentation on IT would give a clarity on that. Yeah, please, ma'am.
Actually, the problem that we face with practically.
Yes, ma'am.
So buffer stock of medications, is there any guideline how much at a health wellness center are the CHO supposed to keep?
So our guidelines only specify that based on the caseload, when CHO does the calculation for the caseload, okay, I have 5 people for this thing. So on that basis, for 1 to 2 months, he can indent from place. That was the thing, but not as a specific guideline. Exactly 1 month ka hi rakhna hai ya 2 month ka hai. So, but there was no specified guidelines as such. They mentioned in those guidelines, but maybe I will, because we are revising the guidelines, I think maybe.
And even about transportation of medicines, because health wellness centers do not have their own transport, like any ambulance or any kind of vehicle to go and get medications. And if they're getting from a warehouse and all,
No,
then
no,
it
we are
becomes
inventing from PHC.
But in Haryana, somewhere they're going to the warehouse also. So it should be better if it stays through the PHC and not to the warehouse.
So, ma'am, basically, when untied fund for HWCs was given now from sub-center, where it used to be 20,000, it was increased to 50,000 with these components only. Because the guidelines specified they can take it from PHC only and not from warehouse, because that was not the idea. So thinking of this, they will be indenting this from the nearest PHC, which would be on normative this much population. So that's why the untied fund was increased to address all this thing.
Thank you.
A&M has tablets for it. A&M has, there's a procurement of tablets across the country for this NCD app, which that is going to take the next session. So. No, not Anmol. Anmol is A&M online. Anmol is a different thing. NCD application. There's NCD GUI application. That's a separate application. A separate tab has been procured across the country. Separate tab hai A&M's ka. Unhone procure. States do procure that to enter. There's whole unki training karai hai. So Tata Trust is a supporting unit for that, who are undertaking this training support for this Dell application. I know. I'm sorry. Not doing that. Haryana is likely to coming up with many issues.
Like the system would be a better, like the desktop instead of tablets and all.
So we agreed with the laptop for sub-center level. We said because for the PHC level we were already okay with the desktop for medical officer, but at the sub-center health and wellness center level we were like tablet and we were okay with laptop. Till laptop it was allowed based on state, but that flexibility was with states, whatever they want to order.
So I don't know, I feel like practically laptops get damaged faster, tablets stop working, whereas a desktop always is more practical.
So during actually states says that they have problem in managing and supporting and maintaining the PCs at that level. So laptop was more handy for them. So yes, but that option was there, and if state says there is a rationing, there is no problem.
Ma'am, in private sectors, for example, if an NCD patient lands up, along with the prescription, he is also given a handout which gives the dietary practices like advices regarding diet, exercise, etc. But whenever a patient lands up in a government sector, that is not followed. Even the posters in the sub-center and primary health centers are not updated. It is said that you have to do exercise, but what to do, how to do, and it is given like eat fruits, but how to eat, what to eat. So our ashas are trained in, counseling the patients, ma'am.
Yes, they are. They are trained. Ashas have 5 days training module, which is less on the clinical aspect, but more on health promotional aspect. So she also gets a major portion of her training module is associated risk factors. She's also she's trained on healthy diet, physical activity, stress, obesity, so alcohol and tobacco. And not only in alcohol, tobacco also, she's just not trained only on this, but also if a person is like with facing the withdrawal symptoms, how to provide support to the caregiver and the family members. Regarding your concern for eating thing, we already have a separate program called Eat Right under FSSAI. So across the HWCs, a separate Eat Right toolkit and an Eat Right program is being launched. It's being rolled out already for last 2 years. And Ashas have a separate training program, a separate training module on Eat Right this thing. So that is also over there.
Thank you.
Ma'am, can I ask you a question?
Yeah.
Good afternoon, ma'am. So some of the observations, apart from what all the participants have said, so what we have observed is whenever we interact ASHAs, ANMs and CHOs, so it is their, they say that there is over-reliance of all the programs on this cadre. And sometimes like the COVID was an example where the multitasking was being done. So definitely the health systems were not prepared. So everyone was utilized. All the cadres were involved in COVID care. Secondly, when we made visits in our urban and rural practice areas, so some of the times we say like they were trained in telemedicines, but the laptops were not there, and there were issues in mismatch of the glucose strips with the glucometers. And regarding the CBAC and the NCD portal, so the forms and the reports are being submitted, but they are not functional. Like as some of the participants have said, the CBAC forms are not being filled up. And this was the issue in nearby districts. I'm working in Batinda, Punjab. So how is there any ongoing evaluation of these initiatives being done, and so that we can learn what are the challenges faced and how to address these issues when we work with the district program officers in the community setting?
Okay. Thank you. So yes, evaluations, monitoring and evaluations are a part of all the programs of Government of India. So after the program launched, we had undertaken a system readiness initially across 17 states in the country to understand how much ready is our system for uptake of this national program, based on which evaluation, certain changes, certain support was provided to states as and when needed. Plus, we have our annual common review mission activity where teams visit to these states and assess all national programs, of which NCD is definitely one of the component. So you can also access these reports on NHSRC website. So far, almost 14 CRMs have been completed. It's an annual activity. So there also the team, it's a multi-sectoral team, a whole group of different people who visit states and districts and facilities till the community level. So there also these programs are assessed, evaluated on a routine basis, on an annual basis, to understand what are the challenges and concerns across the states. We also have regular state workshops. We have a regular review workshop with state, where states also reports their challenges. Plus, our teams on a routine basis, we visit field areas to understand how is this program functioning, what are the key areas, or where we need more focus, where the states need more support. Also, this is all what is happening so much on this, but and also at the national level, normally we have a review meeting on and off on a very routine basis. And we also are planning another evaluation because our the system readiness is already old now, and already all of the uptake is there now. And by December 2022, all 150,000 HWCs would be functional. So another step, as a next step, NPCDCS evaluation would be also planned, where definitely this population-based screening will be a component.
Regarding issues with the laptops, issues with the online this thing, we do understand because state has come up with these issues, and we also are having a meeting with Delhi with CPHC NCD application regarding the same. And I think I'll again not touch much on it because in next session I assume that Dr. Sunita will be covering these topics, that how they are facing these challenges across the states. And I also highlighted it as one of the challenge where unavailability of hardware or software, like no proper troubleshooting mechanism has been reported, where even ANMs are having problem in entering data, and we have some loopholes in terms of ICT mechanism. So maybe that would be discussed over there as well. So I would not touch more on that.
Excuse me, ma'am. There is one query from the online participant. She's saying clear job responsibility and work division between ANMs and community health workers are needed. So it is creating problem. That's the query.
So they're from which state?
No idea.
So maybe the more capacity building exercise is needed, because when training modules were developed, a training module for ASHA and ANM was developed for 5 days and 3 days respectively, with the concept that on the 5th day of ASHA training, ANMs would also be joining them for the same centers. So that there is a role clarity, there is a role distribution is clear. But states also needs to check, because many of the states did not do this team-based training. CHO when came later, there is always, when one cadre is being trained, we do have a concept of training them about the roles and responsibilities of the other cadre. How are they going to support? So, but then maybe state needs to do a refresher training, because we always say that refresher training should be an ongoing activity. It should not wait that once in 2 years or once in 3 years.
Thank you, ma'am. And the presenter is from West Bengal.
Yes?
The presenter is from West Bengal.
West Bengal, okay. Yes. Please do, because MPW curriculum has been revised last year. I think ASMD ki taraf se chithi ke saath it has gone to states. There are roles and defined. Maybe check with your state nodal officer. So that time Ms. Varna Gurnani ma'am was ASMD. So a letter with revised curriculum and roles and responsibilities has already been circulated. So just go through once, because it was a dying cadre, so it was revived with new curriculum, added responsibilities, and all these national programs. Okay, I'll move ahead. Otherwise, we'll keep question and answer round will go forever. So now I have covered this, so I'll just go just the different modules for each of these cadres. Where, as I told, ASHAs are more on health promotions, risk factors associated with NCDs, mobilizing community. Similarly, for her skills, we were only teaching her waist circumference, self-breast examination, and self-oral examination, so that she can mobilize community, or during her household visits, she can train them to undertake this regularly. For MPW, it was a 3-day schedule where we were training, in addition to ASHA skills, we were training her on a clinical breast examination as well. In some states, we said our guidelines said in later stage 1, MPWs or ANMs are very confident. They can do cervical cancer screening also in VIA. In some of the states like Tamil Nadu, even Chhattisgarh, they trained ANMs with the help of AIMS or other higher institutes, so that they can at least undertake the screening, and total handhold support was given. So ANM for staff nurse training, staff nurse were being trained on VIA, for which a separate 10-day module was developed to just train them on how to screen using VIA. These are the modules which are also available on our website. The CHO module came later on, and it will be soon uploaded. So far, these are uploaded on the website already. So convergence is already one of the components being highlighted at NCDs. We also encourage that not only we talk about tobacco, alcohol, but there should be an effective linkages of de-addiction centers and tobacco cessation centers when we talk about these components at the facility. We also have to talk about different departments, and even RK, SKs, and different, like not just NHM, but other departments which are working in at that level, to ensure that we work together as a team and nobody is working in silos for these components. I want to touch upon this because the earlier session was quite comprehensive and covered all the areas of research. And this also, as I said, the capacity building is a very important component. So states should develop the mechanism where this becomes a routine, regular practice, and not once in a year or once in 2 years they are doing this. Like we say that for ASHAs, they have their monthly meetings with PHC, MO, at PHCs.
Why not train them on a, do like a refresher thing for them on each of the identified topic at once in a 1 month, and it can be a part of routine monthly activities. Innovation and learning sites, as I say, these are the learning labs. We have presently 6 across states. AIMS is one of them, which are running in ILC in Haryana. So still we are figuring out to have a full workforce at those HWCs, because this may affect the functioning in future. We have to ensure that we have the full-fledged HR available at those centers, because sometimes there is one ANM, sometimes like with CHO, the functionality criteria is like if you have a CHO, it's functional. They have just one MPW who is not able to manage the entire caseload in the catchment population. Continuum of care has to be there. There have to be linkages across all facilities and not just limited to the facility the person is posted at. Complexity is there. We understand we need to, the innovation and research has to be a continuous process for understanding and evolving in this aspect. Like medicines, we discussed the medicines, we have to train, a CHO should be trained so well they're able to forecast so that enough supply is there. Addressing your question, that is very important. It should not happen that the medicines are not available at the HWC and we are not able to dispense when we know that we have a caseload for that common condition. Public health function, yes, we understand the lack of clarity of public health functions across CHOs. So government has also now started community health officers mentorship program with CMC Vellore, where we are going to further enhance their skills so that they emerge out as an effective leader at HWCs. Team spirit, as we already discussed, the issues regarding the role clarity, care coordination, because we see at times what happens from PHC, we hear that MO has referred a patient to higher center for a specialist consultation, but when that person visited or reached the facility, found that the specialist was not there at that time. So he or she had to come back unattended. So referral should not be linked just by referring somebody and just saying that our job is done. No, there has to be a facilitation as well, that when I am referring X person to a specialist, I should know that specialist is there at that time. And I know that the message is there that this person from HWC will be visiting your facility. So to ensure that the person is attended, and also when the person comes back, it's my responsibility to set up a follow-up for that particular individual. Community mobilization activities, we are working more on it to strengthen our VHSNCs and Mahila Arogya Samitis in urban areas, VHSNCs in rural areas, so that they are also mobilized, they are also trained to understand their role in health promotion. Also with the newer intervention called JAS, which is a Jan Arogya Samiti at HWC, NCD is one of the components they would be trained on, so that they are also equally involved as one of key stakeholders. Low uptake of IT application, as the query was already raised. So we have this issue in the next presentation. I assume that this will be explained in more details. And definitely we need to develop more capacities of our program managers to ensure that they are able to monitor program well, and so that we have an effective coverage of these NCD programs. Thank you.
Thank you, ma'am. Next, we have a session by Ms. Sunita Nadamuni. She is Global Head, Social Innovation Environment, Social and Governance, Dell Technologies. She oversees Dell's Global Social Innovation Strategy, driving technology-enabled social impact program to advance health education and economic opportunities for the underserved. Ma'am, you can present from your side.
Yeah. Can you all hear me?
Yes, ma'am, you are audible.
Okay. I first want to say that my colleague Akanksha is there. So she's there in the audience. So
yes, ma'am, she's there.
Yeah. Okay. And she'll be there also to answer any questions should they come up. Okay, just a second. I'm trying to find the right. Okay. Can you all see my screen?
Yes, ma'am.
Okay. Well, first of all, thank you to Dr. Krishnan and AIMS team for giving us the opportunity to talk about our role in engaging with the national NCD program. We are the technology partner. So Dell and Tata Trust have been working with the ministry for the last 5 years on supporting the ministry through technology for the NCD program. So I'm going to walk through a little bit about what we're doing, specifically how we're enabling continuum of care, and then we'll open it up for any questions. So you obviously have been talking and discussing this quite a lot, so I don't need to spend time on this. This is the national NCD program where we're doing population-based screening for 5 diseases for people over 30, hypertension, diabetes, oral, breast, and cervical cancers. So what has the technology journey been for us, for Dell and Tata Trust together? So we started our work, Dell started this work in 2013, working with an NGO called Karuna Trust. We did a pilot then worked with Andhra and Telangana. And since 2018, Tata Trust and Dell have been working with Government of India as the technology and program partners. So we provide the technology solution, which is a social impact CSR contribution from Dell for the national program. And Tata Trust is the partner for enhanced program design, workforce capacity building, and monitoring of this implementation of the technology solution. We have a dedicated team also set up for support at the center. Right? And this was developed with inputs from all the expert partners, including AIMS, NHSRC, DGHS, WHO, and several others, ICMR institutions. So we started in 2013. Since 2018, we've been working with Government of India on the NCD program. Today, we have more than, in March, we had about 10 crore enrollments. Now with Gujarat also added on recently, we have 21 crore people digitally enrolled across 32 states and UTs. A few of the states in the different color are using their own application, and about 5.63 crore people over the age of 30 have been screened for these NCDs. It's running in about 593. The software is running in about 593 districts, and 1.5 lakh personnel have been onboarded, and close to 1,96,000 people have been trained. Like I said, it's implemented. It's a large collaborative effort. It's probably one of the largest public health technology solutions because it's population-based. Many other programs are targeting a particular audience, right? A particular segment of the population. It could be pregnant women, it could be children under 5, TB patients. All of that is a smaller segment. Because this is entire population over the age of 30, which is 37% of the population, it's a very large program. And therefore, it's running a technology solution for something this large is obviously a huge number of complications and complexities. So we have a lot of experience. I'm not going to focus on that specifically, but even the design of the solution and the requirements and how do we implement it as per the guidelines was done in collaboration with this ecosystem that I just mentioned: NHSRC, AIMS, WHO, Dell and Tata Trust, ICMR institutions, NIC for hosting it, National Health Authority for the new NDHM, and CCDC. So what is the CPHC NCD IT system? Basically, if we look at the entire health system, each of these colored circles that you see is one user, one stakeholder in the health system, right? Starting with ASHA at the village level, the ANM CHO at the subcenter level, the MO and staff nurse, and the other staff at the PHC level, specialists and nurse at the NCD clinic or the CHCDH level, and then the administrators at the district level, block and district level, state level, and then the overall program officials, the ones who are decision making, running this program. Each of these are stakeholders with a very key role to play in running the national NCD program. So when we created the technology solution, we looked at this as the entire the health system, the entire health system, and said that how do we have a threefold objective that's there on the right hand side. The first key objective is how do you achieve, help support continuum of care for the patient, for the individual. That is, every individual who starts their journey, they go to the end of the journey, basically treatment management over time, right? And without dropping off in the middle. So that continuum of care for the individual over time is very important. Second, productivity and quality for the care providers, from the ASHA, A&M, everybody who's providing care. How can we support them with technology in terms of standardizing care quality, task shifting, protocols, reports, just reducing their, one-time entry. If they enter the patient information, they can get that easily next time instead of re-entering. And then finally, for the people who are running the program, how can you support evidence-based decision-making, giving them data about how it's actually running, starting from, with data being collected at point of care, right? It's not aggregate data being reported, but actual individual level data that's being collected. So through dashboards, analytics, how can you ensure that the people who are running these programs have all the information they need to be able to make decisions about improving the performance of the program, right? So this is the threefold objective. So what we have mobile apps for the ASHA worker, for her to do population enumeration, enrollment, and risk assessment. At the A&M level, CHO level, we have, basically they do NCD screening and they do follow-ups and referrals. So we have mobile apps and tablet apps for them. They can also enter it on a portal if they have their laptop. And the blue circle, that's for the PHC, and that's where you have the MO and the staff nurse. For them, we have a mobile app and a desktop app or a laptop app, right? And there we're assuming they have connectivity. In the first two, we assume that they may not have reliable, regular connectivity, so the apps can be used offline. Whenever they have connectivity, they can sync it to the cloud, right? But the MO PHC level, we assume they have connectivity. At level 4, the green circle that's for the CHC and DH level. It has more obviously advanced information that they need to capture and diagnosis and treatment that they do. And 5 is for the administrators. The administrator portal will allow them to onboard users, make any changes. An A&M has been transferred to another subcenter. Somebody's mobile number has changed. This village actually belongs to that subcenter, not to this subcenter. All these changes they can do. Right? They don't need to keep coming back to the Dell or Tata Trust team. They can do it themselves. And finally, for the program officials, all the dashboards. And I'll show you some screenshots of that. Right? So this entire thing is the CPHC NCD IT system, and it is sitting on a platform on the cloud. Right? That's called the cloud. It's sitting on a platform on the cloud. And what that means is that there is continuity of, the data that's captured here can be seen by a user here, of course, with all the right permissions. But because it's sitting on the cloud, any user can access with permission, can access the data that's entered by some other user, right? So this gives you a tremendous flexibility and visibility across the referral workflow. Okay. So how is this particular, so we've developed the software, then what? Obviously, software is no use if it's just developed and just, not deployed effectively on the ground. So Tata Trust is a program design, implementation, training, monitoring, upskilling partner. So they do what is called, cascade, field training, cascade training, and then field tiered support. Cascade training is basically, once we have a new version of the software or whatever, then, or a new app, they will train all the master trainers from states and districts, who will then go and conduct training to the actual end users. But sometimes Tata Trust also supports in that. It could be even 2 levels of that. And then the end users are actually using the software. So that's the cascade training. And it's pretty robust, because what I mean by that is that, they don't just walk in and say, okay, we're going to do the training tomorrow. There's a lot of work that needs to be done up front, right? Making sure that everybody, all the devices are procured, all the master data, which means the IDs for the facilities, the IDs for the users, all that is prepared up front. All the mobile numbers are there because you need secure OTPs to log in. So all that prep work is done first before you can actually begin that training, right? And then on the support model, it's again a tiered support model. So on the field, they would be people, it could be the people from the supervisors at the PHC level, the data entry operators, or whoever, is trained to provide the immediate first level support, or it could be a Tata Trust person. There's also call center, so people can call the call center for support. And if they are not able to resolve it, then it goes to the National IT TSU, the Technical Support Unit. And there you have the people who are running the application in the national data center. It runs in the BSNL, the NIC data center. So they are there, the technical support unit, to manage the deployment and also to answer more tougher technology questions like, this particular, there was a crash in this particular sync didn't work. It looks like my tablet doesn't have the right account, something that's more complicated than the base level. Right, so they handle that. If there's an actual problem with the software or if there's an enhancement needed, then that comes up to the engineering team, which is Dell, based in Bangalore. So this is a tiered support model. So using all of this, about 96,000 people, health workers and doctors have been trained. And still, as national IT projects go, this is still relatively early stages. It's going to take a while to mature and to stabilize. Yeah, so that's basically just the summary of the overall what is the software, who all have, how we worked on it, where it's deployed, how it's deployed, who's providing the support and training. Now I want to spend a few minutes talking about how this system specifically supports continuum of care. If there are any burning questions, I can take them now. Otherwise, I can finish the presentation and then we can answer any questions. Okay, let me continue. Okay, so how does it support continuum of care for NCDs? Because that is the goal, right? That is what all of us want. We want to be able to make sure that the patient has continuum of care. So we'll talk through a few specific sets of features that are enabling it, right? One is, first, the apps are designed for low resource settings, meaning they can, first point in the one in blue, they work in offline mode, right? Meaning only when there's connectivity, they can sync. Otherwise, if they don't have connectivity, they can still continue to work offline. That is for the ASHA and the ANM. Second, it's supported in 11 local languages. We don't expect that the ASHA and the ANM and CHO are going to be using comfortable, all of them are going to be comfortable using it in English or even just Hindi. So it is supported in 11 local languages. It enables task sharing and task shifting, right? So some of the things that, I think Dr. Nikhil Tandon would have spoken at an earlier session about the clinical decision support system, but that's a good example of how task shifting is being enabled by providing support to the staff nurse, who can then take the recommendations and then share them with the doctor, but she can do the preliminary work, right? This minimal data entry required. So mostly we've tried to keep the data entry to minimum. So mostly people can, do, touch, drop down, swipe, all pictorial, trying to keep it as simple as possible. And then dashboards is not something that's available going upwards to the senior decision makers. Dashboards are available at every level. ASHA has her own dashboard, ANM, CHO have their own dashboard, because every user needs to be able to understand their, what their targets are, how they're performing, what they need, what are their tasks, what they need to do. So these are some of the key sets of features. We're digitally enabling continuum for risk assessment to management, right? So some of the key features that are enabling that, I talked about it a little bit, but I'm going to go through some detail. First is the ABHA ID, right? The Ayushman Bharat Health Account, the ABHA ID. That unique health ID is absolutely critical. That's kind of like the central thing for continuum of care, because then you're saying that this person has this ID, whichever facility they go to, whenever they go, whichever disease they go for, right? And that's really important, so that if the person has gone to a DH and they're getting diagnosed by a doctor there, or if they've gone back to, they were at the ASHA who's doing a risk assessment, the health ID of that individual is the same. So it's always the same health record that's being pulled up. I can't emphasize enough how important this is, right? Second, we are enabling the capture of data at each of these levels, like I said, so that, and these are all compliant with the Government of India guidelines, so that now the data that's captured for screening by the ANM is visible to the doctor at the PHC or CHC, right? It's also based on the guidelines for diagnosis and treatment, NCD guidelines that are published. So that's why we worked a lot with all the expert committee and the partners to ensure that we're compliant. And this whole referral and follow-up, this I think is really key, that many times there are IT systems that will say, for the ASHA worker alone, or for, a hospital, or for a primary health center. The challenging thing has been to say that this will allow, there are apps for every level, right, for all these facilities, and they're all synced. They're all, looking at the same data center, the same data that's in the data center, same platform that they're all talking to. So I think that's been extremely key to continuum of care. Right. Now, a little, showing you some of the screenshots for each of these stages, just to give you a sense. So for instance, there's this, I'm not sure how clearly you can all see, it must be pretty far away, but Mithali Devi is the woman, let's say, who's been enrolled here. And even the risk assessment is done by the ASHA. And then the screening for that same person. So the ANM can also see whatever the ASHA has entered. And then the ANM can do the screening, for hypertension, for instance, she's entering the BP, the pulse rate, she's taking some medical history of that person. Has that person been diagnosed earlier? The examination, if the person is referred up to the doctor, same individual, Mithali Devi, referred up to the doctor. The doctor is then, let's say the person was referred for diabetes. The doctor has opened up the screen, pulled up the person's record. They can see what the ANM has entered. They can enter the blood sugar levels, and they can get immediate inputs based on the government guidelines that, okay, if this blood sugar is this high, then this is probably the diagnosis. Again, it's a recommendation. Obviously, it's up to the doctor to override that or make their own decision. But it gives the recommendation, and also the recommendation of what are the medicines that are prescribed by the government and by the state, right, for that particular disease. So all those are, built into the software. And then, so this is where you would see the treatment information. And also the follow-up is, so for instance, metformin 500, let's say, is entered here, and the follow-up. And the counseling the doctor must do, and that is also entered here, and then the follow-up. So this entire thing available at each level for each of the users. Right? The beneficiary can walk into any facility, the health provider can search. So even if, let's say, the ANM has referred the person, or let's say the PHC doctor has referred the person to the CHC, but for that individual, for Mithali Devi, the DH, the district hospital, happens to be closer to her house, she might walk in there instead of going to the CHC. Person has a freedom to go anywhere, right? The doctor there can still pull up the record based on the ID. So these are the critical elements that allow continuum of care. Another important feature is referrals that can be tracked using work plans. So we'll give you, two examples here. Let's say that the subcenter has, the ANM or CHO has referred the person to a higher facility, but it's been 30 days and the person hasn't shown up at the PHC, right? That will show up in the ANM, the ASHA's, the ANM's tablet under, general follow-up, priority follow-up based, and I'll talk about those later, but it will show up as a person was referred and didn't reach, right? So that's an important thing. So she can actually check and say, and same thing for a follow-up. The person required a monthly follow-up, they didn't go, that will show up here as an action item, and the ANM can look at that and say, oh, how long has it been since that person has missed their appointment, and then follow up with that individual, or ask the ASHA to follow up and close it. So this is really important. If she's looking at 5,000 people, or obviously a small subset of those who are over 30 for this program, the ability to get these work plans to say, these are the individuals that need to be followed up, these are the individuals who missed this, these are the people who've been enrolled but haven't been completed their screening, all that is very, very useful for the ANM and CHO. Similarly, the PHC level, let's say a bunch of people have been referred to the PHC, the doctor there can see, who are all the individuals who referred. So the doctor also has, the MO will have their own work plan. These are all the people who have been referred for this particular condition, right? And if the doctor MO refers somebody to a CHC, but that person hasn't reached the CHC, again, the doctor will know that, right? So they can select the status. Who are the people referred to CHC by PHC, referred to DH by PHC, and they can look at that list and then see who hasn't reached and then take action. So this reference using workflow work plans is like a very important feature. Then the monthly follow-up due list, right? Now let's say that somebody had a follow-up visit, but the BP was 140/90, right? It's uncontrolled. They're on medication, but the BP is not under control. They will show up under priority follow-up, right? Which means that they need to be followed up. It's very important for them to be followed up. General follow-up is, yeah, the person had their follow-up, but they were BPs under control. So good, that things are on track, right? And then this is how they would enter the follow-up. During the follow-up, this is how the information would be entered, right? What is the medicine? Because they might come there to pick up the next, set the medicine for the next month, right? So that is entered. What are the vitals and the counseling? Yes, has it been done? So all of this is great. It's all done. But once this is done, how is actually being monitored in the dashboards? Because the MO or even the district officials, they can't go looking, at individual line list and go individual by individual. Is it done? Obviously, right? So they have to look at comprehensive dashboards. So yeah, I talked already about this, how this is just actually about the follow-up, how they can search for an individual either by name or by subcenter and village or by ID. You can search by multiple ways and then select which individual and then open up their record, right? And this is how it would look in the dashboard. So here, for instance, this is what we call the continuum of care funnel. At each level, these are the people who've been enrolled. This is the target population over 30. How many out of them, the first is the total target population. Next, out of them, the population over 30, that's this beige line. And then out of them, how many have been enrolled? Then enrolled 30 plus, right? Of that, how many of them are over 30? Then the green one is of them, how many are screened? Of them, how many are referred? Of them, how many have been examined, diagnosed, under treatment? Finally, how many of them are doing their follow-up? Like in the last 30 days or whatever, have they had that follow-up? And out of that, how many of them are under control? So if you look at it, this is the holy grail that we want, right? We all want to know if for the people who have their NCD, are they being, not just were they screened, but everything to the end, are they being followed up, and is there hypertension, diabetes, whatever, under control? So this is available in the dashboard, both as a graph and as numbers. And then again, at a higher level, lot of different features, for instance, disease wise, you can look at the trends, what is happening over time, right? May 2021 to April, this is all not real data. But just to give you guys a sense of this, but for hypertension, for diabetes, what is happening, what are the trends? For instance, if you look at CBAC, what are we seeing, of the individuals, if you look at attributes, tobacco usage, alcohol, how many people are, how many people have a family history, how many people are not entering the data. So all of this information, distribution of risk factors, socio-demographic parameters, all of that is available. So we have a very advanced dashboard that we've developed with lots of different features for people to be able to use. Right? There's also SMS new feature. It's been there, being deployed in stages, but currently the three features, that three SMS things. One is a reminder for screening, right? If somebody has been enrolled but they haven't completed the screening, they get a reminder. Then another is a reminder for annual rescreening. As Neha was talking, people will do their, all the guidelines that she mentioned, right? That hypertension, diabetes, annual, cancers every 5 years. So those reminders will also go out. And if somebody had they were referred, then a reminder to complete the referral visit, right? So these, a lot of studies have shown that SMSs will improve compliance. So that's something that, and these are examples of how the SMSs would look. Yeah, I know I kind of went through quickly, but happy to open it up for questions. And I think Akanksha is right there. So Akanksha, if you could also maybe stand up and come to the front and, you could answer questions that would be in person, it might be nice. Akanksha is based in Delhi and, has apart from being a part of our product team to actually develop all these requirements, also liaises with all our Delhi, with the government and all our partners, and manages the deployment in a few states. So really has end-to-end knowledge of the entire program.
Ma'am, I have two questions. So this software is same as that of NDHM, or is it something else different from other? Because I see all the 5 components of NDHM is included in the software. So is it same or?
No, so this software, this IT system is being developed specifically for the NPCDCS program.
for the 5 diseases: hypertension, diabetes, and 3 common cancers. What NDHM has and does is much larger. So they are looking at a unique patient health identity. They are looking for registries, provider registries, doctor registries, and looking at PHR apps, HIP. So that is separate. The NDHM program is managed by National Health Authority, NHA, while NPCDCS comes under Ministry of Health.
And one more thing is that you said that 21 crore people are enrolled in this app. So which is really astonishing. That is really like the 15% of the Indian population. So do you have any data among that 21 crores? How many are actually suffering from NCDs, or how many of them are healthy people just screened for?
So, yeah, I can take that. Yeah. First of all, as since this is a government program, then we don't really talk about these. This is not in our purview to share all the details of the government data. In terms of enrollment and screening, we can share that. Right. And also the other point that I wanted to share earlier. So screening, I think we have 5 crore people, because enrollment, by the way, is not just, while the NCD program is targeting people over 30, the enrollment people have done at like a community, the entire family in many cases has been enrolled, right? So the target population for NCD screening is much smaller than the enrolled population, and the actual population screened has been lower. So what we are looking for the higher adoption at higher levels of care. So this is, like I said, still in early stages, but yeah.
Thank you.
Ma'am, how many states are using this ASHA application? ASHA app, mobile app?
ASHA
how many
mobile
states
apps
are currently using?
Currently used by 2 states, because it was also launched during like the first wave of COVID, actually 2020 we launched, and after that Rajasthan and Karnataka started adopting the ASHA application. But we have almost 80,000 ASHAs which are using.
And in this application, screening application, in the medical officer login, do we have the provision to do entry FBS and postprandial values? I mean, for diabetes.
PBS and you're asking?
FBS.
Yeah.
FBS.
Yeah.
Blood sugar.
Yeah, that's available. Yes.
Yeah.
So there are provision for both value entry.
Yes. Including HbA1c.
Yeah.
I just wanted to know, this is just a stray question. So are you using these applications for any kind of analysis, secondary analysis? And you said that they're in 11 languages. So whichever is the central server, do you again retranslate, like how do you, or is it just the question numbers?
Yeah.
Go by the codes?
Good question. So the data entry is not in different languages, because that is a very, very challenging thing. And anyway, we've also limited the amount of data entry, but the labels and the messages for using the app, those are in different languages. So the data entry, whatever they enter, the drop downs and all that stuff, the minimal typing they have is only for like the name of the patient, very few areas where they actually enter type stuff. So that's in this thing. And the other thing about analysis, it's not very high. So there is some amount of usage of the portal by states when they are doing campaigns, right? So they use the dashboards a lot heavily. So let's say a state is doing a campaign for NCD screening, right? Then they use this very, very rigorously. But is it being used for very, much deeper analysis? Not yet.
But for routine NPCDCS monitoring and all, yes.
Monitoring, it's used heavily.
By district and
quite heavily. Yeah.
Ma'am, my question is a bit radical one. I want to ask that the cloud storage of this data is with the Dell or with the government of India?
No, not at all, not at all. That's why that was a very important question. Thank you for asking. But I thought I also made that clear in the presentation. This is completely a government program. This is a social impact initiative of Dell. So we are contributing this open source software to government, and it is running in the government data center. The data belongs to, citizens and government. Dell does not in any way own that data at all, right? It's a production system. It's run inside BSNL. There is a separate team that looks at the production system, not us.
I have a follow-up question for the same thing. Like Dell is a US-based company and it is investing as a CSR initiative with Government of India. And you said that you are going to send 6 follow-up messages to the beneficiaries. So is it possible that Dell can anytime access that data and send any sort of?
Let me just, we are not sending anything, right? It is messages that are coming from the government data center. Again, I really appreciate you asking this question because it's so important that everybody understands this. The SMSs are coming from the NIC server. We don't even have a setup to do this. We only have a development team that sits in Bangalore that is developing the software, right? But it is the software runs in the government data center. The SMSs are sent from the government data center to the individuals. All of that production system is in the government data center, right? And there are government teams. So NIC, all of them are very,
I was about to mention that. So that government data center is managed by NIC and CHI, Center for Health Informatics, which comes under Ministry of Health.
Thank you, ma'am.
Ma'am, I have a question. Like, you said the people who are like people can be tracked, but how are the provisions in the software enables reaching out the exact location or exact patient? Like, is there any facility to download the list of people who are not properly following up, or is there any facility to identify a cluster of area? Like they, for example, in a PHC, there can be 100 patients. Any facility to find there is an area in which most of the people are there, is to find identify any clusters?
I couldn't tell. This was breaking up a little bit. Akanksha, do you want to answer or do you want me?
So I think what you are asking is sort of tagging maps. So no, we are not there yet. We haven't done that kind of analysis.
But are you asking about GIS, like, mapping locations where people are? See, the thing is, that's not really at the person. The people doing the follow-up are the ANM and the ASHAs, right? And we know which village that person is because that happens as a part of enrollment. A person is from a village. So beyond that, it's not needed. The ASHA will know who that individual is and will follow up with them. If I understood your question correctly. How does the ASHA, the ANM?
The line list is there, but yeah.
Ma'am, here. This portal seems to be similar to IHIP, Integrated Health Information Platform under IDSP. Then, like, if it is similar, then why not use IHIP? Why, like, it is creating such a confusion for like many portals for many diseases, other diseases, and in our PHC, like in UP, I don't think they are using this. And they are using simple app for hypertension exclusively, and they are not using this. So why creating many portals for different things? Why can't we integrate?
Yeah, that is that's much more complicated question than we can answer here. But I think that what you're raising is a very important point, the fragmentation and the challenges there. But that is the reality, right? In a very diverse country, different programs. Forget just center, right? States also will have their own program. They have their own software. And so the short answer to this is NDHM is really an important, we're looking at that as a very important pillar that will enable interoperability, integration in a seamless way, right? So the health ID is a very important thing. Then NDHM, the health information provider, health information user are those frameworks that they've set up for consented sharing of data will be the mechanism by which you will allow innovation, different people to develop different apps. That's the thinking, right? That there should be innovation, there should be ability for people to develop different apps, but that sharing should be seamless. sharing of data. But again, this is a very real issue, and I think we're in the early part of the NDHM integration journey also. But that's the bigger thinking.
Facility to refer the patient to the health wellness center, or like he gets registered at a district hospital, but ultimately our aim is that the patient gets the medicines from the health wellness center. So are we referring him? Is there any change in the assigned facility or where he is actually?
No, so actually, even at the district hospital, if a patient visits, when you capture that patient details, you always enter his village where he belongs to. And based on that village mapping, the subcenter and HWC automatically gets mapped to that individual. So if the person actually gets diagnosed, then the further follow-ups, etc., automatically get generated and can be seen by that HWC. You don't have to refer. Once you enroll, it automatically happens. You're talking about downward referral, right? Yeah.
How do you prevent duplication of patients
So again, yeah, for duplication, actually, we've given a lot of features. So one is, again, like through trainings, we are reinforcing this to always at the higher facility, because there is a higher chance that the ANM or ASHA may have already enrolled the patient and now the patient is visiting a PHC or a CHC. So the protocol is to always search for the record. You either use a ABHA health ID, which we have generated for a lot of individuals now, or you can use their mobile number, or you can actually search by a combination of their name plus village, and draw up a list of individuals will show up on the app, and then you sort of take action on that app. And plus we also have provisions in some other, like in a couple of apps, where if you enter the same name plus gender plus age combination, the app will also throw up an alert saying this is a potential duplicate. No, you can access patients outside the district also. The wider list, yes.
We have raised many of the suggestions for the development.
Yes. Okay, so you're from Gujarat. Okay. Yes, sir.
Have you any planning process to develop that suggestion, whatever we have done?
Sir, I think anything in particular that you want to call out, because
basically for monitoring, we haven't access of the name and everything at the
line
state
list.
level, even at the district level. So,
yeah, sir. So that line list we are provisioning for in the next release itself at the district and state dashboard level. You'll be able to download that line list of individuals, including health ID and certain format. That format is actually getting finalized with NHSRC and the ministry, but we have already started work on that, sir.
are you mapping up with the ASHA's ID, or still you are mapping with the village ID only?
Right now, it's still that individual is still mapped to a village. We can take a look if you want to sort of map it to ASHA ID and have an ASHA mobile number next to it. Yeah.
Because for the incentive to the ASHA,
Yeah.
that is a
Yes.
major problem.
Okay. We'll consider that, sir.
My question is just, it's a corollary to her question, that if there is a duplication, what do you do to the subject? Do you down referral, or is the candidate taken up there itself? If there is a duplication, like if the records already exist, so the entry just you have to keep entering on the old application, or what exactly happens?
You are talking about a scenario in which already duplicate was enrolled.
So
Okay.
I'm just curious, does it cause some kind of delay, or for the subject or for the candidate who has come for seeking
No.
services?
Again, we have not seen that, but and what happens, everything is like post facto. What we can do is like the ASHA or the health worker gets a list, or let's say a district administrator gets a line list, and they can figure out these are duplicates. Then the list can be sent to the technical team to resolve. But otherwise, on ground, services will be given to the patient. Nothing stops NCD services.
Ma'am, you said that NDHM is managed by National Health Authority, and may I know, can you clarify my doubt whether your project is government funded or it's private?
Do you mean the NCD program itself, or do you mean the software development, or what?
Is it supported by government, or is it private developed?
No. So that's what I mentioned. This is a CSR initiative. So we have developed this as a social impact contribution. It's a pro bono, free software that we're providing to government, right? The software development. There are many aspects to it. Tata Trust is a NGO, as a philanthropic organization. They are providing the training and support. Again, it's a pro bono thing. There is no financial arrangement between us and government, between us, Tata Trust and government. We are all providing this for free. It's hosted in the government infrastructure. NIC is managing all of that, CHI. And the devices and all are procured by government. The staff is all government, right? So there are many, did that answer your question?
So in future, whether Tata will be the software support for the NDHM program, or is it an attempt to gain the tender? So I'm just curious.
Sorry?
No, could you repeat that?
Could you repeat that?
Is it like in future whether the Tata will be providing software support for the NDHM program, or is it an attempt to gain the tender?
No. So Tata Trust does not provide support to NDHM program. I think you may be coming from the health IDs that we have also integrated. So what we have done is for the CPHC NCD system is integrated with one service of NDHM, which is to generate a unique health ID for individual. And Tata Trust provides training on this NCD software, not on NDHM.
Yeah, there is no connection to NDHM with this, except that NDHM is a software that is a platform that all software systems in health are working to integrate towards. Right? All IT systems are integrated.
I mean, Dell is trying for early integration with NDHM. That's why I got this doubt.
Early integration?
We have already integrated.
We've integrated health ID for CPH, for the NCD system. The government, this NCD system, health ID is already integrated with NDHM.
So indirectly, Tata is providing software support. That's what you mean.
Tata but provides software support for the NCD.
Not for NDHM.
Not for
this
NDHM.
Is only, we're all engaged only on the NCD program, the national NCD program.
We integrated with NDHM through which the IDs get generated on NCD system.
But there's no.
When you are enrolling a patient on the NCD system and you are entering his name, gender, age, you get an option, you can generate ABHA health ID. So once you click on that, on the back end, like a call is made to NDHM server and they return the unique ID and we store it.
So like all other IT systems, we are users of the NDHM, all the, all IT systems are using the NDHM system to generate health IDs as per the NDHM platform.
So you are saying that you're working specifically for NCTs, but so you mean ABHA ID is specifically designed for NCT or?
No. ABHA health ID is common. No, it's supposed to be unique ID for any individual. You're supposed to have a longitudinal health record linked to that ID, whether you go for NCTs or whether you go to a clinic for some other service. The idea is that all your health record gets tagged to that ABHA health ID. So in fact, like all programs, so you have the tuberculosis program, they will also use NDHM services to generate a health ID for Nikshay beneficiaries. So our systems are just an entry point for that health ID. After that, any system can use it.
Yeah, every program will be using it, like RCH, all both public, private, everybody is using NDHM to generate health IDs.
Yes, sir, true. We have integrated that way only using APIs.
What I would like to say, if someone is generating his health ID through NHS software, someone is generating his health ID through our software. Is there any linkage between these two?
So, sir, on our software, because it's a government program, we only allow health IDs which are Aadhaar based. So the individual enters Aadhaar. So automatically, if anybody has generated your health ID on NHA website using Aadhaar, they always return the same health ID.
But for a EPSC portal, is there any tag with the ABHA ID? EPSC ID is there.
Yes. Yeah. Back end we maintain a mapping. Yes. Our enrollment ID, which is a CPHC ID, it is tagged to the ABHA health ID. Not for all, those who were generated using our system or linked on our system. Not for all. Otherwise, sir, we cannot unless somebody has to link it to that NCD record.
even though in NDHM.
Online question. Ma'am, can you answer that? What about the patients who are going to private hospitals?
So currently, this system, as per government guidelines, is only built for the public sector facilities.
Patient taking treatment in the private sector and coming for a measurement of a BP or a blood sugar or to a public sector, are such patients enrolled in CPHC or not?
Yeah, everybody, nobody's turned away from the public facility. So it doesn't matter where they're getting treated or whatever. If they come into the public facility, then they can be enrolled, they can be followed up just like anybody else. But is the software going to go and check, used by private facilities? No, that's not happening. Thank you.
If we have no further questions, then we can end this session. Thank you, ma'am, for a wonderful session. It was, I guess, one of the most interactive sessions of the day. A lot of questions and answers. So thank you all. So
Thank you.
Hello. Hello. Next session is by State Program Coordinator, Dr. Jagannath Reddy.
Mr.
Sorry, Mr. Jagannath Reddy.
Thank you, Daksha. Thank you, Anand sir, for inviting us and WHO for sponsoring me. So I'm into this health department, health system from 2009 onwards. So there are a few initiatives which we have taken up in our program. So the first slide shows how the state NCD cell functions. We have included all programs of NCD excluding NPCCHH into our fold, and we are looking after all these 10 programs. Then you all know, because much is talked about this process flow and everything implementation. So this is where our state team is there. Like state NCD cell, we have Dr. Madhvi, Chief Program Officer, Dr. Pushpa, Additional Director, Dr. Shravan Reddy, Cardiovascular Health Officer from WHO, who looks after IHCI, but we have made him part of all our programs. Myself, Jagannath Reddy. Only initiation I wanted to talk to you about is the district NCD cells. So let me be frank with one or two issues Please apologize me for this. When I joined as district program manager in a district called Medak in 2009, the first initial reaction response, everything was like, "Arey, wo NHO wale ko bulao." Even the district medical and health officer attendant used to say that, "Arey, wo NHO wale ko bulao." It took 1.5 years for me to prove my capability. And when the district medical officer himself calls me on over phone saying that, "Reddy sahab, aaj aap office aa rahe hain kya?" So it took 1.5, 2 years for me to prove something. So when I've joined as a state program coordinator in 2018 and we were initial stages of NCD screening, I've requested our MD ma'am saying that, "Madam, don't go for the recruitment of district program officer NCD, district program coordinator NCD." Then she said, "Why?" And I said, "It takes 2 years for them to prove their will and capability. By the time golden time is missed." Then she said, "What is the next option?" Then I said, "There are many young doctors who are enthusiastic from the regular cadre. Please identify them as district program officer. And there are very active supervisors with internet computer skills and knowledge. Please identify them as state program coordinator. And make the already NHM unit is there in the district level, which is headed by district program officer NHM. There is a district data manager NHM. There are so many people who can assist the district NCD cell." Ma'am was little apprehensive. "Nahi, when you are getting much of HR." Then I said, "It's not the problem of HR, ma'am. It's the problem of implementing the program from day one itself." And we are right. That has proved a very good initiative. Like we've started our initial enrollment in Government of India application, and whatever 5.62 crores what Sunita ma'am was saying about screen, 1.08 crores was from Telangana. We have a target population of 1.37 lakhs and we have screened 1.08 crores, and there were issues with urban centers where we had. So all this just with one initiative, making the active, enthusiastic medical officer as district program officer and a tech savvy or computer knowledge supervisor as district program coordinator. Then this is what our first round screening details. In fact, in spite of doing this best, we are unable to do annual screening for all the people. So 3 years. We started in 2017 December, and on February 20th, we were able to screen about 1.8 crore population, and our total screening percentage was only 80%. And it took us 3 years to do that, 2.5 years. So it is not easy to do it on an annual basis. For record's sake and for saying it is easy to say that every year so you are supposed to do the screening, but it is practically difficult. Then out of which the prevalence of hypertension, this 9.5% prevalence, see what WHO reports and all other reports say that 20% prevalence is there in Telangana. But what we were able to digitize with the name, Aadhaar number, mobile number is only 9.5% population of hypertensives are registered with us. We have all their data with us. Same case with diabetes, 4.3% in the first round of screening. Gap in screening, as I told you earlier, it is in the GHMC, Greater Hyderabad Municipal Corporation and other urban areas. In rural areas, we are able to complete screening 100%. Then, as I said, 12.96 lakhs hypertension patients details and 5,94,000 diabetic patient details. They are registered with us with their all details. And these are the state specific protocols, thanks to the support of IACI team, which is working in 20 districts of our state. And we have 5 cardiovascular health officers in addition to the state cardiovascular health officer who's working at the state level. And we also have 20 STS supported by WHO under IACI. And this we have designed in 2019 when we had issues with Government of India application. Like the data access, as Sunita ma'am was saying, still the data access is not available. No one can see, get the details. So we have designed this card like it is in my hands. So what we thought is when we have manually registered all hypertension diabetes patients and we have digitized. So we thought, let us give them a card so that they can get the medicine or they can get the treatment at any facility which they go. So we have given village number, subcenter code, then 3 digits for the patient ID. There's a unique, with this card, if they go to anywhere, they can get medicines. If, for suppose, and this counterfile will be with our staff nurse who's sitting at the PHC. So she checks whether every month, this is useful for 3 years. She checks every month that whether she turned up either to the A&M or to the facility to check the control rates. So this is what we have started. And reporting system, everything we have put in place that I was mentioning about IHCI. It started in November 2018, and most of the people are supporting the state administration in the implementation of this program. And this is more critical. Usually, I'm sorry, as I said, I'll be very frank. Usually, the private practitioner at a village who's a quack, non-qualified, people still believe him. And first word of that private practitioner to the beneficiaries in the village, सरकारी दवा है, ये क्या काम करेगा? सरकारी दवा है, काम ही नहीं करेगा, मत लो, मत लो. It took us a lot of time and pain in convincing people to take drugs from government facilities. Sorry, I don't know whether I can mention it. Pre-COVID, it was only 25-30% in government, I mean, utilization of government drugs, hypertension, diabetes medicine. Post-COVID, it has reached up to 58%. Because our A&Ms, we have started decentralization of drugs. Our A&Ms have gone door to door during the lockdown period to give drugs, hypertension and diabetes drugs. Telangana is the first state to initiate this program. So door to door, we have gone and we have given the drugs, and 58% was the utilization during the lockdown period and COVID. So with this, and another important step here is ensuring that continuous supply of drugs is met. Thanks to all the commissioners who worked at our place, they have listened to us, and we always have 6-month buffer stock at the state level. I mean, and once it goes below 6 months, we start indenting. So that even the supplier has many reasons, even though it is from the date of purchase order, it is 90 days for supply. Usually it doesn't come in 90 days. It may take 4 months or 5 months, but we are able to ensure a minimum of 3 months drugs at the PHCs before the second lot, the next lot comes to the district central medicine stores. And initially when getting the information from PHCs was also difficult. So we have created Google spreadsheets wherein even every medical officer, every supervisor who's working at the PHC is capable of entering the drug detail data by collecting it from the A&Ms. And this is how we calculate our drugs. So by using this, so this is CMS's central medicine store. We have only 10 CMS in those CMSs and including DMHO office. So Sangareddy, Siddipet, Medak, we have only one CMS, but there are 3 districts who are getting medicine from these CMS. So we list it out, how many drugs are, total number of STN patients who are registered with us taking drugs, and what are diabetic, and this is the calculation which we do. So that it gives us access and clear-cut idea about what, how we are, when we are supposed to procure, how we are supposed to procure, and how to prevent stockouts. As I said, during COVID, because we delivered 58% of total patients, and it was less than 30% pre-COVID. And this was reported in WHO portal. Latsamma has become a national heroine with this report. Like our A&Ms go to door during, and they have delivered it. And this is the treatment card given to them. And another important issue I wanted to highlight here is procurement of digital BP monitors. We have toiled like anything for the last 3 years to finalize a digital BP monitor. Government of India allocated money is about 2,000 to 3,000 rupees, and you will not get a professional digital BP monitor. 5 times our corporation has gone for the tenders. Every time, even though specifications were given, everything is given. Bidders have come and they have filed, and in those 5 times, nothing was a professional digital BP monitor. We have been continuously fighting with them. Finally, we have recently tender has been finalized. Probably Telangana is the first state to procure state-of-art digital BP monitor for all the A&Ms. We have about 9,000 A&Ms working at field,
and also the facilities, 636 PHCs and 238 UPHCs, 101 NCD, CSC NCD clinics, and 33 district NCD clinics. Probably Telangana is the only state where we are procuring digital BP monitors under NPCDCS program, which is costing us 10,200 rupees. Omron professional model with the annual warranty for 3 years with on-site replacement of 72 hours. We made it mandatory for them to keep some buffer stock at the district level. The company should keep at least 10 digital BP monitors at the district level so that it is replaced within 24 hours at the district level, and the team should replace within 72 hours. That's, we put it as condition. That is the reason no bidder was there in first 4 bids. So this is another initiative from our state. And as I said, decentralization, NCD drug pouch. This I was showing it. Usually incentives, TB diagnosed patient gets incentive. In Telangana, maternal health, every ANC registered with us gets 13,000 rupees during our pregnancy period and infant immunization. We thought there is a reduction of 6% after COVID relaxations has come. Right now, even though we have reached 58% in government facilities, right now it is only 52%. Probably we thought, let us incentivize, let us, I don't know whether I can say incentivize. We have started bribing. We have started bribing, giving this drug pouch to the hypertension and diabetes registered with us. So we said, the PMPs and quacks who are sitting at the government mein bacha de rahe, bag bhi de rahe, jaake le lo. Now, there were times when they used to say, sarkari medicine ne kaam nahi karega. Now they say that sarkari medicine acha kaam kar raha hai, le lo, because they are concentrating more on other diseases where they can mint money, but not in NCD. So we have clearly said that this is for the morning white, this brown is for afternoon, and black is for night. So our A&M refills every month after checking hypertension measurements. BP is measured, diabetes is blood sugar, RBS is measured, and then only they'll give. If it is in control, our A&M gives. And every 3 months, it is mandatory for the A&M or the for the beneficiary either to visit the PHC or the medical officer to reach the patient through outreach camp. So till last year, we got some incentive from Government of India at 4,000 rupees per month towards the mobility of the medical officer. So it is mandatory for every medical officer to reach the hypertension diabetes patient in his service area at least once in 3 months. So this is a pouch with good IEC. And this is the IEC displayed at our NCD clinics. We put up this board at all our NCD clinics. And we have started second round screening in November 2020, but unfortunately, spells of COVID has stopped our work. But so far, we have screened more than 50 lakhs. Entire data in Government of India application, Ayushman GOI NCD, 22 lakhs were rescreened. But in Telangana, we have, in the second round, which we started recently, we have screened about 50 lakh population so far. And this is our cancer care program, wherein level 3, level 4. One is level 4 is community screening, awareness, and palliative care. When it comes to palliative care, Telangana is the only state which is having one palliative care center at the secondary level hospitals, not palliative wing in the medical college. One palliative care center at the district or community health center, one per district with 6 to 10 beds. And all this staff recruited under NHM, one medical officer, 3 staff nurses, support staff and everything. And they are trained for 48 days, 28 days in pain relief and management. So only those who are trained, then only we include them. Telangana is the only state after Kerala having so many palliative care centers. But even in Kerala, I'm sorry, with due apologies, even in Kerala, they are the model for many things. In palliative care, many of the centers are in private, not in government. But Telangana is the only state having so many centers in government. Next, local diagnostic and daycare unit. We have started feeling that there are many cases which are coming to Hyderabad or going to nearby medical college place, wherein we are facing issues of follow-up chemotherapy. So we have identified 15 such districts where the huge caseload is there. We have sent 15 of our NCD staff nurses who are recruited for district NCD clinic to Tata Memorial Cancer Hospital, Mumbai for a 1-month training and follow-up chemotherapy. Now we are in the process, we are waiting for the Tata Memorial people to visit our facilities and finalize the service delivery. Hopefully, we are expecting to start this by first week of May. Then level 2 is dedicated unit annexed. So wherein radiotherapy, medical oncology, surgical oncology is taken care, and lab services are high end. Level 1 Apex hospitals, we have only one, that is MNJ Regional Institute of Oncology. Then this is our level 1, level 2, level 3 hospitals which we are planning to start in Telangana. And procurement of mammograms. That was another issue out of the court cases and everything. Now we have procured 33 mammograms and video colposcopes for 33 facilities, and procurement for another 60 is in process. So establishment of L2 Cancer Care Center, because we don't have an oncologist on board with our office. We are coordinating with the oncologists who are working at the tertiary care center and trying to do it. So far, we tried our best to call for request for proposals, finalization of cancers, but we are in the process. Probably in the last 6 months, no proposals have come. Recently, PwC and many other institutions have come, and we are hopeful of completing our level 2 cancer, establishment of our level 2 cancer care center at Khammam very soon. So in the treatment part, all these facilities are tagged to the nearby L3 centers. So this village health registry, that our joint secretaries are also talking about multiple entries, duplication of work and everything. So this village health registry is the basic profile of each and every individual of Telangana, right from 1 year to any age. So wherein one-time data entry is required. Any application, whether it is NICUST, whether it is NICSHI, whether it is RCH, whether it is any application, IHIP, any application, they can have data from this particular place instead of doing duplicate data entry. This data can be accessed. The application is in state data center, as we had issues with Government of India application. We have started our own application, Telangana specific NCD application, wherein all this data is available. And ASHA mobile app. So it's an offline application we have started. So initially everyone was thought, "Arey ASHA's mobile kya use karenge? Kahan karenge? It's mushkil hai." Out of 26,200 ASHAs who are working in Telangana, only 1,200 ASHAs are unable to do ASHA disease profile using a mobile now. Because thanks to Jio and other 3G, 4G, 5G revolutions and smartphones, even before we have given smartphone to the ASHAs, out of 26,200 ASHAs, 23,000 ASHAs were having smartphones already and they were using it. Because whenever they accompany a pregnant woman to the hospital, they used to post a photograph and mention something in their language or saying that I have accompanied, and they used to post it in the group. By seeing this, I said, "Ma'am, we can do it." Then we have started this ASHA disease profile, and so far, out of a targeted population of 3.7 crores, 2.6 lakh village health register entries have been completed in our application. And ASHA disease profile, we have revised our CBAC form. So this, what happens is, an ANM or ASHA is supposed to go to the field for multiple activities. One time she goes for NCD, one time she goes for NICUST, one time she goes for leprosy case detection campaign, one time she goes for the vitamin A campaign. There are many programs she is supposed to go. We said no. One simple sheet, we have revised our CBAC form, including all the diseases, whether it is, I'll show in the next slide. So ASHA disease profile is completed by our ASHAs only. All this questionnaire we have developed in Telugu, and application is also in Telugu. So 1.6 crore population. So during this risk, during this assessment, whoever is found risk and screened by ANM, we have started this pilot in 2 districts. I mean, electronic health profile, whatever MDHM, all are happening, but we started at a specific state level. So we collect, we draw blood, ANM will draw the blood sample from the suspected person and send it to the nearest hub. We have diagnostic hubs in what you call in government side, we don't hire any service to the outside. We have 20 diagnostic hubs wherein 57 tests are conducted for free of cost. And a message with the link is sent to the beneficiary as well as the concerned medical officer. So right now we are doing LFT, RFT, lipid profile, as well as HbA1c and all this CBP for the blood samples who are drawn there. So far in these two districts where we have piloted, 70,000 people have screened as on today who are found high risk. And 30% of Telangana population, probably on a higher side, they don't even know what is their blood group. So for entire population, we are going to do this e-health by taking their blood sample and giving them their blood group, and a digital health card will be given to them. So state government, we are using all this money from our state government money. So whatever we have projected in our NPCDCS, the state government has sanctioned rupees 100 crores recently for this activity. And Asha smartphone, we have not compromised on it. We have given 4 GB RAM and 64 GB memory phones to all our Ashas. I could not compress it. We also have all other programs, vector-borne disease control program. Whoever is assessed by ASHA, risk assessment is done by ASHA for so many people. We were really surprised to see 20 lakh people need more than palliative care. Running. So in the way forward, like we have 1,877 health wellness centers which are already functional, and we have trained all our PHC medical officers on management of health wellness centers. And probably Telangana is the only state which is having MBBS doctor at the health wellness center. So far, we have recruited 300 MBBS doctors, and we call him as Palle Davakhana doctor. Basti Davakhana is at a rural area, and we call him as village doctor, Palle Davakhana doctor. So far we have about 300 MBBS doctors who are working at health wellness centers, rural health wellness centers, manning a population of 5,000 to 6,000 rupees. And government of Telangana has taken a decision to give weightage for the people who are working at this health wellness centers, 30% weightage for the PG seats. So recently GO has been issued. So many of the MBBS doctors are interested in joining now. At least for 3 years, we'll have many MBBS doctors working at our office. And as I said, the drug dispensing from 52.8% to it has come down to 52%. We want to sustain the same and increase it because we have sufficiently invented. We have this time we have invented for 60% of drugs for the next 6 months. So we want to increase utilization and to sustain the BP control and follow-up rates. Recently, WHO has certified that Telangana has the good control rate, 73%. So we want to sustain the same. And many times what we are seeing is the people who are missing the follow-up. Even though we made it mandatory for the medical officer to go to him, the cases referred by the medical officer, uncontrolled hypertension and uncontrolled diabetes, are not going to the secondary facilities. So we have identified a supervisor from the PHC and we have designated him as NCD supervisor. He is the one who is responsible to transport and take the cases of uncontrolled hypertension, uncontrolled diabetes, as well as suspected cancer cases to the nearby NCD clinic. So NCD supervisor is responsible to take these people to the nearby hospital, and whatever money given by Government of India, 25,000 to the PHC and 5,000 for the subcenter, that money is being utilized by providing vehicles to the PHCs on a designated days. We have designated 2 days in a week, Tuesday and Friday for cancer related thing, and for general physician every day. The supervisors which come with the referred case and uncontrolled diabetes cases. And involvement of elected representatives. Usually elected representatives give us the targets, ye kyun nahi hua, wo kyun nahi hua. This time we said, you come and sit in your village, right from sarpanch to ward members and everything. We are going to give him the task. आपके गांव में इतने लोग हाइपरटेंशन डायबिटीज के हैं, आपके गांव में ये लोग इतने डिसीजेस के बारे में, एंड अगर ये लाइफस्टाइल आप चेंज करवाएंगे आपके लोगों से, we are going to give more incentive from health department, as well as we recommend more incentive for your panchayat from the finance ministry. So it is our responsibility. So we are making them responsible. We have started this pilot in 2 districts and which has given good results. So we are trying to do this right from sarpanch in the villages or ward member in the villages, MLS MP ko, we are going to utilize this platform of health melas. Under HWC, health melas are supposed to be conducted from 18th to 22nd April. And we want to involve all the elected representatives of the village to headquarter level into this activity so that they know what is happening. Health promotion, in spite of continuous efforts from the health department, we are not sufficient to do the health promotion or make lifestyle changes. They are the people, right persons, and only thing what we said is every 3 months we call the sarpanch who made a visible change to a head office, and we appreciate him with a certificate by the whoever minister he wants to get facilitated by. If he a minister he wants to get facilitated by a finance minister because he has some issues, we said ठीक है भाई, we'll make you to facilitated by finance minister, but आपके गांव में improvement दिखा. That's what we are trying, and it is successful in 2 districts. I mean, we have tried in very 20-25 villages initially, and we are in the process of upscaling it from in this health mela concept. This is what we have done so far, and we thank you very much for the patient hearing. And suggestions are welcome. We wanted to improve because, as I said, as I mentioned earlier, in spite of doing all this, we are at 10% hypertension registered with us. Of course, this time 5% diabetes registered with us. So still we need suggestions to improve our program in Telangana. Thank you.
Thank you, Mr. Reddy, for your presentation. Any
Thank you, sir.
questions?
Actually, the story was very inspiring, sir. And similar to Telangana, even the Union Territory of Puducherry has appointed doctors in all the 81 sub-centers since last 2 years. Sir, and I'm interested in one thing, sir. Sir, how did you deal with the quacks there? Because the quacks are a major problem in my field area. Like I know, to my knowledge, there are 6 to 7 quacks. And the one single drug, famous drug for hypertension they prescribe is Amlo 80 by Mankind, which cost 40 rupees per 15 tablets. And since they are available 24/7 in the village, so the people are almost, they believe and they are attracted to their services. So how to deal with this? It's a major challenge for us, and there is almost nil footfall for hypertension for procuring hypertension drugs. Like, can you please share your experience, sir?
So we tried because as you said, he's the one who is available in the village. So we have made our ashas responsible. I mean, it's not a punitive supervision, supportive supervision, saying that this is what happening in your village, in spite of having so much of medicines. And we also spoke to the concerned sarpanches. Unfortunately, in few areas, ward members and sarpanches are the RMPs for that particular village. So we tried all our sources, and now in 70-75% of the villages, the RMPs and quacks doesn't touch NCD.
Sir, I would like to share the actual situation. Even the husbands of the Ashas are running a clinic. And since the patients have to come to the Ashas to procure the drugs for TB, so they are deluded that they are the doctors providing local care. And nobody believes us, rather they believe them more. So
Agreed, sir. This is there, but it took us almost 2.5 years to come to this stage, sir. But somewhere you're supposed to start, definitely you'll get the results. Winning the public confidence is most important, sir. Yes.
I must congratulate you. I got the opportunity to work with Telangana Warangal as such, and I was really impressed by the health facilities. The PHCs had very few patients because most of the patients were actually getting medicines from the health and wellness center. They had a drug stock of 3 months, well labeled. Registers were very well followed up. Asha A&M referral system was amazing. Like every patient, the PHC staff nurse also knew, the PHC and CD staff nurse knew about the patient of the health wellness center, whether he's come for a follow-up next month or not. So it was amazing work which is being done, sir. And I believe you don't have CHOs at your health wellness centers, right?
No, we have only 30 of them, staff nurses. We have 585 Ayush medical officers and 300 MBBS doctors. and recent recruitment. Government has given order recently to recruit only MBBS doctors at this health wellness center. That is hampering our progress.
So your ANMs and ASHAs are also doing an amazing job. Like they're following up the patients regularly, maintaining registers and referral system, and the referral card itself is a very good system that you like being used and implemented, just not on papers. I must congratulate you as your whole team doing a great job.
Thank you. Thank you.
Have a break.
Online delegates, we are breaking for 5 minutes. Please connect to us after 5 minutes.